Uh, Ma'am, please start the session. We are live now.
Okay, thank you. Thank you so much. Am I audible?
Yes, ma'am, you are audible.
A very good morning to everybody present. On behalf of 45th ISP Conference Scientific Committee, I would like to extend a warm and hearty welcome to all the participants as well as the judges for today's session. To begin with, I would like to introduce the judges for today's session. Dr. Babita Pawar ma'am and Dr. Triveni Kai ma'am are the judges for today's session. Dr. Babita Pawar ma'am, who has an academic experience of more than 20 years, has mentored n number of students, UG and PG students. I have known her personally, along with Dr. Triveni Kai ma'am, who has an experience of more than a decade, who is currently working at MGV Dental College, will be judging for today's session. A very warm welcome and good morning to ma'am, both of you. I hope you like all the presentations today and have a good time.
Thank you, Anuradha, for your kind and loving words.
Thank you. Thank you so much. Good morning, Babita madam.
Good morning, ma'am. We can start with the presentations.
Yes, ma'am. Shalisa, we could just start with the presentations if it's all good. Participants, please note once the presentation is displayed on the screen, you have to start your presentation because you have slot of only 3 minutes, followed by question answers for the next 2 minutes. So please start your presentation. The delegate with BRPO 025, please start your presentation.
I suppose he's not there. Whoever it is.
No, he's just logged in, ma'am, but I don't know, he's not starting the presentation. BRPO 025, please start with your presentation. Unmute yourself.
Unmute.
Yes, ma'am. Good morning, ma'am. Am I audible?
Yes.
Okay, ma'am.
Yes, doctor. You are audible.
Yes, ma'am. Good morning. So I'll start, ma'am. So the topic of my study is like the comparative evaluation of coumarin and vispetin levels in saliva of the patients with chronic periodontitis and type 2 diabetes mellitus. So coming to the introduction, adipokines enhance the synthesis of pro-inflammatory cytokines, which play a role in extracellular matrix degradation. Adipokines are increased in the inflammatory process and are associated with periodontal destruction. So coumarin and vispetin, they play an important role in obesity-related disorders like the metabolic syndrome and insulin resistance. So the aim of the study is to determine the levels of coumarin and vispetin in healthy individuals and chronic periodontitis with type 2 diabetes patients. So the study included totally like 40 subjects, which were divided into 4 groups. That is the healthy individuals, that is group 1, chronic periodontitis without type 2 diabetes mellitus, that is group 2, and group 3, that is diabetes mellitus patients without chronic periodontitis patients, and group 4, that is chronic periodontitis and type 2 diabetes mellitus patients. And periodontal status was assessed, then FBS levels, fasting blood sugar levels, and HbA1c levels were assessed. Then so from the results, so the obtained results, like it showed that coumarin and vispetin, both levels were like high in group 4, that is chronic periodontitis and type 2 diabetes mellitus patient, when compared to like group 2 and group 1, 2, 3. Like in group 4, higher levels of coumarin and vispetin levels were seen, and then followed by group 2, that is chronic periodontitis without type 2 diabetes mellitus patients, then followed by group 3, that is type 2 diabetes mellitus patients without chronic periodontitis patients, and then followed by healthy individuals. So from study, like we can conclude like the higher levels of coumarin and vispetin were seen more in chronic periodontitis patients with type 2 diabetes mellitus than in the healthy individuals. And this coumarin levels, like it leads to the chemotaxis of monocytes and macrophages, which causes the irreversible tissue damage by increasing the MMP levels, and thus leads to the periodontal tissue breakdown. And this vispetin, it also has this action of this triggering PGE2 synthesis, and it also stimulates the interleukin 6, interleukin 1 beta, then TNF alpha, and so it has influence in the pathogenesis of immunity and inflammation. So from the study, like we can conclude that coumarin and vispetin, it plays a role in pathogenesis of chronic periodontitis and diabetes mellitus. So hence, this coumarin and vispetin, they are reliable markers for monitoring the progression of periodontal disease with diabetes mellitus.
Okay, doctor. So, which test did you use to assess?
Ma'am, ELISA, ma'am.
ELISA test you had done. You had done some staging of periodontitis?
Actually, ma'am, like staging, like I didn't do. Just like age criteria I took, and like CEP by assessing that periodontal status I have took, ma'am. Like staging I didn't include, ma'am.
Yeah, okay, good. So what was your result? Oh, there was statistical significant difference, did you see?
Yes, ma'am. Statistical significant like difference was there, ma'am. Like for coumarin and vispetin levels, like it was like more pronounced in group 4, ma'am. That is with CP and chronic periodontitis and type 2 diabetes mellitus patients, ma'am.
Okay, good. So next time you can assess after treatment, right?
Yes, ma'am.
Okay, yeah, thank you. Next presenter, please. Hello, yeah, Dr. Trivedi, would you like to ask?
Yes, ma'am. Which ELISA kit did you use?
Ma'am, bioassay ELISA kit, ma'am.
Bioassay, okay. And you have stated that the coumarin levels determine the chemotaxis of monocytes and macrophages. If you have mentioned it in your conclusion, did you carry out any specific test for that?
No, ma'am, not.
Why? If you are concluding it and if it is not a part of a study, the conclusion should not be there.
Okay, ma'am.
Yeah?
Yes, ma'am.
Okay.
Okay.
Ma'am, next case, Babita ma'am.
Yes. Yeah.
Hello, ma'am.
Presenter, please unmute yourself.
Hello, ma'am.
Yeah.
Can I start, ma'am?
Yes.
Good morning to one and all present here. Today we are going to present our poster on the topic determination of periodontitis as a risk factor for age-related macular degeneration, a cross-sectional study. Age-related macular degeneration is a type of maculopathy that results in irreversible visual impairment among the aged population. Macula is nothing but a membrane that is situated between the retinal pigmented epithelium and light-sensitive rods and cones of the eye. With time, there will be deposition of lipids within this membrane that will lead to change in diffusion characteristics of the membrane that will further result in degenerated epithelium. So in India, it is found to be one of the rarest disease among the Indian population. And traditionally, this disease can be classified into wet and dry forms of AMD, and of which dry form of AMD is the most common form, which can be further subclassified into early, moderate, and advanced form of AMD. Coming to the pathogenesis, factors like inflammation, smoking, age, light, photosensitizers will result in the production of oxidants, free radicals, reactive oxidant species that will lead to the oxidative damage within the tissue, which will further lead to reduced repair, reduced antioxidants, and accumulation of oxidative damage products within the tissue. And it is considered to be one of the common pathway for both the development of age-related macular degeneration and periodontitis. So aim of the present study was to analyze whether there is any association between periodontal disease and age-related macular degeneration. Materials and method. After obtaining ethical clearance from the ethical committee, a cross-sectional study was carried out among 50 AMD patients reporting to the Department of Ophthalmology, and informed consent was obtained from these patients, and patients were selected based on certain inclusion and exclusion criteria. Age between 40 to 65 years and systemically healthy individuals were included, and exclusion criteria was that age less than 40 years and greater than 65, patient with smoking characters, pregnant and lactating mothers, patient with genetic and autoimmune disorders were excluded. A detailed case history was recorded, and clinical examination was done, and clinical parameters like probing pocket depth, enamel bleeding index, and oral hygiene index were recorded. Statistical analysis was done using Spearman rank correlation test, and a p-value of less than 0.001 was found to be statistically highly significant. And in the present study, there was a positive correlation between age-related macular degeneration and periodontal disease, and age-related macular degeneration and probing pocket depth, which was found to be statistically highly significant. And coming to the result, out of the 50 AMD patients who were diagnosed, 29 patients were found to be having periodontal disease, and 21 patients were found to be clinically healthy with mild gingivitis. And with respect to the severity of AMD, moderate to advanced form of AMD was found among the periodontitis group, and early form of AMD was found among the healthy individual. Coming to the conclusion, further epidemiological and interventional studies with large sample size will be necessary to provide a better understanding of this association, and in future, periodontal health maintenance among these AMD patients may help in preventing the severity of age-related macular degeneration. Thank you.
Okay. Good. What about hypertensive patients? Did you categorize them? Like,
Yes, ma'am. I have to call this systemically healthy individuals, ma'am.
You excluded hypertensive patients.
Yes,
right?
ma'am. Yes, ma'am. Yes, ma'am.
Okay. Dr. Triveni?
Is there any difference in the age group of 40 years and 65 years in macular degeneration? Did you take the intragroup variation?
Ma'am, actually, age-related macular degeneration is a age-related disease, ma'am. That is commonly seen above 40 years of age, ma'am.
So a 40-year of person and a 65-year of person, did you find any difference in the macular degeneration?
The prevalence of AMD got increased with the age, ma'am.
Any specific test to check macular degeneration?
That has been done by a ophthalmologist, ma'am. They have their fundus examination, ma'am, which they have been doing.
You have not quoted in the post, no?
Yes,
That how did you check the macular degeneration?
Yes, ma'am. From a trained ophthalmologist, we got the diagnosis of the patient.
Yes, because your study is related to macular degeneration. How did you check the macular degeneration? You should have justified.
Yes, yes.
Okay. Thank you.
Thank you, ma'am.
Ma'am, can I start?
Yes, yes, please.
A very good morning to one and all present here. My poster presentation was titled Evaluation of Microbial Profile in Patients with Polycystic Ovary Syndrome and Periodontal Disease, a cross-sectional study. Polycystic Ovary Syndrome, otherwise known as PCOS, is a complex heterogeneous endocrine disorder which is most often seen in females during their reproductive age and is often tend to negatively affect various health systems. So patients with PCOS are more predisposed to conditions such as insulin resistance, obesity, dyslipidemia, cardiovascular diseases, all of which contribute to a chronic low-grade systemic inflammation. Meanwhile, periodontitis is considered as an immune inflammatory disease which affects the supporting tooth structure, which ultimately causes tissue destruction and tooth loss. So chronic low-grade inflammation is found to be an emerging plausible mechanism connecting PCOS with that of periodontitis. So the aim of the present study is to evaluate the levels of Porphyromonas gingivalis and F. nucleatum in patients with PCOS and periodontal diseases. Coming to the materials and methods, 30 patients were enrolled in the study who were aged between 20 to 40 years of age, and a complete periodontal examination was done using a UNC15 probe, and subgingival dental plaque samples were collected using a periodontal curette, and the samples were stored in EDTA buffer solution and was later sent for the quantification for F. nucleatum and P. gingivalis using RT-PCR. So coming to the results, amongst the intergroup comparison, the periodontal inflammatory surface area score and periodontal epithelial surface area score, they found to be a statistical significant difference between patients who were healthy with that of patients with PCOS and periodontitis. Coming to the microbial profiling, there was an increasing pattern of trend of, seen in patients who had PCOS with periodontitis pertaining to F. nucleatum. So coming to the discussion, our study, we were able to demonstrate the effect or the impact of PCOS on gingival inflammation as we could portray the increase in the inflammatory burden with PISA and PISA score. And whereas amongst the most prevalent periodontal pathogens, we had selected one key pathogen, that is Porphyromonas gingivalis, and the bridging organism Fusobacterium nucleatum, and of which we could find a statistical significant difference in the levels of F. nucleatum in patients with PCOS and periodontitis when compared to those of that in the healthy. Although changes in the Porphyromonas gingivalis levels were also seen, owing to the low sample size, we couldn't statistically bring out any significant results on it. And our study went in accordance with Alkali et al., who demonstrated the augmented effect of PCOS and salivary levels of P. gingivalis and F. nucleatum. So in conclusion, we could make out that PCOS may affect the composition of oral microflora, causing a repercussion in the periodontal health. So the future direction of the present study would be to analyze the dysbiotic microbiota in patients with PCOS and periodontitis over a large sample size. Thank you.
So which method of microbial assessment you had done?
Ma'am, we had done an RT-PCR. We had quantified the levels of Fusobacterium nucleatum and Porphyromonas gingivalis.
So,
Okay. How did you check the PCO levels, polycystic ovary? How did you select the sample?
Ma'am,
on what criteria?
Ma'am, based on according to the Rotterdam's criteria, we had selected the patients who were having PCOS. So those criteria had produced certain key features, and we also were checking for their levels, their hormone levels, and we also checked their diagnostic reports whether they were diagnosed with PCOS.
Did you exclude thyroid patients?
Yes, ma'am. None of the patients had any other systemic disorder. We were particular only with patients.
Yeah, you didn't include them.
Yes.
Thank you.
Okay.
Good morning, ma'am.
Good morning.
Can I begin my presentation, ma'am?
Yes, sure.
Good morning. So today I'm going to be presenting on the topic expression of trefoil factors 2 and 3 and adrenomedulin in unstimulated saliva of chronic periodontitis subjects with and without coronary heart disease. So basically these trefoil peptides are anti-inflammatory peptides which aid in epithelial restitution and healing, and adrenomedulin is a pro-inflammatory peptide which acts synergistically with the inflammatory cytokines. So the aim of my study was to assess the demographic variables, periodontal parameters, cardiac parameters, and also to determine the expression of these three biomarkers in unstimulated saliva samples of periodontally healthy subjects with coronary heart disease and generalized chronic periodontitis subjects with and without coronary heart disease. So totally 85 subjects were screened, and after careful inclusion and exclusion of the study population, 75 were included in the study. They were categorized into three groups as 25 patients in each group of chronic periodontitis, group 2 consisting of chronic periodontitis with coronary heart disease, and group 3 with just coronary heart disease. So for the demographic variables, periodontal parameters and cardiac parameters were assessed for all the study population, and unstimulated saliva samples were obtained for molecular analysis, and the molecular analysis is carried out using ELISA. So moving on to the results. So we found that the mean plaque index, the bleeding on probing, the probing pocket depth and clinical attachment levels were all higher in group 2 subjects, that is chronic periodontitis subjects with coronary heart disease. So now looking at the cardiac parameters again, the group 2 subjects, that is the patients with coronary heart disease along with chronic periodontitis, were found to have increased cardiac parameters. So the cardiac parameters we checked were the total cholesterol, HDL, LDL, and triglycerides. And now looking at the mean trefoil factor 2, trefoil factor 3, and adrenomedulin. Adrenomedulin was found to be the highest in all the three study populations. So the Pearson's correlation was also done, which showed significant correlation between plaque index, bleeding on probing, probing pocket depth, LDL levels, and total cholesterol. The trefoil 3 was significantly correlated with total cholesterol and LDL. Adrenomedulin was again significantly correlated with all of the periodontal parameters. So they give us a telescopic understanding on the expression of trefoil factors in adrenomedulin and periodontal disease. The expression of these biomarkers usually unveils a new paradigm link connecting periodontal disease as well as cardiovascular disease, as we all know that there's an established link. So according to previous studies by Charith et al. And Garg et al., our studies also demonstrated similar findings. So trefoil factor 2 and adrenomedulin values reached a statistically significant difference between the three groups. And on comparison of mean trefoil 2, trefoil 3, and adrenomedulin levels in all the three groups, so adrenomedulin levels were increased, validating its role as a pro-inflammatory biomarkers. So the conclusion of our study was that trefoil factors and adrenomedulin can be used as inflammatory biomarkers and putative risk indicators for periodontal as well as for cardiovascular diseases. Thank you.
Yes, ma'am. How did you estimate the unstimulated saliva or collection of unstimulated saliva was done?
Ma'am, we asked the patients to refrain from eating 1 or 2 hours before unstimulated saliva sample collection, ma'am. And once we were there to collect the samples, we just asked them to swish their mouth once with plain water and then expectorate the saliva which is available, ma'am.
This is unstimulated saliva, you see.
Yes, ma'am.
Okay. And is there any literature that supports the trefoil 2 and trefoil factors are involved in the pathogenesis? Any literature you have supported?
Ma'am, yes, ma'am. There was one article by Sucheta et al. In 2018, ma'am, which linked periodontal disease and diabetes, and they found trefoil factor 2 and 3 expression, ma'am. The pioneering study, the initial study was by Chirith et al. In 2012 and 2017, who proved that P. gingivalis has a action on trefoil factor 2 and 3 expression in saliva, ma'am. And there are various articles which also stated that the trefoil factors are expressed in the salivary glands, apart from in the periodontal tissues, ma'am.
Okay. Any periodontal study?
Ma'am, yes, ma'am. There's a study by Chirith et al. In 2016, ma'am, where they found that in patients with chronic periodontitis, the trefoil factor levels were decreased. They had taken gingival biopsies as their sample, ma'am, and they found that the trefoil factors were decreased during periodontal destruction. And after periodontal therapy, that is non-surgical periodontal therapy was done, then the trefoil factors value increased, ma'am.
What salivary analysis did you do?
Ma'am, I've done enzyme ELISA was carried out, ma'am, as a molecular analysis for our study.
ELISA. Which ELISA kit?
Ma'am, Abkine's ELISA kit, ma'am.
Okay.
Thank you, ma'am.
Yeah. Ma'am?
Yeah. Next presenter, please.
Ma'am?
Next presenter. Thank you.
Can I start, ma'am?
Yes. Yes, you can start.
Very good morning to one and all. Very good morning to one and all. So today's poster presentation topic is on the evaluation of comparative release of PDGF-AA from various forms of platelet-rich fibrin using two different centrifugation protocols. So to give a brief background, PRF or the platelet-rich fibrin is a second-generation platelet concentrate which was introduced by Joseph Chopra in the year 2001, which consists of a complex fibrin matrix of autogenous platelets and WBCs. So since its introduction, there have been different centrifugation protocols which have been developed based on the low-speed centrifugation concept developed by Ganati et al. In the year 2014, and these same set of authors have also reported that a lower centrifugal force can lead to better accumulation of growth factors, which is important for periodontal regeneration. So although a horizontal centrifuge has been widely used all over, most of the clinical studies which PRF have made use of the fixed angle centrifugation. However, there are few studies which have highlighted the role of horizontal centrifuge as well. One is by the Lorenco et al. In 2018 and another study by Miron et al. In 2019, both of which have reported that a horizontal centrifuge has a better ability to separate the cell types based on the density. So the various growth factors which have been said to release from PRF include platelet-derived growth factor, VEGF, TGF-beta, etc. And based on all these studies, there have been various general factors which have been determined, which determines the composition of PRF clots, which include the G-force or the RCF value, the rotor arm length, and the rotor angulation of the rotor arm. So the aim of the present study was to compare two different centrifugation protocols for platelet-rich fibrin preparation, and the objective was to analyze the variations in release profile of the growth factor PDGF-AA using the two different centrifugation protocols. So coming to the methodology, blood was drawn from 5 healthy volunteers and was subjected to centrifugation in both fixed angle and horizontal centrifugation using the protocols for LPRF and APRF, which was given. And the PRF clots which were obtained were suspended into culture media and the culture media with the PRF clots was placed into a shaking incubator at 37 degrees Celsius for release of growth factors into the media, as this is a protocol which was proposed by Kobayashi et al. In the year 2016, and the samples were collected at different time points, 15 minutes, 1 hour, 1 day, 3 day, and 10 day, and ELISA was carried out to analyze the release of PDGF-AA at the different time points. So the results, we observed that the release of PDGF-AA was higher in the clots that were obtained from the horizontal centrifuge when compared to the fixed angle centrifuge. So coming to discussion, PRF, as we know, is widely used in regenerative periodontal surgery, and the present study investigated the release of PDGF-AA from both the types of PRF obtained by a fixed angle and horizontal centrifuge. However, there was only statistical significance in the 1 hour time point, but the general trend showed that there was an increased release of PDGF-AA from the clots obtained from horizontal centrifuge when compared to that of a fixed angle centrifuge. So this could be probably because of the smaller sample size. So in order to conclude, we can say that a horizontal centrifuge can be used clinically, but however, future studies are required to clinically substantiate the use of horizontal centrifuge in clinical practice. Thank you.
Okay. Centrifugation you have used, horizontal and vertical both.
Yes, ma'am.
What is the difference in the rotation per minute?
Ma'am, we have used the protocol for LPRF and APRF in both the centrifuges, ma'am. So for LPRF, as proposed by Chopra protocol, we have used the G-force of 700 G-force, and for the horizontal centrifuge, we have used a G-force of 200.
Was this a cross-sectional study?
No, ma'am, it was an in vitro observational study.
How could you analyze that the centrifugation force at one time and after 30 days, the PRF that you have got any correlation?
Yes, ma'am.
How will you correlate these
Sorry,
results? How will you correlate these results?
Correlate in the sense because actually in the fixed angle centrifuge, because the cells are getting the cells are being adhered to the back walls of the tube, and whereas in a horizontal centrifuge we can say that the cells are being evenly distributed in the required layers, ma'am. So we can say that a horizontal centrifuge can be
One analysis we have done after 1 hour and simultaneously we have done after 30 days also. So 1 hour analysis and there will
no,
be
ma'am,
1 hour analysis and 30 days analysis.
Not 30 days, ma'am. 1 day, 3 day, and 10 days we have done now.
Yes. So yeah, 10 days, whatever the duration is for the 10 days. Yes. So don't you find any difference in this?
Yes, ma'am, there are differences, but it has been shown that in the earlier time points, the release is more. Whereas in the 10th day, there was only less release.
Babita ma'am?
Yeah, how did you analyze growth factors?
Ma'am, using ELISA kit, ma'am.
Yeah, same question, like which ELISA test?
Ma'am?
Which ELISA test?
Ma'am, the ELAB Science ELISA kit, ma'am, for PDGF-AA. Sandwich ELISA kit it was.
Okay, so what is more important, G-force or RPM?
Ma'am, RPM does not take into consideration the radius of the rotor, whereas the G-force takes into consideration the radius also, because all the centrifuges do not have the same rotor radius. So RCF is more standardized to follow.
Okay.
Okay.
Thank you.
Good morning, ma'am. Am I audible, ma'am?
Yes, yes.
Good morning. My study is evaluation of porosity of fibrin network, platelet and WBC entrapment in platelet-rich fibrin of diabetic and non-diabetic individuals. The use of platelet-rich fibrin has seen a wide and steady increase in regenerative periodontal therapy. And the components of a platelet-rich fibrin include the fibrin network, platelets, WBC, other inflammatory cells, and growth factors. The variations in the fibrin network may also affect the concentration, the cellular entrapment. So the aim of our study is to evaluate the porosity of fibrin network, platelet and WBC entrapment in PRF of diabetic and non-diabetic individuals. For this study, 69 blood samples were of 5 ml each were obtained from diabetic and non-diabetic individuals, diabetics who were diagnosed with type 1 or type 2 diabetes, and were subjected to centrifugation at 3000 RPM for 10 minutes, and PRF membranes were prepared, and with help of cell block cytology study, histological slides were prepared. Histological slides were stained with hematoxylin and eosin. The slides thus obtained were assessed using a Olympus trinocular research microscope, which is equipped with the digital software and program research software that helps in attaining photomicrographs. The photomicrographs obtained for analysis of porosity were taken at 40x magnification at the middle segment of PRF membrane of 5 representative areas. And the photomicrographs for analysis of cellular entrapment were taken at 20x magnification at the junction of RBC and PRF membrane.
the taken photomicrographs were analyzed for porosity and cellular entrapment using a software, ImageJ, which is an open source software for analysis of biological images. The JPR plugin for ImageJ software was used for analyzing porosity, and color deconvolution vector for ImageJ software is used for analysis of cellular entrapment. This study is first of its kind to quantitatively analyze the porosity and cellular entrapment in PRF. The results have showed that in diabetic individuals, the fibrin structure is less porous, more compact, with less cellular entrapment. Whereas in non-diabetic individuals, the fibrin structure was less compact, more porous, with increased cellular entrapment. Our study was in support with the studies done by Kubesh et al., Ganati et al., and Chowkran et al., who used low-speed centrifugation concept in order to obtain PRF plots. In the study, the authors reported that the PRF plots using this concept, low-speed centrifugation concept, have showed more porous, increased inflammatory cell entrapment. The reason given was the more porous structure allows more space for inflammatory cell entrapment. To conclude, our study showed minimally porous nature of fibrin network in diabetic individuals decreases cellular entrapment, which may negatively influence growth factor release. Thank you.
Doctor, you said you took type 1 and type 2 diabetic patient. Is it?
Yes, ma'am. Yes, ma'am. Most of them were of type 2 diabetes, ma'am. All of them are of type 2 diabetes, ma'am.
Okay, so what was your, did you compare between these two, type 1 and type 2?
No, ma'am. It was only between diabetic patients and non-diabetic patients, and all of them were of type 2 diabetic.
Because you mentioned, that's why I asked you. Yeah.
Yes,
right.
Yes.
Okay.
You have mentioned something regarding low speed centrifugation results in the difference in the porosity.
Yes,
any literature supporting the statement?
Yes, ma'am. Kubesh et al. Sir's literature, ma'am, regarding low speed centrifugation concept to obtain the advanced platelet rich fibrin, ma'am. And Ganati sir and Chowkran sir's article, ma'am, using low speed centrifugation concept, ma'am.
Okay. So the speed, if it is low, the porosity will be more.
Yes,
you mean to say.
Yes.
So what is its effect in the non-diabetic patient and a diabetic patient?
Using low speed centrifugation concept.
Yeah.
Yes, ma'am. In non-diabetic patients, it is more porous, ma'am, with increased inflammatory cell infiltration into the increased porous structure of the PRF, ma'am.
Okay.
So what is the reason you think that in diabetic patient it is more porous?
Yes, ma'am. Previous literature, medical literature has shown that there is variations in the glycemic controls may affect the porosity of fibrin network. And this is mainly due to abnormal concentrations of factor 13 in diabetic individuals that is seen, ma'am.
Okay.
Thank you, ma'am.
Thank you.
Good morning, ma'am.
Good morning.
Ma'am, am I audible and visible?
Yes.
Okay, ma'am. Shall I start, ma'am?
Yes, please.
Good morning. Wound healing occurs as a complex interplay between cells and signaling molecules. Even though when disinfection has been stringently followed, microbes infiltrate the underlying tissues, resulting in impaired wound healing. Therefore, the topic for my poster presentation is antimicrobial activity and time-dependent antibacterial effect of antibiotic or non-antibiotic incorporated platelet-rich fibrin and titanium platelet-rich fibrin on aggregative acto-actinomycetin competence and Porphyromonas gingivalis. The main aim of the present study is to assess the in vitro antimicrobial activity as well as the time-dependent antibacterial effect of PRF and TPRF incorporated with antibiotics, that is amoxicillin and metronidazole combination and clindamycin, or not incorporated with antibiotics, especially testing on the main periodontal pathogens, the aggregatibacter actinomycin contents and Porphyromonas gingivalis. The methodology is as follows. Like sterile paper cones were taken and they were placed in the pockets of chronic periodontitis patients to obtain the subgingival plaque samples. They were cultured initially in brain heart infusion broth, and later for the growth of the specific organisms, selective media was used, like the trypton soy besitracin and vancomycin media for the growth of A contents, and brucella blood agar plates were used for the growth of Porphyromonas gingivalis. Once these organisms were cultured, the platelet concentrates were also prepared. These were prepared by obtaining 12 ml of fresh blood, and it was divided into 6 tubes equally. Three to obtain PRF and the other 3 tubes to obtain TPRF. Into these, in some tubes, the antibiotics were added, amoxicillin and metronidazole, and to other tubes, the clindamycin was added. So the study groups now included are plain PRF and plain TPRF, PRF and TPRF with amoxicillin and metronidazole combination, and PRF and TPRF with clindamycin combination. Once the plated concentrates were prepared, the microorganisms which were initially cultured were streaked using the streak plate method onto the Muller-Hinton agar plates. And onto these sterile conditions, microwells were prepared, and all these 6 variables, the platelet concentrates, were added into them, and the antimicrobial activity and the time-dependent activity was observed for a period of 4 days. The results showed that the antibiotic activity was sustained throughout the 4-day period, but there was a statistical decline from day 1. And it also showed that either antibiotics were incorporated or non-incorporated, both showed PRF and TPRF, both showed antimicrobial activity on both the organisms. But when incorporated with the antibiotics, the PRF and TPRF showed a higher zone of inhibition and more antimicrobial activity rather than when antibiotics were not incorporated. Compared to all the variables, PRF clindamycin had showed a larger or highest inhibition zone compared to all other 6 variables on all the 4 days on both the bacteria. On day 1, the order of inhibition is as follows. PRF clindamycin greater than TPRF clindamycin, which is followed by TPRF amoxmetro, followed by PRF amoxmetro, followed by TPRF and then PRF on both P. gingivalis and A contents. Whereas on day 2, 3 and 4, all the other variables are similar, but with TPRF amoxmetro and PRF amoxmetro on Porphyromonas gingivalis, TPRF amoxmetro showed a higher activity and PRF amoxmetro showed higher activity on A contents. Therefore, to conclude, the antibiotics incorporated or non-incorporated, PRF and TPRF had antimicrobial activity on these pathogens. But incorporation of these antibiotics into PRF and TPRF is a novel approach for local drug delivery. Thank you.
Why did you choose clindamycin?
Ma'am, there were studies which showed that clindamycin had good activity on chronic periodontitis conditions, ma'am. Like whenever mechanical therapy and adjunctive antibiotic therapy was used, in recent times, clindamycin also showed that it had activity. So we wanted to test clindamycin with the commonly used amoxicillin and metronidazole, ma'am.
Any other antibiotic you could have assessed which has got better effect on A or P. gingivalis?
Yes, ma'am. We can use a doxycycline, tetracyclines. Vancomycin also we can use. There is a recent literature which is done with vancomycin incorporated with PRF also, ma'am. Amikacin and teicoplanin were also used, ma'am.
What about ciprofloxacin? Have you come across any studies?
Ciprofloxacin was also used, ma'am. There was a study by Wang et al, ma'am, 2016. Antibiotics, ma'am. These different antibiotics, but we tested with platelet-rich plasma, ma'am. On but not on P. gingivalis and A contents, ma'am. Staphylococcus aureus and other bacteria they have tested.
Okay, yeah, right. So, was it statistically significant with antibiotic impregnated and non-antibiotic? How much was the difference?
Ma'am, we have taken p-value as 0.01, ma'am, and it has shown that PRF clindamycin was highly significant when compared to the plain PRF and TPRF, ma'am.
Because
Yes, ma'am.
You have mentioned time dependent in your title. How do you justify that?
Ma'am, actually, we have observed for 4-day period, ma'am. The inhibition zones which were observed on day 1, they either in some samples they either retain as the same zone, or in some samples they have declined, ma'am. Comparatively, they have declined over the 3-4 days, ma'am. But the P. gingivalis A incompetence have not overgrown, ma'am. So the inhibition zones were sustained. So we thought, ma'am. But there was a study by Nafilde et al, ma'am. They have observed for a 7-day period, ma'am. And throughout the 7 days also, they had seen the antimicrobial activity, ma'am.
There are 15 days and 30-day studies also on
Yes,
this
ma'am.
literature. Yes, you should. Okay. And pocket depth selection you have not done?
For the initial samples, ma'am. Initial
Yes.
to collect subgingival plaque sample,
Yes,
ma'am.
yes.
Greater than 5 mm pockets were taken, ma'am, for the initial sterile points placement and collection of plaque samples to grow the bacteria.
Okay. Okay.
Thank you, ma'am.
Okay.
Hello.
Say start.
Hello. A very good morning to one and all. Coming to the title of my poster, it is Scanning Electron Microscope Study to Analyze
Sorry to
the
interrupt.
surface.
Please put on your camera.
Yes, ma'am. Ma'am, but I'm not able to put the ISP background.
It's
Is
okay,
it
but
fine?
put on your camera.
Yes, ma'am. Ma'am, am I visible?
Yeah, please
Yes,
continue.
yes.
Yes, ma'am. Good morning to one and all. The title of my poster is Scanning Electron Microscope Study to Analyze the Surface Roughness Caused by the Toothbrush Abrasion with the Application of Sodium Bicarbonate along with Hydrogen Peroxide and Milk-Derived Protein Casein. It is an in vitro study. So as we all know, that dental abrasion is one of the most common factor which is resulting in the tooth loss structure or the loss of the tooth surface. Now, sodium bicarbonate, it is used commonly as a polishing agent. It is having lower abrasivity and also antimicrobial properties. Now, when this is used along with hydrogen peroxide, it is a bleaching agent and it helps to remove the surface stains and also the other deposits and helps to reduce the surface roughness. The casein phosphopeptide, it is a bioactive agent with the milk-based products. Now, this is also it is also seen to have good potential in order to improve the mineralization of the decalcified tooth, as well as to lubricate the eroded and the abraded surfaces. Now, with this background, the aim of the study is to analyze the surface roughness, which is caused by the toothbrush abrasion with the application of sodium bicarbonate with hydrogen peroxide and the milk-derived protein casein. So the objectives were to analyze and evaluate the efficiency of these two agents individually. Now, coming to the methodology, in this, about 10 human extracted teeth were considered. Now, these were selected with no known history and no visible presence of caries or abrasion or tooth wear. And they were selected from the pool of extracted teeth. Now, from each extracted tooth, 2 specimens were taken by cutting them buccolingually, and so 20 specimens were derived from these 10 extracted teeth, and 2 groups were considered. Group 1, where the application of sodium bicarbonate along with 1.5% of hydrogen peroxide was done, and group 2, where there was application of this milk-derived protein casein. So the specimens were taken, and initially the specimens were brushed with the toothpaste slurry. Now, this was taken in the ratio of 1:3 of the toothpaste to the saline, and then about 60 strokes per minute were given for 10 to 15 seconds twice daily for a month. And after this, they were again stored in the saline until the remineralizing agents were applied. Now, after this, both the remineralizing agents were applied for about 5 minutes. After the initial 3 minutes, the excess of the paste was removed, and after that, after the complete 5 minutes, these specimens were removed where the toothpaste, the reagents were removed and they were cleaned up with the deionized water. Now, after this, the analysis was done under scanning electron microscope using a 3D confocal lens, and the estimation and analysis of the surface roughness was done. Now, this was carried out by using the paired t-test, where group 1 and group 2 were analyzed. And the results were seen that both the group 1, which had sodium bicarbonate along with hydrogen peroxide, and the group 2 milk-derived protein casein have shown statistically significant results in order to reduce the tooth surface roughness. However, better results were seen in group 2.
How did you categorize the roughness? Like, how did you score it?
Ma'am, to categorize, there is relative dentine abrasivity and relative enamel abrasivity, ma'am. And these specimens, they were kept under the scanning electron microscope, ma'am. So, ma'am, there is RA and RZ, ma'am. So these peaks of the surface roughness, ma'am, in the specimen. So the distance between these surfaces, the peak and the deepest value, it was calculated.
Any other scanning method better than this you could have used?
Ma'am, when compared to transmission electron microscope, this is said to be better, ma'am, because it has a focused beam, ma'am, and the electrons are directly focused, so it has the depth of focus is better in scanning electron microscope. And yes, ma'am.
So what about you studied this milk-derived protein casein, right?
Yes, ma'am.
Surface roughness. So is there any product available?
Yes, ma'am. We have one is tricaldent. We have, ma'am. Then we have this tooth mousse, ma'am. Again, in that 2 versions are there, ma'am. One is CPP ACP, ma'am. That is casein phosphopeptide with amorphous calcium phosphate, and one is CPP ACP with along with fluoride, additional fluoride component. Sorry, ma'am.
Yes, ma'am. You have done the application method as 5 minutes, 3 minutes. How did you standardize this application methods?
Ma'am, there was a study, ma'am, which was carried out by Arhari et al, ma'am, in the year 2017, and then Ranjitkar et al in the year 2011, ma'am. Now, what they have done, ma'am, they have analyzed in the study by Arhari et al, they have analyzed in the surface roughness along with erosion, ma'am. So they have considered the 5 minutes standardized time, ma'am, out of which first 3 minutes, first the paste was applied, and after first initial 3 minutes, the excess of the paste was removed, and then after 5 minutes, it was washed with the deionized water, ma'am. So the previous studies, ma'am, in the literature, they have tried to consider this tooth wear. Hello?
Yes.
They have tried to consider tooth wear, color, and micro hardness of enamel, ma'am. But with this combination of sodium bicarbonate along with 1.5% of hydrogen peroxide to evaluate the surface roughness has not yet been done.
Yes. And as ma'am said, any other method of scan electron microscope better than this?
Ma'am, that I don't know, ma'am. There's one, they basically told, ma'am, for surface roughness, actually there are 2 types we can check, ma'am. One is contact type and one is non-contact type, ma'am. So there's a standardized probe, ma'am, which they come in contact with the surface to trace the micro irregularities, ma'am. Other one is non-contact type laser-based beam, ma'am. So with that also, they can check the micro irregularities, ma'am.
So that is a newer method. This is the older method, no? Yes. How many scans did you take? How many sections for ACM?
Ma'am, for each two sections we have taken, ma'am.
2 sections. Okay.
Yes. Thank you, ma'am.
Okay. Thank you.
Thank you.
Good morning, ma'am. Hello. Ma'am, am I audible?
Yes.
Hello.
Yes, you're audible. Please put on your video.
Hello.
Yes. Start.
Hello.
Yes, you're audible. Please start, but please put on your video.
Hello.
Kindly unmute.
Hello, BRPO033. You are completely audible. Kindly please start your presentation and put on your video.
Hello. Hello, ma'am. Hello. Hello, ma'am. Am I audible? Hello.
Speak. We can hear you.
Yes, ma'am.
Please put on your video and start your presentation.
Yes, ma'am. Hello. Good morning, everyone. The poster I'm presenting is on comparison of use of diode laser and toothpaste containing strontium chloride in dentinal tubule occlusion, scanning electron microscopic study. So dentin hypersensitivity is an abnormal response of exposed vital dentin to thermal, chemical, or tactile stimuli. The prevalence of dentin hypersensitivity has been reported ranging from 4 to 57% in many studies. The most common factors involved in dentin hypersensitivity are abrasion, which is caused by inadequate intensity toothbrushing, abstraction, which is caused by tooth flexion due to abnormal occlusal forces, parafunctional habits, or occlusal disequilibrium, erosion, or secondary to the presence of acids in the oral cavity, as in bulimia nervosa or gastroesophageal reflex, anatomic predisposition due to structural deficiency of enamel cemental junction, cavity preparations in the vital teeth that expose dentin, or badly controlled dentin acid conditioning. So with this, coming to the aim of the study, it was the study was carried to assess the effect of strontium chloride containing toothpaste and 810 nanometer diode laser for treatment of dentin hypersensitivity by evaluating the dentinal tubule occlusion before and after treatment in extracted human teeth using scanning electron microscopy. 10 caries-free teeth were single-rooted teeth were sectioned below the cemento-enamel junction, and one was and that one teeth was considered healthy. That means it was untreated. 3 teeth was treated with laser, 8 nanometer diode laser. Then 3 teeth were treated with 10% strontium chloride toothpaste, and 3 were used with both a combined strontium chloride and laser, and it was treated for about 60 seconds. And the section treated teeth was analyzed using scanning electron microscopy, and the photographs were taken. And it was seen that the use of diode laser along with the toothpaste was able to achieve better occlusion compared to laser alone and the toothpaste alone. So it was concluded that the combination of diode laser along with the 10% strontium chloride toothpaste will help in clinical treatment of the dentinal hypersensitivity.
Which mode you use this laser?
Ma'am, non-contact mode, ma'am.
Use it non-contact mode. Why?
Yes.
Why strontium chloride you selected?
Ma'am, there was one study by Gupta et al. Ma'am in 2019. They have seen that inclusion of 10% strontium chloride toothpaste was effective in treatment of dentinal tubule occlusion, ma'am.
So the study is already done, no? There are n number of literature on strontium chloride. What different you have done in the study?
Ma'am, I've combined laser and strontium chloride toothpaste, ma'am.
That is already been done. That's what. What you could have added?
Yes. Any more additions or comparison with any other material you could have done? You're getting the question?
Yes, ma'am. Yes, ma'am.
Yes. The thing that you have done, materials and method, you have used a diode laser. Yes. Using laser, the
Yes,
already studies have done. Okay, the literature supports these studies. Any other addition you could have done in the study?
Ma'am, I could have checked for the acid resistance also, ma'am.
Yes. That could be one of the criteria to be verified, no?
Yes.
And on what basis did you make the sample size selection? Sample size selection was done on what basis?
Ma'am, it like a pilot study, ma'am, I have done, ma'am.
How did you select the samples? You have selected the tooth, extracted tooth.
Yes, ma'am, based on the other studies, previous studies also, ma'am.
It is an in vitro study.
Yes, ma'am.
So you have selected the extracted tooth, already extracted tooth, or abraded teeth?
Already extracted ones, ma'am. Non-caries extracted teeth. Non-caries extracted teeth was collected, ma'am.
Okay. Babita ma'am?
Yes, sir, no problem.
Okay.
Next present.
Good morning, ma'am.
Good morning.
Good morning, ma'am.
Good morning.
Yeah.
Yes,
The topic of my today's presentation is on evaluation of the cytogenic damage in diabetic and non-diabetic individuals with periodontitis by DNA laddering, ma'am. Coming to intro, as we know, inflammatory conditions show cytogenic damage in a peripheral blood leukocyte, and this can be assessed using various tests. This cytogenic damage is a marker of the periodontal disease. So DNA laddering is a sensitive assay that evaluates the cytogenic damage that can be visualized as the ladder pattern. The aim of this present study was to investigate the cytogenic damage in a diabetic and non-diabetic individual with periodontitis in comparison with the healthy control. This study was a cross-sectional in design comprising of 45 patients who attended the outpatient department of perio. I have allotted 3 groups. In group A, 15 patients with chronic generalized periodontitis. In group 2, 15 patients with the chronic generalized periodontitis with diabetes mellitus, and in group 3 as a control I have put 15 healthy patients. After recruitment in this study, the study patients were subjected to detailed for their general clinical and clinical examination, and relevant parameters were recorded. The clinical parameters were PPD, CAL, modified gingival index, and the plaque index. Later, I have taken the blood collection from the skin over the antecubital fossa and disinfect with the 5 ml. Then I have taken 5 ml blood collected in all the 3 groups. Then we centrifuge at 3000 RPM for 5 minutes to separate the white buffy coat that consists of leukocyte. The final isolated DNA was run on 2% agar gel for the electrophoresis to visualize the DNA fragmentation. The grading of the DNA fragmentation as the mild, moderate, and the severe. In mild, the degree of location of the band was nearer to the well or upper third of the DNA sample was loaded. In moderate, the location of the band was in the middle third, and in severe, the degree of location of the band was away from the well, which is on the lower third area. Coming to the result, we have taken 45 subjects with 26 male and 19 females with a mean age of 48 years. The mean PPD plaque index were significantly higher in the CGP and the CGP with diabetic group and comparative to the control. The apoptic DNA fragmentation was observed as a ladder pattern in both the CGP and CGP with diabetic group, and the gradation was moderate as the location of the band was in the middle third and the midway between the well where the DNA sample was loaded at the end of the gel. In this study, we observed that the DNA fragmentation was observed in both the CGP and the CGP with diabetic group, which is suggestive of cytogenic damage, as a DNA laddering was observed as a ladder pattern in the middle and lower third of the wells in both the CGP and diabetic group. But we found the absence of fragmentation in the healthy control. So we concluded that within the limitation of the study, chronic generalized periodontitis patient with diabetes and chronic generalized periodontitis without diabetes have shown the statistically greater tissue damage when compared to the healthy patients.
How did you score this DNA laddering?
Ma'am, we scored it as a grading pattern, ma'am, mild, moderate, severe. In the mild, the ladder pattern was in the above, ma'am, above level. In the moderate and severe, the layers of the laddering pattern was in the lower third and lower third, ma'am. Middle
That's
third.
what I'm asking. How did you
It is
score it?
already established in the previous articles, ma'am. This laddering score. 1/3, 2/3, and lower third, ma'am, middle.
Okay.
And in healthy, there is no fragmentation seen, ma'am.
No fragmentation. Healthy means how did you assess healthy gingiva?
We taken as a CGG patients, ma'am, chronic generalized gingivitis patient, where there is no cytotoxic inflammatory condition things are there.
So gingivitis, can you call it healthy?
Healthy.
But
You're saying it to be healthy.
Yes, ma'am.
Huh?
Comparative analysis should be less, no, ma'am. Like in diabetic, there is a lot of cytogenic damage. In CGP also, there is more destruction. So.
Okay, so you took mild gingivitis. Did you grade that? No. Relative, okay.
Why didn't you take a control group? That is what madam is saying. Why didn't you take a control group?
Some patients were relatives, ma'am, like the patient who came with other patients.
That is not a control group.
Should have taken
pristine patients found to be really.
Why did you select diabetic and non-diabetic patients?
In diabetic, there is a more cytogenic damage, no, ma'am. So I have collected that patients, and in CGP, there is less cytotoxicity. So that. And this DNA laddering is simple, easy, and cost effective. That's why I have taken this test to check comparative to other tests.
Okay.
Okay. Thank you.
Good morning, ma'am. Am I audible, ma'am?
Yes, you are audible.
Okay. Good morning, everyone. Today, my poster presentation topic is on comparative evaluation of platelet count and fibrin network between LPRF and TPRF. As we know, there's autologous platelet concentrates, that is platelet-rich fibrin, with main source of fibrin network and platelets, which act as a storehouses of growth factors, have shown promising results in periodontal regeneration. Through time, various generations of platelet concentrates have evolved, but there is a very scant literature comparing their internal structures and properties. So we have made an attempt to qualitatively compare this TPRF and LPRF. So we have taken 10 ml of blood from healthy volunteers, and 5 ml of blood has been transferred to the glass tubes and centrifuged at 2700 RPM for 12 minutes to obtain the LPRF clots, and other 5 ml of blood was transferred to the titanium tubes and has been centrifuged at 2800 RPM for 12 minutes to obtain this TPRF clot. And half of each clots, they were processed for the scanning electronic microscopic analysis to evaluate the fibrin network, and half of other clots have been used to study with the help of light microscopic analysis to evaluate the distribution of the platelets and other cells. So in scanning electron microscopic, in analysis, we have seen that the cells are densely packed in TPRF when compared to the LPRF, where we can see that the cells are, when compared to TPRF, the cells are a little bit loosely packed. And in coming to the analysis of the fibrin network, in TPRF, we can see that there is a dense sheet-like fibrin meshwork when compared to the LPRF, where we can see that there is a loose fibrin meshwork when compared to this TPRF. Then coming to the light microscopic analysis, this is at the low magnification, that is at 10x, and this is at high magnification at 40x, where we can see in TPRF, there is a more number of leukocytes and platelets when compared to the LPRF. So coming to the results, the TPRF samples, they seem to have a highly organized and thicker fibrin network with continuous integrity than LPRF samples. And the platelets and the leukocytes, they are densely packed in TPRF when compared to LPRF. So coming to the conclusion, with the limitations of the present in vitro study, TPRF with thicker fibrin network and densely packed cells might enhance wound healing by reducing the growth factors in a drop-by-drop manner over a long period of time. Thank you, ma'am.
What was the purpose of taking both these two analyses, light microscopic analysis and scanning electron microscopy analysis?
Ma'am, we want to evaluate both the fibrin network, and also the distribution of the cells, ma'am, because in scanning electronic microscope, we could only see the, how the cells are packed, but we couldn't have a proper analysis of leukocytes and platelets differentiation, ma'am. While in light microscopic analysis, we could say that the cells which had a staining with this blue, that is the nuclei of the leukocytes are stained with blue, ma'am, and the background with pink dot-like cells are the platelets, ma'am. So we wanted to see the differentiation. So we had done both the analysis, ma'am.
Any in vivo studies done?
Ma'am, comparatively, in intrabony defects and intrabony defects, they have done, ma'am. Chatterjee et al. He has done in intrabony defects, but they haven't seen any significant difference in both the groups, ma'am.
Did you carry out a pilot on in vivo studies?
Ma'am? Yes, ma'am. They have. Even in recessions also, a few studies have been done, ma'am, using this TPRF, that is by Manvi Chandra et al. And Tunelli, Anirban Chatterjee sir has also done many studies, ma'am, in recessions. But many of the studies are not showing much significant difference between both, ma'am. But after doing the study, I feel that maybe because ease of handling is better in TPRF, and also the number of cells are better. So maybe the result can be a little better, ma'am.
Yeah. So what is the limitation of your study?
Now even the low speed identification concept, so like APRF plus IPRF and all, also I should have compared, ma'am.
Yes.
Thank you.
Yeah, thank you.
Thank you, ma'am.
Good morning, ma'am.
Good morning.
Ma'am, can I start the presentation?
Yes.
Good morning, everyone. Today's my topic of presentation is estimation of NLRP3 inflammasome levels in gingival clavicular fluid of healthy patient, gingivitis patient, and chronic periodontitis patient. Coming to chronic periodontitis is an infectious and inflammatory disease leading to characterization of destruction of periodontal tooth structure, and will lead to stimulus of post-immune response, that is innate inflammatory response is activation, leading to creation of inflammasome. So the NLRP3 is an inflammasome leads to caspase-1 dependent release of pro-inflammatory cytokine, that is interleukin 1 beta and interleukin 18, so which are the primary marker for the tissue destruction in periodontal disease. So I am checking the levels of NLRP3 levels in GCF of healthy patients and chronic periodontitis and gingivitis patients. In these patients where 30 patients were selected, and they divided into 3 groups, that is group 1 10 patients were healthy patients, and group 2 10 patients were gingivitis patient, and group 3 it is 10 patients with periodontitis patients. And after that GCF sample was collected from the 3 patients, and baseline modified gingival index, plaque index were taken for these three group patients, and probing pocket depth and clinical attachment level was taken for the periodontitis group. And after that values of GCF NLRP3 inflammasome level were estimated by using ELISA kit. Coming to the results, this NLRP3 inflammasome levels were mean concentration were increase in periodontitis group compared to gingivitis and healthy group. And coming to this modified gingival index and plaque index were very high in periodontitis group compared to that of gingivitis and healthy patients. So concentration of NLRP3 inflammasome were seen, levels were seen high in periodontitis patient were significantly high when compared to that of gingivitis group and healthy group. So coming to conclusion, it is concluded that there is increased NLRP3 inflammasome levels were found in periodontitis patient when compared to that of gingivitis patient and healthy patient. So this NLRP3 inflammasome level, it acts as a potential biomarker for periodontal disease.
did you collect GCF?
Ma'am, using micropipette, ma'am.
Using micropipette. Okay. Any special device you use?
Ma'am, ELISA kit, ma'am.
For GCF collection.
Periotron, ma'am.
We use Periotron. So,
then why did you select ELISA?
For checking the levels of inflammasome level, ma'am.
You have checked two groups, gingivitis, periodontitis.
Gingivitis, healthy patients, ma'am. 3 groups, ma'am.
3 groups you have checked. So naturally there will be difference in the inflammation between a gingivitis patient and a periodontitis patient. So
Yes,
don't you think that the inflammatory marker that you're checking will definitely have different levels in gingivitis and periodontitis?
Ma'am, there are less number of studies checking this 3 groups, ma'am. That's why I selected, ma'am. And also many studies checked that the serum level, ma'am. They have taken blood serum and they have checked this inflammasome level, ma'am. There are only less number of studies check this level in GCF sample, ma'am. So,
but how did you estimate these levels in GCF? By ELISA.
ELISA kit, ma'am.
What was the scoring criteria?
20 nanograms, ma'am.
20. What is the normal level?
Normal have they given 1 to 25 nanograms per ml, ma'am.
Babita, ma'am?
it's okay, fine.
Thank you.
Good morning, ma'am.
Good morning.
Start.
Shall I start, ma'am?
Yes.
Yes.
Good morning, everyone. Today I am going to present my poster on topic of comparative evaluation of antimicrobial efficacy of calcium hypochlorite, erythritol and povidone iodine solutions in vitro study. Erythritol, it is a non-toxic, chemically neutral and highly water-soluble polyol. It is widely used as an artificial sweetener and as food additive. And it also has a slightly slower abrasiveness and than glycine due to its smaller particle size. And so it is suitable for subgingival plaque subgingival biofilm removal. And whereas calcium hypochlorite, it has antimicrobial efficacy, which affects the cytoplasmic membrane integrity, enzymatic action, and cellular metabolism of microorganisms. And povidone iodine has already been proven as an antiseptic. So this study was aimed to evaluate the comparative antimicrobial efficacy of calcium hypochlorite and erythritol and povidone iodine solutions against subgingival biofilm in periodontitis. Coming to methodology, subgingival plaque samples have been collected from periodontitis patients, and they have been transported in brain heart infusion broth, and later they have been centrifuged, and that centrifuged plaque mass was streak cultured onto blood agar plates, and later they were cultured in gas pack anaerobic culture media, and they were incubated for 2 years for their culture. And the later the anti-anaerobic organisms have been grown on the culture media, and they have evaluated after 2 days. And later the sample was inoculated onto a fresh chocolate agar plate, and erythritol, calcium hypochlorite, and povidone iodine solutions were prepared. Erythritol preparations were, two erythritol preparations were done, that is 3.2 and 6.4%, and 2.5 and 5% calcium hypochlorite solutions were prepared, and 5% weight by volume povidone iodine has been used, and these 5 solutions have been used. Paper discs were immersed in these solutions, and they were placed onto the stab cultured chocolate agar plate, and they were again placed in anaerobic culture media along with gas pack. And after 2 days of incubation, again zone of inhibition was noticed on the chocolate agar plates. Coming to the results, the average zone of inhibition was higher for group 3, that is 2.5% of 2.5% calcium hypochlorite and povidone iodine, whereas comparatively erythritol have shown less antimicrobial efficacy than povidone iodine and calcium hypochlorite. And coming to the conclusion, availability of more chlorine in calcium hypochlorite solution predicts promising antimicrobial activity of this of the product, and it can provide a new insight into therapeutic strategies for management of periodontitis. Thank you.
Okay, how sensitive is this test? Blood agar. You chosen blood agar plate, right?
Yes, ma'am.
Yeah.
Blood agar and chocolate agar.
Any other tests you could have carried out?
For culture.
What was your conclusion? What was your
Yes.
conclusion?
What is your conclusion?
Calcium hypochlorite have similar results, similar antimicrobial efficacy as povidone iodine, but erythritol has lesser efficacy than calcium hypochlorite and povidone iodine.
So among 3, calcium hypochlorite had better efficacy. That is your conclusion, right?
Yes, ma'am. 2.5% of calcium hypochlorite and povidone iodine have similar effects.
Povidone iodine at what concentrate you are taking? Concentration?
5% weight by volume, ma'am.
Okay. And
What about the rest two materials that you have verified? What was the concentration?
Erythritol, ma'am.
Yes.
3.4 and 6.4. 3.6 and 6.4%. 3.2 and 6.4%.
3.2 and
6.4%.
So you have estimated 2 concentrations of erythritol. And
Yes,
what about calcium?
Calcium hypochlorite 2.5 and 5%.
So two concentrations of each and 1 concentration of povidone iodine.
Yes, ma'am.
Okay.
I have taken povidone iodine as control group, ma'am.
Yes, it is a control group, but you have taken 2 variations in erythritol also and calcium hypochlorite also. Why?
At which concentration amount of zone of inhibition.
So you should have taken only one ingredient as a test, and you could have controlled it with the other one, no?
Easier.
It would have been easier by taking 2 concentration of 1 ingredient. This will give you a biased result for the study, no?
Okay.
Okay.
Thank you.
Good morning, ma'am.
Good morning.
Ma'am, shall I start the presentation?
Yes, please.
Good morning, everyone. Today, my poster presentation is under the topic named Comparative Evaluation of Antimicrobial Efficacy and Quantitative Evaluation of Insulin-like Growth Factor 1 in Advanced Platelet-Rich Plasma Fibrin Plus and concentrated growth factors, an in vitro study. Coming to background, according to Wolfberg, blood is termed as a very special juice. Owing to these statements, the evolution of platelet concentrates in the periodontal regeneration have made a very pivotal role in periodontal regenerations through various amounts of platelet concentrates coming to first till third generation concentrates. Currently, their antimicrobial efficacy is being least explored. Owing to this statement, we have made an attempt to evaluate the antimicrobial efficacy. The main criteria to select E. coli and S. aureus is because of an study done by Castro et al. In 2019, where he have claimed that during the process of wound healing, E. coli and S. aureus have harbored to be a main source of microorganisms for infection during infection for periodontal regeneration. The aim of this study is to the primary aim of this study is to find the antimicrobial activity of APRF plus and concentrated growth factors against the microorganisms S. aureus and E. coli. And the secondary aim of this study was to evaluate, quantify insulin-like growth factors against APRF plus and concentrated growth factors. Coming to materials and methodology, 10 healthy volunteers were recruited, out of which 5 were male and female, and they were done through anticubital vein. 10 ml of intravenous sample have been collected, of which 5 ml have been done for APRF plus and concentrated growth factor of the same individual through the centrifugation. According to Kobayashi protocol, APRF plus and Sacco et al. 2006 protocol. In APRF plus protocol, it is 1500 RPM for 8 minutes, whereas in Sacco et al., the concentrated growth factor was named in such a way that 30 seconds acceleration followed by 2700 RPM for 2 minutes and 2400 RPM for 4 minutes, 2700 RPM again for 4 minutes and 3000 RPM for 3 minutes, and during 36 seconds for deceleration. This was done in a specialized centrifuge called NEA centrifuge, which is digital, so that we can standardize the RPM. And later the other half of the membrane have been done for quantification through the ELISA kit called AppCan, which have been done through Sandwich ELISA. And after obtaining this APRF plus and concentrated growth factors, this membrane have been placed into this sterilized nutrient broth agar plate, which have been cultured already of Staph aureus and E. coli, and have been incubated at 37 degrees for 1 day. And the control we have used is that ciprofloxacin 5 micrograms. We have evaluated various antibiotics, of which amoxicillin, ciprofloxacin, gentamicin, norfloxacin have shown antibiotic sensitivity to both S. aureus and E. coli, of which amoxicillin have shown 50% resistance. Owing to its resistance capacity, we have choose ciprofloxacin 5 micrograms as a control, and we have done for inoculation. And coming to the results, surprisingly, both APRF and concentrated growth factors have shown inhibition ring in both S. aureus and E. coli. Compared to S. aureus, E. coli have shown major inhibitory concentration in both APRF plus concentrated growth factors. However, the results claimed that through Mann-Whitney test, it was claimed that there was no statistically significant results have been found between APRF and concentrated growth factors compared to control. And coming to the secondary aim, that is ELISA, these have been the results have been done in nanograms per deciliter. Even the concentrated growth factors have shown more amount of insulin-like growth factors compared to APRF plus. However, it has shown no statistically significant difference between the two groups. Coming to the discussion, there have been done very few studies with regards to both antimicrobial efficacy and growth factors. One such study is Castro et al. In 2019, where he have evaluated LPRF exudate, where he claimed that even LPRF exudate have claimed a potential antimicrobial efficacy of mainly anaerobic bacteria like P. gingivalis and A. comitans, and another study by Feng et al. In 2020, which is a very recent study where he have evaluated using two methods, that is horizontal centrifugation and vertical centrifugation, where he have claimed that horizontal centrifugation have shown better antimicrobial efficacy compared to the vertical routine centrifugation method. And these results, my present study have shown that no statistically significant result have been found in relation to either antimicrobial efficacy of between concentrated growth factors and APRF plus in both SRAs and E. coli. The same with insulin-like growth factor, it haven't shown any such greater statistically significant results between the both concentrates. So conclusion, within the limitations of the study, autologous platelet concentrates, despite the generation, because concentrated growth factor is a second generation and advanced platelet-rich fibrin plus is a third generation, despite in the differences in the autologous platelet concentrates generation, it has proven that it will show an antimicrobial efficacy against various plethora of microorganisms in periodontal regeneration.
Doctor, why did you choose Streptococcus aureus and E. coli?
Ma'am, a recent study by Castro et al. In 2019, where they have claimed that S. aureus, E. coli, and Klebsiella are the pioneer microorganisms which have shown to prove potential damage while periodontal regeneration in both periodontitis patients and peri-implantitis patients, ma'am. And owing to its cultural properties, though the main putative microorganisms for periodontitis is P. gingivalis and the A. comitans, considering as these microorganisms are easy to replicate, so I found this would be an easy and without any less contamination. I have chosen this S. aureus and E. coli compared to P. gingivalis and A. comitans.
Yes, that is the reason. What are the limitations of your study?
First limitation is, ma'am, I haven't quantified my platelet concentrates. That would be the major flaw. And the second concentration is definitely the sample size, ma'am.
You have carried out everything, but no quantification is only not done.
Yes,
and you have mentioned it in your title also.
Ma'am, the quantification, I have quantified the insulin-like growth factor through ELISA, but my main limitation was I haven't quantified with regards to this growth factor in
growth factors. Yes, that you have not done.
Yes, ma'am.
And centrifugation at different levels, why have you carried out?
Ma'am, according to Sacco et al. In 2006, he gave the protocol of various, he had given at various levels. When we follow these various levels, the concentrated growth factors will be obtained at the maximum compared to the other various centrifugation methods.
Okay. Ma'am?
Yeah, next presenter, please.
Please start. You can start.
Presenter is not in this session, ma'am, I guess.
Ma'am, now she is here.
Good morning, ma'am.
Okay.
Yes, ma'am. Ma'am, sorry for the inconvenience. There was some network issue, ma'am. Can I start, ma'am?
Yes.
Good morning, everyone. I am here to present my poster on serum 25-hydroxy vitamin D in chronic periodontitis patients with type 2 diabetes, a socio-economic and clinico-biochemical study in Chhattisgarh. As we all know, periodontitis is a multifactorial disease, and the bidirectional link of periodontitis is with diabetes mellitus has been clearly established. Now we propose that vitamin D deficiency may play a role both in periodontal disease and diabetes mellitus. So the objective of my study was to estimate the levels of serum 25-hydroxy vitamin D in chronic periodontitis patients with type 2 diabetes as compared to chronic periodontitis and healthy controls, and to study the correlation between socioeconomic variables and serum vitamin D. The study subjects were included based on the inclusion criteria, that is 30 to 60 years of age. At least 20 teeth should be there, 30% of periodontal sites with probing depth of more than or equal to 4 millimeter, 20% periodontal sites with interproximal clinical attachment loss more than 2 mm, and diabetes mellitus criteria 2018. Any patients having systemic diseases like cardiovascular, renal diseases, bone diseases, malignancies, history of smoking, pregnant, lactating, menopausal women were all excluded, and a total of 105 patients divided into 3 groups, that is periodontitis and with diabetes mellitus, and a control group, each with 35 patients each were included. Patients were first assessed with the socioeconomic and demographic variables were assessed using a questionnaire. Clinical examination was done, and then biochemical analysis, which includes vitamin D and HbA1c levels, was done, and finally the statistical analysis was done. The results showed that the vitamin D levels were inversely correlated with HbA1c level and also with the clinical parameters, that is OHIS, gingival index, probing pocket depth, and clinical attachment levels. And the level was shown to be lowest in chronic periodontitis with diabetes group as compared to chronic periodontitis and healthy group. And overall, there was a significance between the groups, but post-hoc Bonferroni test for serum vitamin D level showed that the difference was statistically significant between chronic periodontitis plus diabetes group as with compared to control group, and periodontitis group compared to control group. There was no statistically significant difference between chronic periodontitis and chronic periodontitis with diabetes group. And we also could not find any significant correlation between socioeconomic variables and vitamin D. Now, the underlying microbial process from the periodontal disease and diabetes could have a synergistic effect in lowering vitamin D levels in these patients. And now prospective interventional and longitudinal studies with a larger sample size would be required to confirm the relationships between periodontitis, diabetes, and vitamin D deficiency. To conclude, the study observed a lower vitamin D level in patients with periodontitis with diabetes than that of patients with periodontitis and healthy subjects, which suggests that effective management of periodontitis can yield beneficial effects in reducing HbA1c as well as maintaining sufficient vitamin D levels. Thank you.
Why did you select type 2 diabetes patients?
The bidirectional link between periodontitis and diabetes has been clearly established, and ma'am, we wanted to see if the cumulative effect of periodontitis and diabetes could lower the vitamin D further. Like there has been a lot of studies which show that periodontal health is that is poor periodontal health has lower vitamin D, linking lower vitamin D and poor periodontal health. Now the addition of diabetes could again lower the vitamin D levels. So we included that group together, ma'am.
So is there any correlation between vitamin D, diabetes, and periodontitis?
Yeah, ma'am. We could find a correlation, that is vitamin D was lowest in the group who had periodontitis and diabetes as compared to only periodontitis group and the healthy control. It was lowest in the group which had both periodontitis and diabetes. But the difference was not statistically significant between periodontitis and periodontitis plus diabetes group, ma'am. But still it was low.
Yeah,
Yes,
what
ma'am.
was the exclusion criteria? Like which?
Yes, ma'am. Patients having systemic diseases like all the cardiovascular disease, bone diseases, malignancies, then pregnant patients, lactating women, all were excluded, ma'am. Smoking individuals were also excluded, ma'am.
Any specific related to vitamin D deficiency?
Ma'am, for example, ma'am, all the other systemic conditions, they also have been linked with vitamin D deficiency, ma'am. There has been studies which show that these other systemic diseases and vitamin D deficiency is linked. And also like in women with postmenopausal women, these women are also found to have a lower vitamin D. That is an independent association. So we wanted to exclude those that the those patients, ma'am.
Did you like standardize those exposure to sun or any medications? Like, did you do any standardization?
Yes, ma'am. Yes, ma'am. We had actually measured the sun exposure. We had, by the questionnaire, we had asked the patients for the sun exposure they get per day, and we could not get any significant difference. Likewise, we had asked for the diet and also their BMI. These were all assessed, ma'am, but we could not find any significant difference between the groups, ma'am. Even after matching for all this, there was a difference, ma'am, in vitamin D.
Which vitamin, like which derivative of vitamin D is important?
Ma'am, like in this study, we have included that is studied serum 25 hydroxy vitamin D rather than 125 dihydroxy vitamin D, because it is the circulating form. Most circulating form is this 25 hydroxy vitamin D, and it shows a cumulative that is amount of vitamin D that is got through sunlight and also all the diet. So this is the major circulating form, and so we had selected 25 hydroxy vitamin D, but the active form is 125 dihydroxy vitamin D.
There are a number of studies on 125 dihydroxy. Okay.
Yes, ma'am. Yes, ma'am. Yes.
Okay. Okay.
Yes, ma'am. Thank you, ma'am.
Start.
Can I start now?
Yeah.
Good morning, everyone. My topic for today's poster presentation is effect of tetracycline, doxycycline, and triphala on collagen membrane degradation and in vitro study. Membranes differ in their resorption pattern following their implantation, thus influencing the clinical outcome. Also, addition of collagenase inhibiting molecules can modify their resorption rates. Hence, the aim of my study is to evaluate the effect of tetracycline, doxycycline, and triphala of various concentrations on degradation of collagen membrane when incubated with collagenase enzyme in vitro. For this, first 5 mm diameter collagen membrane discs were prepared from the helicite collagen membrane and incubated in tetracycline, doxycycline, and triphala in concentrations of 25 mg, 50 mg, 75 mg, and 100 mg for 24 hours. After 24 hours of incubation, the membranes were thoroughly rinsed and collagenase enzyme was added to all the test samples. Along with test samples, each and every concentration of every drug has had an control where no enzyme was added to the sample, but the membrane was incubated in the drug and studied on the same examination day of 2/7/14/21. The assessment was done as amount of protein content in the medium, which was studied by using spectrophotometric analysis. The statistical analysis have shown that there is a difference in the amount of protein released in the medium over time between the groups with and without collagenase for tetracycline, doxycycline, or triphala. In case of tetracycline, 50 mg per ml concentration was more effective in delaying the degradation of collagen membrane, and for doxycycline, both 50 mg per ml and 75 mg per ml concentrations are equally effective in delaying the degradation of collagen membrane. And in case of triphala, 25 mg per ml, 50 mg per ml, and 100 mg per ml were efficient in delaying the membrane degradation. Of all the three concentration of triphala, 100 mg per ml is more effective, followed by 25 mg and then 50 mg. Hence, I conclude that herbal and natural products like triphala can be encouraged to use in periodontics in order to prevent several adverse effects seen with the commercially available drugs such as tetracycline group of drugs. Thank you.
Why triphala was selected?
Ma'am, actually, I have come through a review article which suggested that triphala has several uses for its use in periodontics, like it have antioxidant property, anti-collagenase activity. Sumantran et al. From his study have also concluded that particularly triphala with three herbal components is effective in delaying the collagenase activity, ma'am. That is, it is a potent collagenase inhibitor. And of the three components, the main component, that is Terminalia chebula, is considered as a potent collagenase inhibitor, ma'am, type 2 collagenase inhibitor.
didn't mention about the concentration of tetracycline or doxycycline you used.
Yes, ma'am. All 4 concentrations, ma'am. 25 mg, 50, 75, and 100 for all the 3 drugs, ma'am. But in case of tetracycline, 50 mg per ml is efficient than all the concentrations, ma'am. And in case of doxycycline, 50 and 75 are equally efficient, ma'am. In case of Trifala, 100 mg per ml is more efficient, ma'am, than all the drugs.
You have verified all the concentrations of Trifala with all the concentration of tetracycline and doxycycline.
Ma'am. Yes, ma'am.
So how many groups, how many intergroup variations did you get?
48, ma'am.
48.
Actually, I repeated the experiment for 3 times, ma'am. 3 replicate experiments I have done, ma'am.
Okay.
So all 4 days, 288 samples, ma'am, actually.
Okay.
So you got better results with Trifala, not with tetracycline.
Yes, ma'am. Yes, ma'am.
Okay.
Thank you, ma'am.
Start.
Good morning, everyone. Presenting poster on comparative SCM evaluation of the effect of gray-curates with diamond-coated file and ultrasonic scalar on root surface roughness and tooth substance loss of extracted teeth during phase 1 periodontal therapy and in vitro study. The objective of this study is to investigate, compare, and evaluate root surface alterations following different instrumentation procedures. Coming to methodology, 48 extracted teeth were selected for this study. 3 different instruments were tested in 3 different approaches, namely Group 1 is gray-curates, Group 2 is gray-curates and diamond-coated file, Group 3 is ultrasonic scalar. 2 indices were used, namely roughness, loss of tooth substance index, RLTSI, and loss of tooth substance index, LTSI, were used to record the magnitude of root surface alterations. SCM analysis samples for Group 1 treated by gray-curate reveals non-homogeneous surface with roughened and corrugated regions, instrumental marks, scratches, and gouges. The first 2 images shows roughened and corrugated areas with instrumentation marks all over. The third image of the Group 1, which is in 500 magnification, shows definite loss of tooth substance with most of the cementum intact. And in the Group 2, treated by combined approach, that is gray-curates and diamond-coated file, presents with definitely corrugated surface with instrumental scratches over most of the areas. Now in Group 3, which is treated by ultrasonic devices, reveals more homogeneous morphology with smooth and even surfaces, which denotes no loss of tooth substance. Coming to the result, the statistical analysis was done using chi-square test. The intergroup comparison for roughness index shows statistical significant difference between this gray-curates and ultrasonic group, whereas for loss of tooth substance, statistical significant differences were found between 2 groups. That is, between ultrasonic group and gray-curates, and between ultrasonic group and combined hand-operated instruments, that is gray-curates and diamond-coated file. The result of this study would favor the use of ultrasonic devices, which has been demonstrated to preserve root surface morphology as compared to hand-operated instruments. Now, coming to the conclusion, instrumentation on root surface causes roughness and tooth substance loss irrespective of the selection of instruments and the method used. Thus, in vivo situation will guide the extent of instrumentation which is required to imply the clinical findings. Thank you.
How did you standardize your instrumentation method?
Pardon, ma'am?
How did you standardize the instrumentation method, like scaling with diamond coated, like the force, the amount of force, pressure, strokes, all those things?
Ma'am, actually, in this study, standardization of situation of the clinical force was used more than less than 500 grams, which is the standardized force for the hand-operated gray-curates, and for the lateral pressure, for the ultrasonic, which is lateral pressure for the ultrasonic is operated by the manufacturer recommendation. It should be used in a light feather stroke. And for the diamond coated file, which is used in apical coronal direction.
No. Did you standardize the strokes? That is 5 strokes per on mesial side, 5 strokes on distal side.
Yes, yes, ma'am. 15 strokes. 15
Yes.
strokes were used for hand-operated instruments.
But there are already studies on hand instrumentation versus ultrasonic instrumentation. Then why did you take ultrasonic as a third group? Ultrasonic scaling will definitely be much better as compared to hand scaling. So you could have taken only 2 groups, greasy curettes and greasy curette with diamond coated files. What was the purpose of taking ultrasonic as a third group?
Ma'am, actually, there are lots of controversies, like whereas in different studies, proof ultrasonic is better, and in other studies, hand scaling instruments were proven better. So I took this ultrasonic instruments to see the variation factors, like in a standardization protocol, a number of samples, and tooth selection. I choose molars for this instrumentation, and
No, that is not a criteria. You have taken ultrasonic as a third group in comparison to hand instrumentation. Why have you taken it? When the studies are already proven, why have you taken ultrasonic? Any modification in the ultrasonic instrumentation?
Modification in the ultrasonic chip designs are there, like diamond coated ultrasonic. And
you could have compared this to greasy curette with diamond coated and the newer form of ultrasonic. Okay, ma'am.
Yeah, no. Next.
Next.
All the presenters are requested kindly stick to the time limit, please.
We cannot hear. Ma'am, ऐकायला नाही येत ना?
नाही.
Anuradha madam, we cannot hear.
Ma'am, actually, I guess there's some connectivity issue, but
Okay.
we'll wait for some time,
Yes,
and then we could start with the next presenter. Otherwise, we'll wait for that time that is given to the student.
Okay, madam. Yes.
Thank you, ma'am.
Am I audible?
Please start your presentation because you'll only be given 2 minutes more.
Good morning to respected judges. The topic of my poster is assessment of antibacterial properties of coated sutures, a comparative in vitro study, in which the aim was to assess the antibacterial properties of neem oil coated sutures. As we know that neem is the most useful traditional medicinal plant in India, well known for its antibacterial, anti-malarial, antiviral, and antifungal properties. It has been in the field of dentistry as its history for treating teeth and gum because of its antimicrobial effects, and is popularly used as twigs in the rural population of India to prevent gingivitis. So in this study, neem oil sutures were used to see its efficacy against well-proven antimicrobial properties of triclosan coated sutures. For this study, the plaque samples were collected from the patients having stage 2 to stage 4 periodontitis, and with the help of curettes, and it was stored in the PBS solution immediately. Then the undiluted PBS containing plaque was inoculated into agar even and triclosan sutures of good equal segments. These plates incubated in the incubator with anaerobic gas pack at 37 degrees Celsius for 48 hours, and then this zone of inhibition was seen around the sutures, which was then calculated with the vernier caliper, and the results for this study, the results for neem coated and triclosan coated sutures was then compared. It was seen that the zone of inhibition around the neem coated sutures is nearly double of that of triclosan, indicating the
आवाज आ रही है.
Please
continue. Indicating that the antibacterial efficacy of neem is more comparatively. Thus, the substantial reductions in gram-negative bacterial adherents were observed on the neem-coated sutures. So we could conclude from the study that these sutures coated with triclosan do not provide sufficient antimicrobial effect to prevent the in vitro colonization by oral bacteria, whereas use of the neem-coated sutures appear to be more counterproductive, and therefore antibacterial coated sutures have a promising potential in preventing the colonization of periodontal pathogens and around it, and then inhibiting the biofilm formation. Thank you.
You didn't mention how did you assess antibacterial property, which method?
Ma'am, there are articles which are given by Subramaniam et al. In 2005, which state that the neem has antimicrobial properties and against the oral bacteria.
No, you didn't mention the method. Which method you assess the antimicrobial efficacy?
Ma'am, I took the zone of, I calculated it by calculating the zone of inhibition around the sutures by calculating that in width around the suture, and then I also marked it on the graph sheet, and then I calculated the area accordingly for both the sutures.
What was the control group?
I'm triclosan coated sutures.
Okay. Which sutures you have taken?
Ma'am, 300 sutures.
Any controversy latest on triclosan? Have you heard about?
Sorry, ma'am.
Any controversy on triclosan in toothpaste or whatever?
I'm not aware.
Okay.
Please go through the literature. Okay.
Okay. Next.
Start.
Yeah, next presenter, please.
Good morning, respected judges. Title of my study is a comparative evaluation of effectiveness of biotic class, nano-ultrasonic and 8% arginine containing devices on occlusion of dental tubule and anti-permeability measurement after day 1 and day 7 to 6% citric acid application for 1 minute and in vitro study. So the dentinal hypersensitivity is one of the common oral health problem, and it is due to the exposed dentin surface because of the atresia, abrasion, erosion, or gingival recession, periodontal disease. And recently, many novel biomaterial available for the treatment of this dentinal hypersensitivity. And in this study, I have compared the three dentifrices, namely the biotic glass, arginine, and the nano-adsorptide dentifrices with respect to occlusion of the dentinal tubule. And the aim of my study is to compare and evaluate the effectiveness of this occlusion of the dental tubule between these three groups. And the objective is to find out is there any difference between the occlusion of dental tubule and dentin permeability measurement with the 6% citric acid application for 1 minute. In methodology, the first step is preparation of the dentin dish sample. For that, I have collected 32 extracted teeth, which are extracted for the orthodontic purpose, without involving any carious teeth or carious teeth excluded from this study. Now, these teeth are stored into the formalin solution and thoroughly scaled and wood plan. The 64 dentin discs prepare approximately of the 1 mm size from these two surfaces by cutting perpendicular to the long axis of the two surface with the help of the tungsten carbide burr or the round disc under the continuous water spray. Now, these 64 dentin discs go through the phosphoric acid etching, 37% phosphoric acid etching for 2 minutes. To remove the smear layer which formed due to the grinding process. Now these 64 dentin discs divided into the 4 groups, each contains 16 sample. The group 1 is a control group, which is a phosphoric acid specimen without any treatment, while group 2 is a phosphoric acid specimen brushed with a biotic glass for 2 minutes. And group 3 is a phosphoric acid specimen dentifrices brushed with a nano-adsorptide for 2 minutes. While group 4 is phosphoric acid specimen treated with a arginine containing dentifrices for 2 minutes. Now the group 2, group 3, and group 4 again subdivided into 2 groups, subgroup 1 and subgroup 2. The 4 dentin discs from the subgroup 1 was evaluated for ACM analysis after the day 1, and the remaining 4 dentin discs daily brushed with respective dentifrices and stored into the artificial saliva to find out the occlusion of dental tubule at the end of the day 7. So the basically subgroup 1 containing dentin disc was evaluated for ACM analysis before the citric acid challenge, while the dentin disc into the subgroup 2 was evaluated for occlusion of the dental tubule after the citric acid challenge. Hello.
Yes.
Sorry. From this, the data collected and master chart created, which contain the completely occluded tubule, partially occluded tubule, and non-occluded tubule. And the one-way annual test and the post-op test was done for the statistic result. Now the result shows that there is a significant, non-significant difference found between the group 2 and group 2. That is the biotic glass containing group and arginine containing group. And after day 7, there is a highly significant difference found between the group 3 and group 2, while group 3 and group 4. And there is a partial significant difference found, which is with the p-value of less than 0.05 between the group 2 and group 4. And from this,
sorry to interrupt, but please stop your presentation, ma'am. You can proceed with the question answer.
Okay. Thank you.
The contents you have mentioned.
Yes, ma'am.
Is the content of any specific ingredient called Novamin?
Sorry, ma'am.
Called Novamin?
No, ma'am. Biotic. No. Only Novamin containing dentifrices are biotic glass, then arginine and nano-adsorptide containing dentifrices.
Because in your results you have mentioned only regarding Novamin and nothing other than Novamin.
No, ma'am. The occlusion on day 7, the occlusion of the dental tubule was highly significant with respect to arginine containing dentifrices, and after the citric acid challenge, the biotic containing dentifrices show the more resistant to the citric acid.
You have checked 2 parameters. One is the dentinal permeability, yes, and one is the dentinal tubule occlusion. What were the methods? What were the methods of evaluation of this two?
Ma'am, increasing the dentinal tubule diameter after the citric acid application.
Method of estimation. How did you check? How did you verify this dentinal tubule occlusion and dentinal permeability?
Dentinal tubule occlusion was done by ACM analysis by putting the grid into the 9 format and the 100% permeability was taken as a consideration as a basic parameter. And post-hoc test and one-way anode test was done for this.
Permeability you have assessed differently, no? How did you assess the permeability?
By increasing the diameter, ma'am. They gave us the increase in the diameter either in partially occluded form or non-occluded form, like 2.8 micrometer size of the dental tubule. Depend upon that, they divided into the partially occluded tubule, non-occluded.
That is the ACM that you have done. That
Yes,
is the ACM related to the dental occlusion tubule, occlusion
Yes,
of the
ma'am.
dental tubules. I'm asking regarding the permeability. How did you verify?
After citric acid challenge.
Okay, madam.
No, you already covered my questions.
Yes.
Next.
Okay, thank you.
Thank you, ma'am.
Hello, am I audible, ma'am?
Yes.
A very good morning to all the judges. Of my study is scanning electron microscopic evaluation of two methods of sharpening periodontal curates. The treatment of periodontal disease, it is based on efficient scaling and root planing and adequate maintenance patient, that is the supportive periodontal therapy. The effectiveness of SRP, that is scaling and root planing, is influenced by operator skill, access to the subgingival area, root anatomy, and the quality and type of instruments that are being used. The aim of the study was to evaluate and compare the bevel measurements, functional and non-functional wire edges of periodontal curates after sharpening using scanning electron microscopy. 9 curates were taken in this. They were divided into 3 groups each. The first group being the factory manufactured curates that were taken from the packet and used as it is. The second being blunted curates. Those were blunted by root instrumentation on extracted human teeth. The single rooted teeth were used for this. And the third group being the blunted curates that were blunted on the human teeth and then resharpened by using an Arkansas stone. Then while sharpening by an Arkansas stone, the curates were the lateral face of the curate was slided against the flat Arkansas stone towards the operator at 100 or 110 degree angle between the stone and the coronal face. The curates, these were evaluated under a scanning electron microscope. The photographs were evaluated by 2 periodontists. The photos evaluated according to cutting edge index developed for this study. Now coming to the scoring that was used, score 1 was given for precise angle of coronal and lateral face without wire edge. Score 2 was given slightly irregular cutting angle with or without wire edges. Score 3 was given for markedly irregular cutting angle with or without wire edges. And score 4 was given for an undefined cutting angle with the presence of bevel at the third surface. Now coming to the results, it was observed in the study that the blunted instruments had a beveled surface present. The factory manufactured and resharpened instruments had a slightly irregular margins with wire edges that were comparable to SEM images. Now we concluded in the study that the sharpness of instrument is of utmost importance to reduce the fatigue of the operator, the amount of force needed for calculus removal, and for the precise hand instrumentation. Here we saw that the strokes on an extracted tooth root blunted the instrument and led to the formation of a bevel surface when viewed under 500x and 1000x on an SEM. By resharpening with Arkansas stone, the blunt bevel can be removed from the cutting edge while still maintaining the structural integrity of the instrument. Thank you, ma'am.
Blunted the curates?
Yes,
manufactured curates you have blunted. How?
Ma'am, by using extracted human teeth, single-rooted teeth, we gave 400 strokes each. Like each curate was given 400 strokes on the extracted teeth.
Okay. And then again resharpened on Arkansas stone.
Yes, ma'am.
And then carried out the SEM.
Yes, ma'am.
How could you sharpen Gracie? Was it universal or Gracie curate?
Ma'am, I use Gracie curates, ma'am.
This vesiculates. So what about angulation? How did you achieve
Yes, ma'am.
angulation on vesiculates?
Ma'am, angulation while sharpening?
The curve, no?
Yes, ma'am. Actually, ma'am, I used a standardized procedure for sharpening. The Arkansas stone, it was kept flat on the table, and then the lateral surface of the Gracie curates, they were stroked on the Arkansas stone in three ends. First the tip, then the middle portion of the working end, and then the last portion of the working end was sharpened. And 5 strokes each was given, and the direction of the sharpening was away from the operator.
Any other method of sharpening you should have compared? Well, it's
Yes, ma'am.
difficult, on Arkansas stones to sharpen vesiculates.
Ma'am, can you please repeat the question, ma'am?
Any other method of sharpening you could have compared? Because on Arkansas it's difficult to sharpen vesiculates and all.
Yes, ma'am. Ma'am, actually, I'm going to carry out this study further, and I'm using one more stone in comparison with the Arkansas stone. It is called silicon carbide stone or India stone. And there are many other stones also available. Like we can use Arkansas 229 stone. That is a pen-shaped stone. We can use that, and there are some patented instruments also available, like Navard Whittler blade that can be used, but they are not very readily available in India, and you have to import these. So I was thinking about using the India stone instead of these, or the silicon carbide stone.
Okay.
Thank you, ma'am.
Next presenter, please.
Please start.
Please start with your presentation.
Very good morning, ma'am.
Morning, good morning.
Yes, ma'am. Very good morning, ma'am. So my topic on today's presentation is about comparative evaluation of chlorhexidine and other herbal extracts as an adjunctive in ultrasonic lavage in the dental water line for the reduction of microbial load and aerosol contamination. Ma'am, am I audible?
Yes.
Yes, ma'am. So it's known that ultrasonic scaling involves production of high amount of aerosols, and they combine with so much of oral microbes and become a potent source of airborne contaminants. And there are some chemical antimicrobial agents like chlorhexidine.
We can hear you. Continue. Please continue.
Please continue.
So since lavage of chlorhexidine, so we would like to replace it with the herbal extracts such as neem and chlorhexidine. So the objective of the study was to evaluate the amount of aerosol contamination in the clinics while performing scaling with neem and cinnamon extracts. So for that, we did a single-centered parallel arm study with the participants of 128, and they were divided into 4 groups. That is, group 1 was distilled water, and group 2 was chlorhexidine, and group 3 was neem, and group 4 was cinnamon. And they were divided into 32 patients per group, and the raw materials were procured and sun-dried for 14 days, and aqueous extracts were prepared using a surface extraction method. So scaling was performed for patients with all the 4 groups with 2 blood agar petri dishes placed on either sides of the patient from a distance of 40 centimeter, and 1 placed on the patient's operator's chest. And they were incubated aerobically for 48 hours, and CFUs were counted. And these are the pictures which show the distilled water, 0.1% of chlorhexidine, cinnamon, neem. And the results are like the number of Mean number of CFUs in water is about 110, whereas in chlorhexidine it is 31 and in cinnamon is 96, whereas in neem it is 89. So I suggest that neem and cinnamon can be due to their potent antibacterial agents, they could be probable or better alternatives to distilled water in using while during scaling.
Okay.
That will be all, ma'am.
Yes, yes. Any literature supporting neem as compared to cinnamon? We have a lot of literature on cinnamon. Any literature supporting neem?
Ma'am, yes, ma'am. There are so many literatures comparing neem, ma'am. But basically, what we have done is we have also taken since they but they haven't compared it individually neem and cinnamon, ma'am. They have compared with the chlorhexidine, either and neem, and they have compared cinnamon and chlorhexidine, but they haven't compared all the four groups together.
Yes. So that is a limitation of the study.
Yes, ma'am.
Babita ma'am? Okay, thank you.
This is the end of the session. I thank Dr. Babita ma'am and Dr. Triveni ma'am for sparing their precious time for today's session and judging this session. Ma'am, kindly please mail your evaluation sheets once you are done.
Yes.
Thank you everybody. Thanks all the
Thank you
delegates
so
for the
much.
presentations. Thank you so much. Have a good day.
Thank you.
All the presenters were very good. Thank you for giving us opportunity to judge this session. Thank you very much. Yeah.
Thank you. Thank you to the organizing team. Thank you very much.
It was very
Thank you, ma'am.
arranged.
Thank you.
Yeah. Thank you.
Ma'am.
End the meeting. Your Excel sheet.
Good morning, everyone. Are all the participants for the next session there from unique ID number 26 to 50? Please let them enter because we would not be able to enter otherwise.
Ma'am, you start the session. They'll be joining.
The judges have joined, Leena Madam and Dr. Manoj.
Ma'am, I'll check.
Yeah. Anuradha, they haven't joined yet.
Chanchal ma'am, please start the session.
Leena madam has joined.
Ma'am, she has joined. Please start.
Good morning, everybody. Myself, Dr. Chanchal Birwani. Welcome you all to this second session. I hope all the participants have kept their posters ready, and the judges for the today's session are Dr. Leena and Dr. Manoj. Dr. Leena is the professor in Department of Periodontology in SDM Dental College and University Dharwad. She's completed her BDS and MDS from KLE Dental College. Also, she has been full of national and international publications accredited. She has completed research under RGUHS University, which has been government granted. Our welcome, ma'am. Our next judge is Dr. Manoj Kumar, who has completed his BDS from JSS Dental College, Mysore, and from the country's oldest and one of the premium dental colleges, Dr. R. Ahmed Dental College and Hospital, Kolkata. He has completed BDS from the same. He has many publications to his credit, and he is working as an associate professor and PG guide in Department of Periodontics, Institute of Dental Sciences, Shiksha O Anusandhan, deemed to be University Bhubaneswar. Welcome, Dr. Manoj. There are some rules for the participants. You have to keep yourself mute, unmute only when your poster is being displayed. You will have 3 minutes for the poster presentation and 2 minutes for question answer. Please restrict to the time since we have already been delayed. Also, you have to keep your video on when you are presenting the poster. Request everybody to please follow the rules. So let us begin with the session. Let's start with the first participant.
Am I audible, ma'am?
Yes, you are.
Good morning, everyone. Today, my topic for poster presentation is on antioxidant effect of propolis containing toothpaste in patients with the chronic gingivitis. Coming to the introduction, propolis is a resinous matter collected by the honeybees. It have activities like antibacterial, antioxidant, immunomodulatory properties. The main aim of this study was to evaluate the antioxidant effect of propolis containing toothpaste in patients with gingivitis. The objectives are to evaluate the efficacy of propolis toothpaste along with scaling and root planing in terms of changes in the clinical parameters. To evaluate the antioxidant efficacy of propolis toothpaste along with the scaling and root planing in terms of changes in levels of salivary uric acid levels. Coming to the methodology, a total of 40 subjects were included in this study from the outpatient department and divided into 2 groups. That is, group 1, non-surgical periodontal therapy plus the propolis toothpaste, of which they are included of 20 subjects, and in group 2, non-surgical periodontal therapy plus the placebo, and a total of 20 patients were included in this group. The clinical parameters that are measured in this study are the plaque index, gingival index, and the saliva sample collection was done for both the groups at the baseline and at 21st day. The salivary uric acid levels were measured with the salivary uric acid assay kit. Coming to the discussion, Andres et al. Defined the effects of Brazilian propolis on the dental plaque and gingiva in patients with the oral health malformation treatment with the multi-bracket and removable appliances are compared to study. The oxidative stress occurs when during an inflammatory response overwhelm the endogenous antioxidant defense system of the body. The reactive oxygen species is generated by the polymorphonuclear leukocytes in process of oxidative burst during the phagocytosis. These are after the 21-day of assessment, we have observed a significant improvement in the plaque and gingival index when compared with the group 1 than in the group 2. In regard of the salivary uric acid levels, there is a slight significant increase in the group 1 when compared with the group 2. As using with the propolis toothpaste, due to the high levels of antioxidant levels, the salivary uric acid levels were slightly improved. Coming to the conclusion, the propolis has its immunomodulating activities, which reduces the oxidative stress in the chronic gingivitis patients when used along with the scaling and route planning, as it showed an improvement in both the plaque index, gingival index, and the salivary uric acid levels. As there are pro-inflammatory mediators such as interleukin-1, 6, the reactive oxygen species are produced from the inflamed periodontal tissues. Hence, when used with the propolis toothpaste, due to the antioxidant effects, the manifestations as the inflamed gingiva produces the interleukin-1 and 2 and the tumor necrosis factor alpha. These antioxidants scavenge the free radicals and prevent the damage caused by them, hence acting as a remedial and prophylactic agents. These in propolis, due to the presence of flavonoids and pure chromatic derivatives in the propolis.
Sorry to interrupt, but your time is over. We can move ahead with question answers.
What was the reason for using uric acid?
To see the antioxidant effects, ma'am.
Why uric acid only?
As it gives an accurate values of antioxidant.
No, there are so many other markers, but why uric acid? Is there any relation between those propolis and uric acid, something like that? Or the antioxidant levels, why uric acid only? You have so many other markers in the saliva to measure the antioxidant level. Okay, we can just find out.
Okay, thank you.
Next presenter, please.
Good morning, everyone. Am I audible?
Yes.
Good morning, ma'am. Today's my poster presentation is on the topic efficacy of oral probiotics in the treatment of halitosis in menstruating patients undergoing fixed orthodontic therapy. The halitosis mainly denotes the offensive smell of breath. The causes of halitosis can be oral as well as non-oral. The metabolism of the gram-negative bacteria, which subsists mainly on protein-containing sulfurous amino acids, will produce volatile sulfur compounds, which has a main role in the development of halitosis. It is also said that the fixed orthodontic appliances, they tend to increase the accumulation of plaque, and they will reduce the daily efficiency of the oral hygiene that is executed. Also, the protected plaque that is present in the interproximal areas will lead to the accumulation of plaque as well as production of odors, will lead to the overall increase in level of the volatile sulfur compound. It said that the probiotics are said to be reducing the halitosis levels as well as the formation of dental biofilm buildup. So, present study may aim at evaluating the efficacy of oral probiotics in the treatment of halitosis in menstruating patients who are undergoing fixed orthodontic therapy. The subjects were mainly randomly allocated into two groups containing 15 participants each, and group A participants were given with oral probiotics, and group B participants, they were given with placebo. And the inclusion criteria mainly includes the patients having more than 20 natural teeth, patients undergoing fixed orthodontic therapy, and the patients who are menstruating who are under the age group of 18 to 30 years. And the exclusion criteria, which mainly included patients who are having less than 20 natural teeth, and also patients with systemic disease, as well as acute infection and inflammation. The baseline measurements were done, which includes the assessment of the volatile sulfur compounds, which was done using a new method, which is referred to as the organoleptic Kim method. And also the measurements of plaque index and gingival index was done during the ovulatory as well as the follicular phases of menstrual cycle. And the oral probiotics were given during the same time, that is from the 1st to the 15th day. After the 15th day of intervention, it was that there was a subsequent reduction in the oral halitosis in the patients who were given with oral probiotics, whereas in the controls it was less. So it can be concluded that the oral probiotics has a significant role in reducing halitosis in menstruating patients who are undergoing fixed orthodontic therapy. Thank you.
Which probiotic was used?
Ma'am, it is from Wellbiome ka Encode probiotic, ma'am, which contains Lactobacillus salivarius, Lactobacillus reuteri, Lactobacillus rhamnosus, and Placea strains.
In what form it was given?
It was given in the form of sachets, ma'am.
Pardon?
Sachets, ma'am. It was available in the form of sachets, which can be swished.
So it was local therapy?
Yes, ma'am.
Was it a local therapy?
Yes, ma'am. Yes, ma'am.
What exactly instructions were given to the patient? How it was used?
The patients were asked to use it in the morning as well as night after brushing, ma'am, after toothbrushing. They were asked to swish it inside the mouth and then asked to swallow.
Patient was allowed to swallow it?
Yes, ma'am. Yes,
how many times?
Daily 2 times, ma'am.
For how many days?
Ma'am, 15 day, ma'am, starting from the follicular phase of the menstrual cycle till the ovulatory phase, that is from 1st to 14th day.
Why that period only?
Ma'am, it is said that during the ovulatory as well as the follicular phase of menstrual cycle, the halitosis, that is the production of, there is increased production of volatile sulfur compounds, ma'am, within the oral.
Okay.
Yes, thank you.
Please start.
Yeah. Good morning, madam. Coming to my topic is a comparison of the 3 different calcium blockers on gingival overgrowth in hypertensive patients. And the introduction of gingival overgrowth is a common adverse effects that associated with the continued use of some class of drugs that including calcium blockers like nifedipine, amlodipine, felodipine used for hypertension. And mostly the presence of the drug-induced gingival enlargement overgrowth given by Seymour and Thompson in 1996. So, the main aim of the study is to assess the comparison of calcium blockers on gingival overgrowth in a population of hypertensive patients, and the object is like to access the gingival overgrowth in hypertensive patients with 3 different calcium blockers, and to compare the gingival overgrowth in hypertensive patients with 3 different calcium blockers. So, coming to methodology, the total of 206 hypertensive patients under calcium blockers at least for 1 year were observed. Based on this type of drug use, patients were divided into 3 groups, like group 1 like nifedipine group, and group 2 like amlodipine, and group 3 like felodipine. And window parameters like plaque index and pocket protein depth and modified circle splitting index were measured. So gingival overgrowth grading was done by Eva and Ingalls, given by 1999. And come to the results, like the figure shows like group 1 like amlodipine, and group 2 like amlodipine, and group 1 nifedipine, and group 3 by the felodipine. And coming to results, like not much not much significant difference was in plaque index scores are observed between the groups, whereas the significant difference like the p-value is less than 0.05 was observed in the modified ocular bleeding index scores in group 1 compared to group 2 and group 3. A significant increase in pocket bone depth is group 1 has seen that group 2 and group 3. So more gingival overgrowth was observed in group 1 followed by the group 2 and group 3, which was statistically significant. And the discussion part coming in, like increased prevalence of gingival overgrowth was seen among elderly patients and the amlodipine therapy, which caused many side effects like edema and phyllodes. And influence of the calcium blockers in gingival overgrowth in the population of severe refractory hypertension patients was observed in nifedipine and amlodipine, but not phyllodes. So the percentage of phyllodes given to the patient is in the less amount compared to the both amlodipine and phyllodes. And the nifedipine was the most common medication, causing enlargement with more severe periodontal dissections than amlodipine and phyllodes. And the main so the main drawbacks like gingival overgrowth according to the even English like grading in grade 0, grade 1, and grade 2, and grade 3, and grade 4. In grade 0, it's no growth, and grade 1 early overgrowth, and grade 3 moderate overgrowth, and grade 3 marked growth, and grade 4 is so complete severe overgrowth will be seen. And the conclusion of this study of this shows that nifedipine was most common medication causing enlargement with more severe periodontal dissections than amlodipine and phyllodes. Thank you, man.
Okay, so can we give felodipine as an alternative to nifedipine according to your study? Can you tell
No,
that?
sir. Yes, sir. Sometimes it will be given, sir, for severe hypertensive patients more than 250 like that, and hypertensive patients, a couple of group of drugs will be given, sir. So at that time, we can give felodipine as secondary drug compared with nifedipine and amlodipine, sir.
Okay, thank you.
Yes, sir. Thank you, sir.
Next presenter, please start.
Good morning, ma'am. Am I audible?
Yes, sir.
Good morning. My topic is critical evaluation and assessment of clinical outcomes and patient satisfaction of implant support in anterior region. Starting with the introduction, dental implants are the pioneering treatment modalities for replacement of missing teeth. Single tooth implant is viable treatment option for single tooth replacement. Single tooth implant can be placed either in healed extraction sites or fresh extraction sockets. Objective of the study is to evaluate clinical outcomes and patient satisfaction in relation to immediate versus delayed implant supported single tooth replacement in anterior region. Starting with methodology, 30 patients were selected and categorized into two groups, Group A with immediate implants and Group B with delayed immediate implants placement. Clinical radiographic evaluation was done with bleeding on probing, height of crestal bone, width of keratinized mucosa, papilla fill index, implant mobility, and questionnaire related to patient satisfaction were filled by patient required in the study. The result of the study was there was a difference between the groups at third month, 6 month, and 9 month was statistically significant as 0.38, 0.021, and 0.0117. In intergroup comparison of height of crestal bone at 6 months, there was statistically significant difference in mean height of crestal bone scores between Group A and Group B, that is 0.014. At 12 months, height of crestal bone scores between Group A and Group B was 0.41. Intergroup comparison of width of keratinized gingiva shows statistically non-significant difference in the width of keratinized gingiva between the Group A and Group B and at the intervals. Intergroup comparison for papilla fill index shows statistically non-significant difference in the papilla index scores between the group A and group B. Last is intergroup comparison of normal implant stability. There was no significant difference in implant stability with immediate or delayed implants. The conclusion was there was no implant mobility and significant difference in the papilla fill in both groups. In psychological benefit from the patient was very good. Thank you, ma'am.
Okay, so can you classify implant placement?
Sorry, sir, you are not audible, sir.
Hello.
Yes, sir.
Can you classify implant placement based on the time of placement?
Sir, what kind of classification?
Based on time of placement, na? Immediate, early, delayed. Can you tell me the time frame? What is immediate, what is early, what is immediate, and what is delayed?
Early immediate implant is after during extraction when we extract the tooth and we place the implant. Delayed implant we extract the tooth and place implant after 3 months. 3 months or 4 3 months in mandible and 4 months in case of maxilla.
What about early?
Yes, sir.
What about early placement? What are the advantages of immediate placement?
Take the time and
I cannot see you. Your video is not on.
yes, sir.
You are not visible.
The video.
You are supposed to be.
All participants are requested to keep their video on when you are presenting your poster and answering the questions, please.
Anyhow, you can answer that. We don't have much of time. But
How did you
the
check
rest
for
of the participants, please keep your video on during presenting and question and answer session.
Okay, sir.
How did you check for the
Okay,
implant stability?
And by we check the implant placability by checking with probe and plastic probe.
No, how did you check for the implant stability? In your study, the last criteria was implant stability. How did you check for that? Yes. Okay.
Sorry.
Can we have the next presenter, please?
Good morning, everyone. Today I'm here to present the poster on the topic evaluating the efficacy of 2% lignocaine with buffer 2% lignocaine in periodontal flap surgeries, a randomized clinical study. As we all know that local anesthetics are widely used in dentistry, local anesthesia acts by hindering the generation and conduction of nerve impulses and by blocking the entry of sodium ions into the channels, thereby decreasing the sodium permeability to the nerve membrane, resulting in the conduction blockade. So the pH of the local anesthesia ranges from 3.9 to 4.5. This acidic nature of local anesthesia solution causes pain during the infiltration of the solution into the oral tissues, and by altering this pH by adding the sodium bicarbonate may decrease the pain on injection and also prolong the action of local anesthesia. This process is known as alkalization. And by doing this alkalization process, the potency of local anesthesia is increased due to the increase in the number of unionized ions. So the aim of my study was to evaluate the efficacy of 2% plain lignocaine and 2% buffer lignocaine 2% buffer lignocaine anesthesia. And this efficacy was evaluated by the parameters onset of injection, which was assessed by the asking the patient for subjective symptoms, and the duration was calculated by informing the patient to report the first occurrence of pain after the surgery and prior the intake of the post-surgical medications. And in this, 20 patients were included in the study, where 0.6 ml of 8.4% sodium bicarbonate was added to 3 ml of the local anesthetic solution, and INV blocks were given, and the parameters onset of action, duration of action, and pain on injection with sodium bicarbonate during the flap surgeries were observed. Results have shown that for the onset of action, duration of injection, and pain on injection, there was no significant statistical difference, but there was clinical difference. And we have concluded that in both the groups, it has not shown much difference, but clinically, the onset of action, the duration of action was prolonged due to the bicarbonate solution, and pain on injection was also clinically it was reduced when the sodium bicarbonate was added. Thank you.
How did you check for the reduction in pain?
The onset was checked by watching the onset of injection when the VAS scale was used, visual analog
Pain.
scale.
I'm asking about pain. How did you check for the pain?
Yes, ma'am. The pain on injection was checked by the using the VAS scale, ma'am, visual analog scale. The patient was asked to rate from 1 to 10 on the ranging the pain, ma'am. It was a split mouth study, ma'am. In 20 patients, in the on.
But that is done during the injection. Am I right?
Yes, ma'am. During the pain on injection.
It was taken immediately.
Yes, ma'am. Immediately, ma'am. Immediately after when the LA was administered, immediately after that, the patient was asked about the scale.
So how does this sodium bicarbonate reduce the pain? You said it reduces.
Ma'am, it increases the pH of the solution, ma'am, where the carbon dioxide and water are reduced, where carbon dioxide causes ma'am, it causes more immediate form of analgesia, ma'am, as it it diffuses rapidly through the nerve sheath and reaches the axon before the local anesthetic solution, ma'am. So the bicarbonate, when it is dissociated into carbon dioxide and water, this carbon dioxide helps in the increase in the action.
Okay.
Thank you.
Can we have the next presenter, please?
Good morning, ma'am. The topic for poster presentation is moringa leaves extract, non-surgical treatment for the chronic periodontitis. Moringa oleifera is a medicinal plant which is having the family of Moringaceae. It is consumed in the rural and suburban area of the India and some Asian countries also. It having some amino acids which is like aspartic acid and some glutamic acid, etc. It having the antibacterial and anti-inflammatory property. According to Sushant et al. 2018, it contains the anti-inflammatory properties also. The anti-inflammatory properties of this and antibiotic properties of this is due to the presence of its alkaloid, which are the pterigospermine and the moringogene. It also shows to reduce the cytokines level in some patient in vitro study. So aim of the study was to assess the efficacy of subgingival irrigation with 2% ethanolic extract of the moringa leaves in patient with the chronic periodontitis. So coming to materials and method, in this study, 20 sites with chronic periodontitis with probing pocket depth of more than or equal to 5 mm was selected, and it was randomly divided into the two groups. A was the test group and B was the control group. So how this moringa leaves extract was made. First of all, the moringa leaves were collected and they were sun dried, and they grounded into the fine powder, which is of the 5 gram, and that it was kept into the alcohol, which was the ethanol. Afterward, it was macerated in the closed flask up to the 24 hours. Afterwards, it was placed in the rotary shaking machine for the 4 hours, and afterwards it was filtered by the Wattmann's filter paper and kept into the water bath up till we get the extract. The get extract was mixed with the distilled water, which was the 100 ml of distilled water, and quantity of extract was the 2.5 ml, which was taken into syringe and mixed into the water plate. So in group A, which was the ethanolic extract group, in which 100 ml of subgingival irrigation with 2% ethanolic extract of moringa leaves was done after the scaling and root planing. In group B, the scaling and root planing done, then the subgingival irrigation with the 0.2% chlorhexidine was used. Clinical outcomes in this study were evaluated like gingival index, plaque index, clinical attachment levels, probing pocket depth, which was at the baseline 15 days and the 30 days. So result of this study shows the statistical significance at the 1 month interval for the gingival index and plaque index only, but it shows the non-significant difference for the probing pocket depth and the clinical attachment level. So conclusion of this study, the irrigation with ethanolic extract of the moringa leaves, which is the non-invasive technique, it improves the clinical outcomes like gingival index and plaque index at baseline 15 days and 30 days. Thank you.
Is this a common name, moringa leaves? What is the source of that actually?
Ma'am, it is in general term we can call this as a drumstick leaves, drumstick, which we are consuming in diet regularly.
Okay. Why did you use it subgingival irrigation?
Ma'am, there are no studies of the subgingival irrigation with the extract of this moringa leaves. There were studies using the mouthwash, which shows the statistical difference, significant difference comparing to the regular used mouthwash. Therefore, there was no study, so I using importance of the subgingival irrigation is due to the pulsation and the pressure felt by the device, which is due to the hydraulic pressure. Yes, ma'am.
When it is effective as a mouthwash, then why you want to try it as a subgingival irrigation?
Because subgingival irrigation also helps to reduce the bacteria due to the pressure and pulsation from the device, and it helps to reduce the plaque accumulation in subgingival areas also. When we use in the mouthwash, yes, ma'am.
Then you could have gone for the gingivitis patients. Why did you go for the chronic periodontitis?
Because chronic periodontitis patients having the probing pocket depth more than 5 mm, and subgingival irrigation helping to reduce the bacteria which present in the subgingival area.
So irrigation helps in periodontitis patients, not much in the gingivitis patients. Okay.
Okay.
Thank you, ma'am.
Next presenter, please.
Good morning. Good morning. Title of my poster presentation is Efficacy of Non-Incised Papilla Surgical Approach and the Entire Papilla Preservation Techniques in the Treatment of Intrabony Defects, a Clinical and the Radiographic Study. NIPSA and EPP was designed to maintain the integrity of the interdental soft tissues covering the intrabony defects. This would prevent the biomaterial exposure associated with the loss of papillary height and increase the amount of space for the hard and soft tissue regeneration and minimizes gingival recession. The aim of this clinical research is to demonstrate the efficacy of NIPSA and EPP technique for the treatment of intrabony defects with the GTR membrane and the hydroxyapatite graft by preserving the interdental tissue. The main objective of this clinical research is to evaluate the clinical parameters such as the probing depth reduction and the gain in the clinical attachment level and the bone regeneration, employing these techniques with the regenerative biomaterial radiographically. Coming to the methodology, 17 members participated in the study in the each group. In NIPSA, one buccal horizontal or the oblique incision is given in the mucosa as apically as possible from the periodontal defects in the marginal tissues. Through the horizontal incision, the soft tissue will be reflected apicocoronally by the full thickness flap to expose the bone crest, delimiting the interbony components of the defect. Marginal tissue will be kept unaltered without raising or detaching the interdental papilla. Then the root planing will be performed and the irrigation will be done with the novel saline, and the root conditioning will be done with the tetracyclines, followed by the hydroxyapatite graft and the stabilization with the GTR membrane, and finally the sutures will be placed. Whereas in the EPP technique, following a buccal intraclavicular incision, a bevel incision is bevel releasing incision is given in the buccal gingiva of the neighboring interdental space and will be extended just beyond the mucogingival line to provide appropriate access to the interbony defect. Buccal full thickness mucoperiosteal flap extending from the vertical incision to the defect, and the associated papilla will be elevated with the periosteal elevator. And following the regranulation, tissue will be removed and using the tetracycline, the root conditioning will be performed and followed by the hydroxyapatite graft placement and stabilization with the GTR membrane, and finally the sutures will be placed. Results when compared to the baseline, there is in NIPSA and the EPP techniques, there is a significant gain in the clinical attachment level and the probing depth reduction. Whereas in NIPSA, there is no papilla loss, whereas in the EPP technique, there will be a minimum loss of the papilla. And when compared to the 6 months, there is a significant gain in the bone fill was also observed. Coming to the conclusion.
Sorry to disturb you, your time is up. Ma'am.
What are the incisions given in IMSA technique? Incisions given.
Ma'am, buccal horizontal incision will be given in the mucosa, and as marginal tissue will be unaltered, and from the horizontal incision, the soft tissue will be reflected.
Soft tissue is reflected from the buccal surface?
Yes, ma'am, from the buccal surface of apicocoronally.
Marginal gingiva is intact?
No, ma'am, marginal tissue is not detached, ma'am.
That's what intact it is.
Yes, ma'am, intact it is, ma'am.
Then how do you eliminate the pocket? How do you reduce the pocket depth?
Ma'am, with the help of curettes, the deep pockets will be neglected, ma'am.
No, you said the marginal gingiva is left intact. Yes, there is no incision given there, not internal bevel incision, no clavicular incision. Then how are you going to reduce the pocket depth or eliminate the pocket depth?
But the soft tissue will be reflected, ma'am, and the full thickness slab will be elevated to expose the bone crest, ma'am, and to delimiting the intrabony component, ma'am.
Yeah, you're directly accessing the defect, but what about the pocket lining? Yes, please go.
Please go ahead. Thank you.
Next presenter, please.
Good morning, everyone. Am I audible?
Yes.
Hello? Okay. All right. Good morning, everyone. So the topic of my research was evaluation of the efficacy of ozonated water irrigation following open flap debridement, pocket elimination in chronic periodontitis patients. So since the time in the early 1940s when ozone gas was first used in medicine by Dr. E.A. Fish, it has been used in periodontics for a variety of reasons, from treatment of gingivitis to chronic and aggressive periodontitis. So because it has a property of releasing nascent oxygen, it has antimicrobial properties, it has properties of immunostimulation, and it promotes wound healing, which makes it a very ideal material for treatment of periodontitis or periodontal lesions. So the aim of my study was to evaluate the efficacy of ozonated water irrigation following open flap debridement versus, it was a comparative evaluation of ozonated water irrigation versus only open flap debridement and pocket elimination in chronic periodontitis patients. So my study had enrolled about 25 patients in a split mouth design. And group 1 was a positive control of only open flap debridement. Group 2 was open flap debridement followed by irrigation with ozonated water. Now this ozonated water was made using an LTEC ozone generator with the oxygen flow of 0.75 liters per minute, which gave us an ozone concentration of around 0 to 10 micrograms per milliliter. So about 4 ml of this ozonated water was used for irrigation following debridement. 4 ml was used for irrigation over 10 seconds, and then the flap was sutured back into position. The baseline parameters that were recorded were the gingival and the pedontal indices and the probing depth using a stent. And these parameters were again measured at 4 weeks. So it was found that there were significant differences, intergroup differences between the gingival and the pedontal indices. However, there was a significant intra-group difference from baseline to 4 weeks in the pocket elimination in both the groups, whereas intergroup differences were not found to be significant. So the reduction of the gingival and the plaque indices could be attributed to the antimicrobial and the oxidative property of the ozone gas. Whereas since the overall result of pocket elimination was not achieved as expected, it could just be attributed to the removal of the etiologic factors, of course, with the use of ozone gas, ozonated water. So my conclusion would be, although ozonated water was found to be efficacious in this case, there is still more research that could be conducted, maybe with the bigger sample size. So that would be one of the drawbacks of my study. So the sample size was quite small, with 25 patients, and I had 3 patients who dropped out of the study. So at the end, I had 22 patients who were enrolled into the study. So yes, so that would be my conclusion, that more research would be required, although ozone was found to be efficacious. Thank you.
How did you check for the antibacterial activity?
Ma'am, actually, microbial assay was not done in the case, which is, again, I would say, is a drawback of the study. So the antimicrobial efficacy of ozone, I would say in this case, was based upon the results of the indices that came out. So we had reduction in the inflammatory reduction in the inflammation of the gingiva, which could be attributed to the reduction of the antimicrobial load. Microbial assay was not performed.
Yeah, that's what your aim and objective was, to check the antimicrobial activity.
Ma'am, yes, ma'am.
Then
Ma'am,
you should have
basically Ma'am, basically my aim was to check the pocket elimination, but yeah, the antimicrobial activity.
See, already you have
microbial assay should have been performed.
Now tell me, already you have opened a flap.
Yes, ma'am.
It is in a flap patients, right? After the surgical therapy was done.
Yes, ma'am.
Yes, the flap is opened.
Yes, ma'am.
Then how does this, or how you expect this, means how does this help much after
Ma'am,
opening?
actually, yes, ma'am. Now, after opening and after debridement, ideally assessing the antimicrobial efficacy of ozone in this case would be wrong, because debridement would mean removal of all the bacterial
local
load
therapy is
in that area. So, ma'am, here my aim, yes. So this was the open flap debridement was following the following scaling and root planing. So following NSPT, we did open flap debridement. So here antimicrobial assay would actually mean this. So my aim would have been, but primary aim would be to check the pocket elimination and not the antimicrobial efficacy of ozone.
Okay.
We can proceed, I think, next.
Okay.
Thank you, sir.
Thank you.
Next presenter, please.
Good morning, ma'am. Good morning, ma'am. The topic of our title is Innovative Radiographic Technique to Assess the Periodontal Regeneration of Grade 2 Furcation Defects in Treatment with PRF, CHIPS, and PPP. Even the aim of the study was to clinically and radiographically evaluate the use of PRF chips with BPP in the treatment of grade 2 furcation defects, where we have taken 30 sites with grade 2 furcation defects in mandibular molars, and followed by impression, stent preparation on cast, and we have taken pre-surgical radiographic and clinical recordings. And then we have done open flap debridement of the furcation sites, and we have treated it with PRF chips and with PPP, along with PPP, and followed by sutures. We have evaluated the patients at baseline, 3 months and 6 months, where we have taken both clinical and radiographic evaluation. Clinically, we have seen a significant reduction in pocket depth and gain in CAL. And radiographically here we have done we have taken radiographic evaluation 3 months, 6 months, where we have taken four parameters. Firstly, we have measured the line joining the fornix to the mesobuccal root, which is T1. Fornix to distal root we have taken as T2, and the line was T3. And then we have measured the horizontal furcation. Using these, we have taken the parameter and the area of furcation. The results, we have seen a statistically significant reduction in the parameter and area. So the radiograph, we have emphasized more on the radiographic technique here, because the radiographic evaluation of the periodontal regeneration allows a better assessment of the bone tissue adjacent to the defect. So even though surgical re-entry is a gold standard to analyze the treated defect, but so that we'll get a good view of the state of the defect after, and we can compare it with the initial surgical intervention. But it has its own shortcomings, like we have to conduct a second surgical procedure, and also we cannot assess the type of attachment we have achieved there, either new attachment or long-range epithelial attachment. So to avoid this, we have taken the radiographic, we have used the innovative radiographic technique, but and also we have advanced techniques like CBCT and digital techniques, but because it is cost effective and we cannot conduct it in a longitudinal and more sample size patients, we have chosen this. And we have taken PRF chips and PPP because as we know, PRF has a better wound healing properties and cell function, and it improves the migration and proliferation of the local fibroblasts. And PPP also allows a firm, it also leads to a firm sealant, where it forms a adhesive, giving adhesive potential property. So, let's do.
What is this PRF chip?
We have taken, we have made a PRF membrane, and we have mixed it, like we have made it into small chips, and we have cut it into small chips, and we have mixed it with PPP. We have taken the upper layer of the
What's the difference between this fiber membrane and that chip?
Ma'am, it forms a better sealant meshwork. It forms a tetramolecular meshwork along with PPP. So that was added advantage.
What is regeneration?
Regeneration is Hui formation of peridone. We get a new clinical attachment with the help of periodontal ligament.
Regeneration. Is it only clinical attachment?
Sorry, ma'am.
The aim was to attain a regeneration, right? So did you attain a regeneration by using this?
Yes, ma'am. Yes, ma'am. We have gained a significant bone along soft tissue.
So did you attain a complete
Regeneration is only gain of bone? Sorry.
Please go ahead. Please go ahead.
Same question I was asking. Regeneration is only gain in bone? There is a definition in Linde, if you have read. Regeneration is not only gain in bone, there are other parameters as well.
Pedial, bone, cementum, and soft tissue, original. All these
So
together.
have you assessed all those?
Yes, sir. Yes, sir. We have taken clinical and radiographic parameters.
You can assess clinically cementum and pedial fibers. Anyhow, thank you.
Go on.
Sorry, ma'am. Sorry for
No, absolutely no problem.
Next presenter, please.
Good morning, respected judges. I am here to present a short study titled as Correlation between Cnidarian membrane thickness, severity and type of periodontitis, a retrospective CBCT analysis. Periodontal disease is a chronic infectious disease that leads to severe resorption of the ulnar bone, tooth mobility, and eventually exfoliation. Because of the intricate root architecture, which includes concavity of the root surface and furcation involvement, maxillary molars and premolars are more prone to periodontal infection. Furthermore, due to the close anatomical proximity of the maxillary posteriors and to that of the maxillary sinus floor, infection in this region may affect the maxillary sinus, leading to the thickening of the maxillary sinus mucosa. The aim of the study is to assess the thickness of the mucous membrane lining the maxillary sinus and to correlate this thickness with the presence or absence of periodontitis by using CBCT. The methodology, 231 CBCT images were evaluated for the following parameters in terms of age, gender, ulnar bone loss graded as mild, moderate, and severe, maximum mucosal thickness, and minimum residual ulnar bone height. Minimum residual ulnar bone height is graded as less than 4 mm for minimum and moderate for 4 to 10 mm and greater than 10 mm for severe. And type of defects are horizontal and vertical defects and type of periodontitis. The presence of mucosal thickening of greater than 2 mm of the maxillary sinus was recorded. The data was analyzed using logistic regression and multivariate linear regression analysis with a significance level at alpha value of 0.05. The results of the present study revealed that mucosal thickness was present in 74.4% of the analyzed CBCT images and increased in frequency as the periodontal status of the corresponding molars and premolars progressed from mild, that is 67.4%, to moderate 80% and to severe 87.2%. Mucosal thickness was significantly increased in cases of residual ulnar bone height of 4 to 10 mm with an odds ratio of 0.104 and a significant p-value of less than 0.001. And for greater than 10 mm, it's an odds ratio of 1.29 with a significant p-value of 0.001. Multivariate linear regression revealed that ulnar bone loss and minimum residual ulnar bone height had a statistical significance influence on maximum mucosal thickness with a p-value of less than 0.001. To conclude, the increase in the mucosal thickness is associated with severity, distribution of periodontal disease, and horizontal bone defects. Thank you.
Okay, so how do you translate your study into a clinical setting?
So
how can you use your study in a clinical setting? I mean to ask.
Sir, by assessing the mucosal thickness in cases of when there is severe periodontal disease where the tooth has to be extracted, again implant placement needs to be done. Then mucosal thickness will be a hindrance, sir. For that, it might be helpful, sir.
Only for implant, but the study is not regarding implant, right?
No, sir. It is to assess the
The study is
mucosal
related to
thickness.
periodontitis.
Yes, sir. It is related to
Yeah.
assess mucosal thickness, sir.
Okay, thank you.
Go on.
Okay, ma'am. Next presenter, please.
Good morning. Am I audible to all?
Yes, go ahead.
Okay. The topic for my poster is the comparison of the effectiveness of a peroxide-based mouthwash versus a honey-based mouthwash in gingivitis patients over the period of 21 days. As we know, gingivitis is a specific inflammatory response of the gingiva to the dental plaque where there is no loss of periodontal attachment. There are several compounds that may help in combating this disease. Two of them that I'll be discussing today is honey, which possesses distinct flavonoid compounds, and hydrogen peroxide, which has nascent oxygen releasing effects. Basically, the objective of this study was attempting to evaluate the effectiveness and efficacy of these two mouthwashes in gingivitis patients over a period of 21 days. A total of 40 patients were recruited from the OPD and were divided randomly into two groups of 20 each. One group was administered the hydrogen peroxide mouthwash, while the other was given the honey-based mouthwash. Both were to be used twice a day after brushing for a period of 21 days, as mentioned. The inclusion criteria included those patients between the ages of 18 to 35 years of age, of both genders, suffering from gingivitis, having a minimum of 24 teeth present, who was systemically healthy and had no clinical attachment loss or any pockets greater than 5 millimeters. Patients who had any processes or appliance, those suffering from any systemic disease, having any known allergy to any of the mouthwash components, patients who had poor compliance or those on antibiotic therapy for the last 6 months, and pregnant and lactating females were excluded from the scope of this study. The criteria that were measured were taken at baseline, the 7-day and the 21st day intervals. The indices measured were the Turesky modification of the Kugelheim plaque index and the modified gingival index given by Lorraine. At the end of 21 days, statistical analysis was done using the SPSS 20.0. ANOVA was done and paired t-test was also done with intragroup and intergroup comparison. Basically, the results showed that the intergroup analysis among the study groups of plaque index, that there was no statistically significant difference with a p-value of greater than 0.5. However, at the end of the 7-day, it was observed that when the group A mouthwash, that is the peroxide mouthwash, was compared to the group B or honey-based mouthwash, there was slight significance where p-value was less than 0.5. Again, the intergroup analysis among the groups of gingival index showed that there was statistical significance, no significance from baseline 7, and the p-value was not significant except for the 21st day. Basically, to summarize these results in a succinct way, I would like to say that at the end of 21 days, it was seen that both mouthwashes were equally effective in reducing gingivitis in all the patients. However, if we were to take it over a period of shorter time, that is 7 days, we would see that the hydrogen peroxide mouthwash is seen to be more effective compared to the honey-based mouthwash, and more extensive studies are required basically to evaluate their efficacy over a longer period of time.
Okay. I just want to, you have compared hydrogen peroxide with a honey-based mouthwash, right?
Yes.
So what is the justification for that? None of them, neither of them are the gold standard. It would have been better,
No,
right, if you had compared one of them with chlorhexidine.
It would have been, actually there
What
are
is the
many.
rationale for using those two?
The rationale is basically, there is a lot of literature actually out there in which chlorhexidine, which is the gold standard, as you said, has been compared to several mouthwashes. But hydrogen peroxide, although it is mainly used as a bleaching agent, there's not a lot of literature comparing it as a mouthwash. But it is actually very effective in the 1 to 3% range, because hydrogen peroxide is a very effective antimicrobial agent due to its nascent oxygen releasing effects. And honey, we already know, is a potent anti-inflammatory. It contains many flavonoids, such as chrysalin is one of those flavonoids, which helps in regulating the COX pathway and basically blocks all the prostaglandins. So I thought these were very two interesting mouthwashes, and I wanted to know that comparing them, what the results would be.
But how do you correlate the results when you don't have a gold standard with you? You're getting my point?
Yes, sir.
That
Could be said that is one drawback.
Yeah. Anyhow, thank you.
Yes, sir.
Now both are known to be having antibacterial effectivity, right? The hydrogen peroxide as well as honey. So what new thing have you done in this? What is the point in searching again for the antibacterial effect?
Ma'am, both of them have antibacterial effects, but both of them, the mechanism of action in which both of them work are slightly different, because the hydrogen peroxide mouthwash works by releasing, basically the main ingredient in that is sodium peroxide. Basically, it releases hydrogen peroxide when it reacts with the saliva. And we know it works by releasing the nascent oxygen, which basically lyses the cell.
That's what I'm saying. Already it is a known thing.
Yes.
Already it is a known thing. So what innovative thing you have done by doing this?
Well, their mechanism, as I said, the mechanism action of both were different. I just wanted to see that whether
you have not studied on the mechanism of action by doing this study, right? Already mechanism of action is given.
Yes, ma'am.
First study is not concentrating on that.
Yes, ma'am.
Right. So antibacterial effect is already known. So what innovative thing is there in this? Because honey also has been used in so
as an
many
anti-inflammatory. Yes,
hydrogen peroxide is known to be an antibacterial and it is already using in perio. So what innovative thing you have done in your study?
Now, basically, it's because I wanted to know, basically, it is said that in my study, the mouthwash that is used, it releases around 0.03 to 0.15% hydrogen peroxide. In many of the literature, it's given that the ideal amount of peroxide that should be used for antimicrobial action is between 1 to 3. So basically, I wanted to see that even in slightly lower amounts, is it equally effective when compared to honey, which is a known potent anti-inflammatory mouthwash.
Then you should have tried for various concentrations of hydrogen peroxide.
Yes, ma'am. That again is another drawback of the study.
Okay. Go ahead.
Thank you, ma'am. Next presentation, please.
Okay, ma'am. A very warm good morning to all the respectable delegates. Today, I would like to present a poster on clinical research conducted in our department, which is titled as Evaluation of Efficacy of an Indigenously Developed Chlorhexidine Chip as an Adjunct to Scaling and Root Planing in the Treatment of Chronic Periodontitis, a short-term study. Coming to introduction, although scaling and root planing is an effective non-surgical periodontal therapy for chronic periodontitis at early stages, limitation to proper instrumentation in inaccessible areas compromises the effectiveness of SRP. This led to the use of various antimicrobial agents as an adjunct to SRP, assuming that these agents would aid to treat the dysbiosis which is found in inaccessible areas and thereby prevent the microbial colonization and promote clinical benefits. These agents can be given either locally or systemically, and locally delivered antimicrobial agents have been preferred over systemic agents because these are associated with less systemic side effects. Out of various agents, chlorhexidine is one such potent anti-infective and antibacterial agent and is considered as gold standard. So when this chlorhexidine is delivered in the form of a chip, it exhibits controlled release of drug and thereby show more clinical benefits. So this study was mainly conducted with an aim to clinically evaluate the use of biodegradable chlorhexidine chip as an adjunct to scaling and root planing in the treatment of chronic periodontitis. So in this study, 10 patients with at least 2 sites with a probing pocket depth of 5 to 8 mm were included. A written informed consent was obtained from all the participants after explaining the study protocol, and all the sites were randomly allocated into test group and control group. In both the groups, baseline evaluation was performed, followed by thorough scaling and root planing. So the SRP was performed in both the groups, and then in the test group, in the area of the pocket, local infiltration was given, and sulcular incision was given, and surgical pouch was created. An indigenously developed chlorhexidine chip, it was inserted into the surgical pouch, and it was condensed. And In this study, the plaque index, probing pocket depth, and clinical attachment level were considered as primary outcomes. These were measured at the end of 3 months, 6 months, and they were compared with that of the baseline values in both test group and control group. In the control group, only plain SRP was performed. So coming to results, when compared to baseline, statistically significant differences were observed in between both test and control group in terms of probing pocket depth, plaque index, and clinical attachment level at the end of 3 months and 6 months. So coming to conclusion, it can be concluded that chlorhexidine chips provided clinical benefit beyond what can be achieved with SRP after 3 months and 6 months period, and hence chlorhexidine chip can be used as an adjunct to scaling and root planing in chronic periodontitis cases. Thank you.
From where did you procure these chlorhexidine chips?
Ma'am, we have developed this chlorhexidine chips formulation from a chitosan base, ma'am. So we have embedded 2.5 milligram of chlorhexidine in a matrix, which is the main vehicle was chitosan.
Whatever chlorhexidine chip you have formed, how is it different from the commercially available? How is it advantageous?
Ma'am, because the carrier vehicle is chitosan, it is a natural extract, ma'am. So it will help in preventing some of the side effects which are associated with commercially available chips like perio chip, etc.
I don't think a commercially available chip has any side effects. Are there any studies like that? Yes. See, using of chlorhexidine chip is a known thing, but you have formed it. So how it is different from the commercially available chlorhexidine chip?
In the commercially available, like in perio chip, it consists of 2.5 milligram of chlorhexidine, which was embedded in gelatin matrix, ma'am, glutaraldehyde. But here we have gone for naturally extracted product like chitosan vehicle, which proved to be beneficial.
Apart from that, anything else? Any other advantages which you have formed as got? No, there should be some reason for doing those chips. If it is already available, not having any problems, then why go for the preparation of our own chips? Is it cost effective or easily available or added
Definitely
advantage?
it is cost effective, ma'am, and placement of the chip also becomes easy. And
so if there is a drastic difference between the cost, definitely you can use this.
Yes, ma'am. Definitely
there has to be some reason, no?
Yes,
okay, go ahead.
Okay. Thank you. Go ahead.
Thank you. Next presenter, please.
Good morning to all the respected delegates. Topic for my poster presentation is on clinical effects of a single application of a novel photosensitizer in the treatment of chronic periodontitis. Coming to introduction, scaling and root planing is considered as the gold standard treatment for periodontitis. However, scaling and root planing instrumentation techniques are not always efficient in eliminating the microbial and mineralized deposits in more severe cases of the disease. Antimicrobial photodynamic therapy, a new adjunct to mechanical treatment, has been investigated to offer better outcomes by reducing bacterial load, eradicating periodontopathic pathogens, and prevent subsequent recolonization. Use of photodynamic therapy is one of the promising approaches as it uses generated reactive oxygen species to kill microbes, and that offers a low risk of bacterial resistance. Phthalocyanine is one such photosensitizer with high quantum yield, increases its efficiency to generate singlet oxygen and high binding affinity to microbes. And it is also known to show promising antimicrobial photodynamic therapeutic properties. So the aim of the study was to evaluate the periodontal outcomes after applying antimicrobial photodynamic therapy with a novel photosensitizer as compared to laser-assisted scaling and root planing. 24 systemically healthy male and female patients of age 30 to 60 years with generalized probing pocket depth indicative of chronic periodontitis with at least 2 sites with probing pocket depth greater than 5 millimeters in each quadrant were included in the study. Split mouth design was followed, and the selected sites of different quadrants were randomly allocated into test and control groups. In test groups, after scaling and root planing, aluminum phthalocyanine dye was applied with a blunt needle starting from the bottom of the pocket and gently moving coronally and left in contact for 1 minute. Then the area was irrigated with a saline solution and irradiated with a diode laser of wavelength 18 nanometers and output power 100 milliwatts at 6 sites per tooth for 10 seconds each side. While in the control sites, laser-assisted scaling and root planing was performed. Clinical outcomes, probing pocket depth, clinical attachment level, and bleeding on probing were evaluated at baseline 3 and 6 months after the treatment. Coming to the results, all the periodontal parameters were significantly improved in both test and control sites at 3 and 6 months after the treatment. Reduction in probing pocket depth and clinical attachment level gain were significantly greater in test group when compared to that of the control group at 6 months following the therapy. Based on these findings, it can be concluded that application of antimicrobial photodynamic therapy with a novel photosensitizer as an adjunct to conventional mechanical treatment had additive effect over laser-assisted scaling and root planing alone. Thank you.
Whatever photosensitizer you have used, how new it is? You have written novel. Has it been not used before?
No, ma'am. Actually, various types of photosensitizers were used, but aluminum thiocyanine dye was most commonly used in eliminating the cancer cells, ma'am. In dentistry, there are very few studies which have been conducted, ma'am.
Has it been used in periodontal therapy earlier?
Yes, ma'am. Very few studies, ma'am. 1 or 2 studies.
You are saying novel. So how do you justify this?
Because it's usually used in the medical field, ma'am, for eliminating the cancer cells.
No, if there are already studies in perio, then how are you putting it as novel photosensitizing agent? Yes, good.
Yeah, go ahead.
Okay, thank you. Next presenter, please.
Good morning, ma'am. Am I audible?
Yes.
Good morning to one and all. The topic of my today's presentation is comparison of glucose levels in gingival, clavicular, venous, and fingerprint blood, a clinical study. As we all know, diabetes is considered as a major risk factor in periodontitis, which is about 3 times higher than in the non-diabetic patients. Long-term favorable prognosis of periodontitis exists when the diabetes is detected and treated in early stages, in which a dentist can play an important role in the cases of undiagnosed asymptomatic diabetic cases. The objective of this study was to evaluate whether the random blood sugar levels of the gingival, clavicular, capillary, and the venous blood are comparable or not. In this study, 30 patients aged equal to or more than 30 years with gingivitis or periodontitis having at least one side with bleeding on probing in maxillary anterior teeth were included in the study, whereas the patients who were smokers and on the antibiotics for past 1 month, also having inadequate amount of gingival blood which could not be sourced after routine periodontal probing were excluded from the study. The methodology used here was after routine periodontal examination, gingival clavicular blood oozing from the most easily accessible bleeding site of the maxillary anterior teeth was collected with the help of strips of the glucometer, and readings were observed. From the same patient at the same time, finger prick blood samples were taken and analyzed for RBS with glucometer. And the third sample, which was taken at the same time from the same patient, was the intravenous blood was drawn by using a disposable syringe from the antecubital fossa and sent to lab for the analysis. In this study, it was seen that non-significant differences in the mean value, in the mean amounts of RBS between GCP and FP finger prick blood were there, and whereas significant differences between finger prick and IV and GCP and IV blood sugar were observed. However, it was concluded that highly significant relation was seen between the the samples between the GCD and finger prick, and finger prick and IV blood samples, and GCD and IV blood samples. And it was concluded that GCD can be used as effectively as finger prick for the estimation of RPS. Hello.
Yes, we can hear you.
Yeah, so in this study, we have concluded that the finger prick, the GCD can be used as effectively as a method we use as a finger prick for diagnosing diabetes as a chairside method.
Okay. Ma'am, Dr. Manoj, any questions?
I can go ahead. Thank you.
Okay. Next presenter, please. Please start. Dr. Sai Shreya, Dr. Gowda, anybody?
Hello, ma'am. This is Shreya, ma'am, but this is not my poster. My poster number is 46.
46.
My name is also Shreya, but this is not my poster.
Okay.
But it's showing as 42. My name is showing as 42.
Is this your poster?
Not my poster, ma'am.
Not your poster, right?
No.
Okay. Okay, you are 46. No, this is 42.
Yes, ma'am.
Okay. Can we keep this on hold? Next presenter, please. I think Sai Shreya and Gowda is not present. Can we have the next poster? 43.
Can I start? Hello.
Yeah. Hello.
Yes.
Yeah. Please start.
Good morning. Good morning, ma'am and sir. My study title is the cocoa bean extract in a combination with the COPAC after the flap procedure, a randomized clinical trial. The conventional periodontal resin, like the COPAC, only provide the mechanical barrier, and that doesn't affect the biological event that occur during the healing phase. Thus, the researchers in the recent years have been in a continuous search of the safe and natural compounds which provide the tissue healing and which can be added with the periodontal resin. So the cocoa bean is a non-toxic natural material which enhances wound healing and also also shows the anti-inflammatory, anti-plaque activity. The aim of the study is to assess the efficacy of the cocoa bean extract in a combination with the co-packed dressing on the wound healing after the flap procedure. The preparation of the 15% cocoa bean by the cocoa bean were pounded into the mortar and pestle. Then the cocoa bean were dissolved in the ethanol. Then the ethanol soluble compound were collected by the evaporation, and the 50% of the cocoa bean solution obtained by the redissolving in the ethanol solution. The inclusion criteria where the subject indicated for the periodontal flap surgery, systematically healthy patients suffering from the generalized moderate to severe periodontitis and a plaque and gingival index less than 1. Exclusion criteria were the pregnant and lactating woman, patient taking antibiotic medication, subject with the history of the cocoa bean allergy. In total, the 20 patient, the total in the 20 patient, the periodontal flap procedure was performed, and they were randomly divided into the two groups, test group and the control group. And in the test group, the with the co-pack cocoa bean extract was added, and in the control group only co-pack dressing was given. And all the patients recall after the 7th day, and at the 7th day wound healing index was evaluated for the both group. The statistical analysis was done by the chi-square test, and the wound in the result, in the test group, the 2 patients shows the good and the 8 patient shows a very good wound healing index score, where the control group 1 patient shows the poor, 7 patients showed the good and very good, and the 7 patients showed the good and the 2 patients showed the very good result. The results showed that significant improvement in a wound healing index at the 7th day when cocoa bean extract was added as a parental dressing. Now, this study is in accordance with the study done by the in vitro study done by the Ahmed et al. In the 2015, who showed that the addition of the 15% cocoa bean extract in a periodontal dressing potentially increased the speed of the wound healing by increasing the fibroblast cells in the rabbit gingival injuries. It can be concluded that the cocoa bean extract can be combined with the co-pack and can be provide the additional wound healing benefits. Thank you.
Why didn't you use this in gingivectomy cases?
Oh.
Where plaque the periodontal plaque placement seems to be more indicated in gingivectomy than the flap. Why didn't you try this in gingivectomy? Because you are saying it helps in wound healing.
My key article, which was done in 2015 by the Mehta et al. They have done in the flap procedure. So I also had done in the flap procedure.
Then you should have made a changes. No, you could have tried this in gingivectomy.
Gingivectomy.
Yes. Then you could have tried this in gingivectomy when they have already done in flap.
Yeah, yes, ma'am. They have used propolis as a propolis. I have used the cocoa bean. We can use with I can done this in the gingivectomy patient also.
Okay. Sir.
Okay, go ahead. Thank you.
Okay, next presenter, please. 4.
Good morning, everyone. My title for the poster presentation is an evaluation of anti-plaque and anti-gingivitis effect of herbal and non-herbal mouthwash in the treatment of plaque-induced gingivitis. Introduction. Gingivitis, it is a non-destructive type of periodontal disease, but if untreated, it can progress to periodontitis. Using mouthwash, in addition to the regular brushing and flossing, can help prevent the gingivitis by killing the bacteria responsible for these conditions. The aim of the study is to compare the efficacy of herbal mouthwash, that is Feel Fresh, and non-herbal mouthwash, Hexidine, in the treatment of plaque-induced gingivitis. Methodology. A total of 120 patients with plaque-induced gingivitis were selected and equally grouped into 2 groups. Group A, treated by scaling, followed by the usage of the herbal mouthwash, and Group B patients treated by scaling, followed by the usage of the non-herbal mouthwash. And then the patients are instructed to use the mouthwash 10 ml for 30 seconds twice daily after the food. And then the patients in the group, both the groups are evaluated for the clinical parameters, that is the plaque index, gingival index, and sulcus bleeding index at the baseline and 21st day. The inclusion criteria included in this study are the healthy patients between the age group of 20 to 45 years, and a minimum of 20 teeth should be present in the dentition, and bleeding on probing should be present clinically, and the participants should not be involved in any other study. Exclusion criteria is a patients who received any periodontal therapy from the past 6 months and the patients who had received any antibiotic therapy in the previous 3 months. Results, there is no significant difference between group A and group B, showing that herbal and non-herbal mouthwash were equally effective in reducing the plaque and gingivitis. Conclusion, herbal mouthwash can be considered as a good alternative as it can overcome the few disadvantages, that is the side effects of non-herbal mouthwash. Thank you.
What are the components of that herbal mouthwash which you have used?
The herbal mouthwash Feel Fresh, it contains almost 22 different herbs.
Main ingredient, few.
It contains many herbal like eucalyptol, neem, babul, etc., which has many properties like antibacterial, and few it acts as a natural painkillers, etc.
So all these have been already used. This is a very primitive study. This has already been established. Have you done something new in your study? This hexidine and non-herbal, sorry, herbal versus non-herbal. Have you done something new? Or has this herbal mouthwash, does it have any component which has never been used before?
It contains a few new herbs.
Like that's what ma'am is asking, no?
Like babul, which will strengthen the gums, etc.
Has never been used before?
It's already tried.
Yeah, it has been tried.
Okay.
Anyhow, okay, thank you.
Okay, sir, thank you. Thank you, ma'am.
Thank you. Next presentation, please.
Good morning, everyone. So my title for my poster is Curcuma longa, a boon to periodontal health. So my objective was to compare the effect of commercially available 10 milligram curcumin gel with scaling and root planing, and scaling and root planing alone on different clinical parameters of chronic periodontitis patients. So starting with a little introduction, periodontal disease, it's a chronic inflammatory disease which is characterized by the destruction of the supporting structures of teeth. The primary etiologic factor is the dental plaque and the microorganisms present on it. There are various treatment modalities for reducing the periodontal inflammation, which can be surgical or non-surgical periodontal therapy based on its severity. So recently, there is renewed interest in the use of the various herbal and Ayurvedic medicines for oral and dental health, such as neem, turmeric, pomegranate, mango, aloe vera, etc. Currently, Curcuma longa, it has been generating much interest because of its anti-inflammatory, antimicrobial, antioxidant, anti-cancer properties. So, coming to the study design, patients with chronic periodontitis, more than 30% sites with mild clinical attachment loss of 1 to 2 mm and pocket depth of 4 to 6 mm were included. So on the basis of inclusion criteria, 15 patients were recruited for the study and were divided into test group and control group. Test group where scaling and root planing plus local drug delivery was done, and in control group only scaling and root planing was done. Which was done at baseline. Then oral hygiene instructions were reinforced and clinical parameters were re-evaluated at 1 month. So the results showed that the gel did not have any adverse reactions, and all the clinical parameters such as plaque index, sulcus bleeding index, pocket probing depth, and clinical attachment loss were all evaluated at baseline in 1 month, and which showed significant reduction of the parameters for both the groups, where there was slight but not statistically significant reduction in mean cal levels in test group than the control group. So discussion, curcumin defluoromethane, which has the anti-inflammatory, antioxidant, and antibacterial properties. It modulates the proliferation and cellular response of various immune cells, and it reduces the inflammation effectively by inhibiting the transcriptional and translational expression of pro-inflammatory cytokines such as interleukin-6 and TNF-alpha, and it promotes the epithelial migration, inducing the transforming growth factor beta-1 and thus inducing reepithelialization.
So I would like to conclude by saying that curcumin, it showed a more profound effect in treatment of chronic periodontitis and was efficient in reducing the gingival inflammation, and subsequent improvement in the clinical parameters from baseline to 1 month, thus opening a new avenue for treating by the use of the herbal products. Thank you.
Okay, so you have mentioned that curcumin has antibacterial and anti-inflammatory properties.
Yes, sir.
Did you do some microbiological assessment or any inflammatory markers? Did you check that pre and post?
Yes, sir, that could be, I could have added any biomarker or microbial analysis could have been done, sir. It would be my limitation, sir.
And how do you justify its antibacterial role?
Sir,
if you have not done any microbiological assessment, how do you say it has antibacterial effect?
So because there was study done by Nagashri where they have done the microbial analysis and they have seen effect on P. gingivalis and A. acetomycetum comitans, and where they have seen there is reduction in the microbial load.
Yeah, but you have not done that. That's what I'm asking. How do you justify the antibacterial effect which you have mentioned without doing any microbiological assessment?
So that's why it was done. The study was already done, but then I was looking after the anti-inflammatory effect, but then it would be my limitations, that I didn't do the microbial analysis.
Even not, you have not done anti-inflammatory also, right? Have you checked any parameter like TNF-alpha or anything?
Sir, I have checked.
You have checked?
Attachment loss and pocket depth, I've checked, sir.
Yes, sir. That can be with SRP alone. How do you justify the role of curcumin?
So yes, sir, because studies were done already with that, and comparison was done with onidazole and chlorhexidine, but I was just checking for curcumin gel, sir.
Okay, thank you.
Okay.
Thank you.
Next presenter, please. Can we start?
Yes. Hello, am I audible?
Yes.
Good afternoon, respected judges. My poster presentation is Association of Obesity and Periodontal Status, a cross-section study. So, introduction, the American Academy of Periodontology 2018 consensus report had stated obesity as one of the systemic diseases that influences the pathogenesis of periodontal disease. The periodontal influence surface area, that is PISA, is a tool which is used to recognize and estimate the estimate periodontitis as a risk factor for other diseases by quantifying the amount of the inflammatory burden which is imposed by the disease itself. So obesity is defined as the accumulation of superfluous amounts of fat in the body to a degree that may debilitate health and is identified by body mass index. The PISA tool and the BMI will help in the effective screening, earlier prevention and treatment of periodontal disease.
हाँ तो मतलब पता नहीं उनको वो सब satisfy हुए
periodontal disease.
एंटीबैक्टीरियल इफेक्ट तुमने कैसे कर लिया अगर तुम
sorry ma'am. Hello ma'am, can I continue?
You please continue.
Sorry. So using the PISA and the BMI tools would help in earlier and effective screening and prevention of the periodontal disease as well as obesity by leading to an earlier diagnosis and prevent further progression. So the main objective of the study was to assess an association between obesity and periodontal status. So in the current study, 198 subjects were screened initially, and then the BMI was recorded for each of the patient using the ratio of weight by height, in which kg per meter square ratio was used. Then once the BMI was recorded, each subject underwent periodontal examination, and the subjects were divided into two groups, that is A and B. based upon the BMI, the subjects were divided in 3 groups. First was the normal weight group, second was the overweight group, and third was the obese weight group. These further underwent periodontal examination, and they were again subdivided into gingivitis and periodontitis groups. Once that was done, the PISA scores were calculated using the preformed Excel sheets which are already pre-prepared. Once that was done, the statistical analysis was done so as to correlate between the BMI and the PISA scores. So as per the analysis which was done, there was a highly, with the increase in amount of PISA score, increased amount of BMI was noted. So basically there was a statistically significant difference which was seen between and a moderate positive relationship which was noted down between BMI and PISA values, which was basically statistically significant. Also, the intergroup among all the groups, it was shown that the highest values of BMI done.
Have you finished?
Did you assess any biomarkers?
Sorry, ma'am, could you please repeat?
Did you assess any biomarkers?
No, ma'am, no biomarkers were assessed. This was strictly the main rationale behind this study was to use these PISA and BMI as as an initial screening tool, so that it would help in a effective and earlier cost-effective diagnostic tool, ma'am.
Okay.
Okay.
Thank you, sir.
Okay, next presenter, please.
Good morning, respected dignitaries and fellow PGs. I am Dr. Visha, presenting assessment of periodontal status in patients reporting for dental therapy post-recovery from COVID-19 infection and observational study. COVID-19 is caused by SARS-CoV-2 belonging to the beta coronavirus family. Association of COVID-19 and periodontitis exists by two pathways. First is a direct link through which the ACE2 receptors and CD147 receptors through which the virus enters and infects the cells. This is increased in case of periodontitis and favoring the severity of COVID infection. The other mechanism is the indirect mechanism of release of inflammatory mediators such as IL-1, 2, 6, 7, 8, 10 and TNF-alpha in case of cytokine storm. And the main objective of my study is to assess the possible interrelationship between patients who have untreated periodontal diseases and the severity of COVID-19 infection in patients who have recovered from the disease. Materials and methods of my study includes 70 patients post-recovery from COVID-19 infection. All the participants in this study read and signed an informed consent. The study duration was conducted for 3 months from July 2021 to September 2021. And the patient criteria was 3 to 6 months post-recovery from COVID-19 infection. The COVID severity criteria included clinical management protocol by National Institute of Health US and Ministry of Health and Family Welfare India. Periodontal diagnostic criteria included AAP 2017 classification, and the periodontal parameters such as PISA index and OHIS scores were recorded, and a statistical analysis was done. Moving on to the results of my study, in graph 1 on comparison between periodontitis and COVID, stage 1 periodontitis corresponded with significantly with mild COVID and incidence of moderate COVID. Stage 2 periodontitis corresponded with moderate COVID. Stage 3 periodontitis correlated with moderate and severe COVID, and stage 4 periodontitis was significantly only associated with severe COVID. In graph 2, on comparing COVID severity and PISA score, with gradual increase in PISA score, the increase in COVID severity was noted. So therefore, a positive correlation was attained between COVID severity and PISA score. The graph 3 represents COVID severity and OHIS score with mild, moderate, and severe COVID. The OHI corresponded directly to good, fair, and poor status of the hygiene. To discuss between the periodontitis and COVID-19, the increased prevalence and severity of periodontitis and associated poor oral hygiene might contribute to the aggravation of SARS-CoV-2 infections. A study by Maruf et al. 2021 reported that patients with severe periodontitis are more likely to develop complications associated with COVID-19 than patients with milder forms of periodontitis. Larvin et al. 2021 concluded that it is essential to assess the oral health status of patients with COVID-19 in order to prevent adverse outcomes. Within the limitations of this study, it is concluded that there is an association between poor oral hygiene, untreated periodontitis, and severity of COVID-19 infection. The take-home message from my study is that since an association exists between the periodontitis and COVID-19 infection, it is important as periodontitis that we provide a periodontal therapy and educate the patients with oral hygiene measures and in order to prevent further outcomes. Thank you.
So, what are the limitations of your study? Sorry, ma'am. Yeah.
Fine.
So,
how do you establish the connectivity?
Okay, you can first answer, ma'am. Just let
so we are establishing the connectivity based on the severity. And we have taken from the study that patients who have existing periodontitis based on their history and the patients who have got COVID and who have reported for periodontal therapy or any dental therapy as such. So based on their results, we have studied as mild and moderate and severe COVID. So assessing the status of the COVID.
My question is, how do you establish the connectivity between the COVID and the periodontitis?
Based on PISA score and OHIS score, based on PISA score, there was a gradual increase in PISA score with the increase in severity of COVID. And based on the hygiene of the patient, with the increase in severity of COVID, the oral hygiene status also differed.
Any mechanism?
We have seen we have not taken IL-6 test, but in the test reports by the patient who have been hospitalized, the patients who had moderate and severe COVID were possibly under the cytokine storm. So therefore, we could say that periodontitis could have influenced the cytokine storm.
After how many days the patients were checked for periodontitis?
3 to 6 months post recovery from COVID-19 infection.
Okay.
Okay, good. Thank you.
Thank you, sir.
Okay. Next presenter, please.
Good morning, everyone. I'm presenting an original research poster on quantification of Candida albicans in plaque samples from periodontal pockets of diabetic patients with varying glycemic levels, a cross-sectional study. The entire study was based on the research question: does the amount of Candida albicans in plaque samples from periodontal pockets of diabetic patients vary with varying glycemic levels? Aim was assessment of the correlation of gingival inflammation and presence of Candida albicans in periodontal pockets of diabetic patients with varying glycemic levels. Aim of the study was extended to the following 3 objectives: to identify the presence of Candida albicans at different depth of periodontal pockets in diabetic patients with varying glycemic levels, to quantify Candida albicans in shallow to deep periodontal pockets of patients with varying glycemic level by total plate count technique, to assess and correlate the inflammatory status of periodontal pockets and amount of Candida albicans present at different sites in diabetic patients with varying glycemic level. Coming to the methodology, 48 sample sites were taken with varying SbA1c level and periodontal pocket depth in diabetic patients. Plaque samples were collected from periodontal pockets and cultured for mycological assay. And results are tabulated in the following graphs. Research answer: the present study failed in establishing any kind of relationship between diabetic status and Candida albicans in terms of its presence and quantity at various depths of periodontal pockets in patients with varying glycemic levels. Clinical implication: the present study ruled out the presence of opportunistic fungi, Candida albicans, in plaque samples of diabetic patients collected from varying depth of periodontal pockets in patients with controlled and uncontrolled diabetes. Thank you.
Dr. Manoj, you can ask.
Dr. Manoj? Ma'am, I think...
yeah, go ahead.
Okay, okay. Next presenter, please.
Good afternoon, respected judges. Myself, Dr. Sustiandika Sahu, will be presenting a poster on the topic of application of plasminogen growth factor in the management of intrabony defect. It is an intrabony defect is an outside defect with definite morphology surrounded by the three sides with the tooth root and forming the fourth one. Plasminogen growth factor is a mixture of autologous protein and growth factors prepared from a certain volume of platelet-rich plasma obtained from a small volume of blood which does not contain leukocytes. My aim of the study is to evaluate the clinical and radiological efficacy of the PRGF in addition to the open flap debridement compared to the open flap debridement alone for the management of the periodontal intraosseous defect in the periodontitis patient. Coming to the material and methods, it is a split mouth double-blinded randomized clinical trial and the 20 patients with 40 sites suffering from the grade A or B and stage 2 or 3 periodontitis. And the patients were included in the study having the age range of the 30 to 50 years, having systemically healthy and present of 2-walled or 3-walled intrabony defects more than 3 mm, along with an intraproximal probing depth of more than 5 mm following the phase 1 therapy. And this is the picture showing the PRGA preparation, and this is the clinical of surgical procedures, and this is the control side which is treated with the open flap debridement alone. And this is the picture showing the treatment of test and which is the open flap debridement followed by the application of the PRGF. And this is the radiographical picture showing the baseline and 6 months of the test site. And see the after 6 months how the amount of bone achieved by the application of the PRGF. And the clinical outcomes like plaque index, gingival index, radiological parameters like intrabony defect area, etc. And patient reported outcomes like swelling, bleeding in the treatment area and level of pain assessed. And the table represent the clinical success criteria according to the Cochrane et al. 2016, that is the clinical attachment level changed by 1.5 mm and linear radiographic bone gain by 1 mm. So the 50% of the PRGF treatment sites show the clinical success rate. But in case of open debridement group, it shows only 15% success rate, and the result shows that there is reduction in the pain at the day 6 in the PRGF group, and there is radiographic bone gain was significantly higher in the PRGF group after 6 months. On conclusion, PRGF was found to be beneficial in terms of improved clinical attachment gain and radiological bone gain when compared to the open flap debridement for the management of periodontal intraosseous bone defects. Thank you.
What was used in the control group?
Control group was only treated with the open flap debridement only. No other intervention.
Why didn't you go for any other material?
Because here only I want to see the efficacy of the plasma rich in growth factor, efficacy of that. So that's why.
No, but when you are comparing, when you are doing only with the flap surgery, we don't see much of regeneration. It's already known thing. So why didn't you compare with some other material?
This was one kind of limitation.
Some positive control should have been there.
No, ma'am, no positive control.
How does it help? This material?
Because it have the growth factors. The material is rich growth factors, so it helps. The growth factors helps in the regeneration process by activating the growth factors. Like.
So you attained a complete regeneration?
No, ma'am, no complete.
What is regeneration?
It is the regeneration is the process of restoration of the periodontium like PDL, cementum, and medial cementum and dentin. It's the restoration of the periodontal semblance.
Okay.
Just to note for the judges, the presenter 42, she was missed out. So now she will be presenting post this 50th presentation. So ma'am and Dr. Manoj, please note, this is presenter number 42.
Okay.
Good afternoon, respected chairpersons. The title of my study is Clinical Evaluation of Injectable Platelet-Rich Fibrin for the Treatment of Gingival Recession Technique or Gingival Recession Defect. This is a novel, non-surgical technique to evaluate and compare the changes in Miller's Class 1 and Class 2 gingival recession from baseline to 6 months. As you can see, appreciate in the picture, the methodology includes first 10 ml of venous blood sample is taken and then it is transferred into IPRF plastic tubes. Again, it is centrifuged for at 700 RPM for 3 minutes. Then the topmost layer, which you can appreciate in the fourth picture, is the IPRF, which is loaded into the 30.5 gauge needle, the insulin needle, which is then injected at the recession sites. It was categorized into two groups. Group 1 includes 15 sites with Miller's Class 1 gingival recession, and Group 2 includes Miller's Class 2 gingival recession defects. Plaque index, gingival index, recession depth, recession width, and width of keratinized tissue was evaluated as clinical parameter at baseline and 6 months. A statistical significant difference was found between the groups with a higher increase in measurements favoring group 2, which is class 2 gingival recession, when compared from baseline to 6 months. There was also a statistical significant difference between the clinical parameter measurement in both the groups. Coming to conclusion, current results sustained from this study showed that injecting IPRF may increase root coverage even without surgical periodontal procedures. Further studies will be needed to clarify the new technique and those limitations. These are my references. Thank you.
How much did you inject?
Ma'am, the IPRF was injected at 5 sites, ma'am. 0.2 ml was injected into the mesial and distal papilla, and 0.1 ml was injected at the attached gingiva submucosal, and mucobuccal and distobuccal of the recession defect, supraperiosteal it was injected supraperiosteally, ma'am.
So did you attain the coverage?
Yes, ma'am. We have calculated root coverage percentage, ma'am. From 25% to 100% of root coverage we have seen, and in 1 to 2 cases we have seen 100% root coverage.
What is the mechanism? How do you say it is worked out?
Ma'am, once it is injected, the PRF makes a 3D scaffold in which these WBCs and platelets get trapped. These the white blood cells and platelets release the growth factors, which causes the action, which causes angiogenesis, collagen type 1 release, which causes the coverage of these recession.
So then it can be used even in class 3?
Ma'am, this is a novel non-surgical technique and it has never been done before, ma'am. We have done this study on the basis of the study done by Ali OH on PRP, platelet-rich plasma. So we have just tried on the recession defects of class 1, class 2, ma'am. Still, there are no studies done on class 3 recession, ma'am. There are studies done on gingival thickness, which was done by Osa Zagar, but on the recession, we have never, this study has never been done before. So we have tried on class 1 and class 2, ma'am.
Okay.
Okay.
So we come to the end of the presentations. I would like to extend my heartfelt thanks for giving the precious time to the judges. Thank you, Leena madam. Thank you, Dr. Manoj. Thank you all the delegates for being on time and wonderful presentations. I request the judges to please mail the evaluation sheets to the given mail ID as early as possible so that we can compile the other results as well.
Okay, thank you.
Thank you, everybody.
Excuse me, ma'am.
Thank you.
Hello.
Yes, tell me.
Ma'am, my poster number is 46.
46. Yes, I got to know your poster number is 46. But Shreya, we have seen it was not uploaded on the site. That is why it is not included in the list. Did you upload it?
Yes, ma'am, but it seems to be missing. I've
Because
sent.
we couldn't receive it. That is why it is not included in the list. We are extremely trying to check. That is why we couldn't put your name and the number in the subsequent list that is given to us. Still, let me just get back to you and confirm, and I'll just let you know, because just now when I spoke, the organizers have told us that your poster has not been received by them.
Okay, ma'am. I've sent it to you, ma'am.
Okay.
Again.
Okay. You have sent it to whom?
Ma'am, in the chat box. Just in case, I've sent it again.
You have sent in the chat box. It will be difficult, Shreya, right now to just upload that. Let me check with the team, and then I'll get back to you.
Is there any way I can contact you, ma'am?
Can contact me? Okay. I'll put you my number on the personal directly one-on-one to you. Okay. Yeah. Okay. Thank you, everybody. Thank you.
Mr. Sailesh?
Yes, ma'am.
So should we start with the next session?
Yes, ma'am.
Can you let in people for this session? CLR PO session 5. So very good morning, one and all present here. A warm welcome from the 45th ISP conference. This is poster session CLR PO5. For this session, I would like to welcome two eminent judges. Dr. Sabita Sudarshan ma'am. Ma'am obtained her UG and PG degree from the prestigious Government Dental College, Chennai. She has a teaching experience of over 30 years and she has guided nearly 40 postgraduate students. She has authored a book on evidence-based periodontology. Ma'am has various national and international publications to her credit. Welcome, ma'am, to the session. Ma'am, can you unmute yourself, please?
Madam, still not logging.
No, she's there in the name of Wales. Okay. Dr. Sabita ma'am, welcome to the session, ma'am.
Thank you. Now you can hear me, Sanghamitra?
Yes, ma'am. Yes, you're audible.
Yeah, right. Thank you for the
and pleasure, ma'am. Pleasure from here. The next judge for the day, Dr. Muthu Kumaraswamy A. Sir is a renowned periodontist. He is associated with the prestigious Government Dental College and Hospital, Chennai. Sir has about 17 years of teaching experience, and his expertise include dental implants, laser-assisted periodontal surgeries, and periodontal regenerative procedures. So we are honored to have you as well, sir, as one of the judge.
Thank you.
Okay, sir. So, Sailesh, shall we move on to the presentation? Shall we have the first poster for the day, CLR PO098? Saili, Dr. Saili, are you there?
Hello.
Dr. Saili, right?
Yes, ma'am. Yes, ma'am.
Please, can you switch on your video and start your presentation?
Yes, ma'am.
Yeah.
Hello.
Yes, please, go ahead.
Yes, ma'am. Ma'am, video has disabled by host, ma'am.
Satish, video has disabled the host now on this problem. Oh.
Yeah, now we are.
Hello.
Yes.
Good afternoon, ma'am.
Yes, good afternoon, Saili.
Hello.
Please start with the presentation. You're audible.
Yes, ma'am. Good afternoon, everyone. Title of my poster is Comparative Evaluation of Antibacterial Efficacies of Triphala and Propolis as an Adjunct to Scaling and Root Planing in Non-Surgical Treatment of Chronic Periodontitis, a randomized double-blind placebo-controlled clinical trial. It is a herbalism, an alternative method in treatment of chronic periodontitis. The aim and objective of my study is to evaluate the efficacy of locally delivered propolis and Triphala on Hello. In the treatment of chronic periodontitis. The objective is to evaluate the efficacy of locally delivered propolis and Triphala on clinical and microbiological parameters in periodontal treatment. In methodology, 21 patients were included in this study, where they were divided into 3 groups, that is Group A, Group B, Group C, and 21 were equally divided into 3 groups, like 7 patients in Group A, 7 patients in Group B, and 7 patients in Group C. Patients were randomly divided into these 3 groups. In Group A, SRP and distilled water as a placebo is used. In Group B, SRP and 4 ml of propolis gel were used. And in Group C, SRP and 4 ml of Triphala gel injected into the pocket site. Then clinical parameters like plaque index, gingival index, clinical attachment levels, and probing depth were measured after the 15 days, that is post operatively, and assessed, and subgingival plaque samples were collected at baseline, 15 days, and 1 month, and analyzed using BANA test. The results showed a significant reduction in clinical parameters with Group B and Group C while comparing at baseline, 15 days and 1 month in plaque index, gingival index, clinical attachment levels, and probing depth. Whereas Group B showed that is where we used propolis gel along with SRP, greater reduction in red complex bacteria on BANA strip compared to Group A and Group C, that is Group A, that is SRP with using distilled water as a placebo, and Group C where we used SRP along with 4 ml of Triphala gel which were injected into the pocket site. There were reduction in plaque index, gingival index, clinical attachment level, and probing depth in Group C were significantly shown. Then the conclusion of my study is propolis is more effective in reduction of the periodontal pathogens as compared to Triphala in periodontal pockets. The references are Coutinho et al. In 2012 and Nair et al. In 2018. Thank you. Thank you, ma'am.
Yes, what is this herbal therapy, as you said, as an alternative for Can it be an alternative for chronic periodontitis?
Hello.
Can it substitute treatment for chronic periodontitis or one of the modalities of treatment?
Ma'am, we can use as a substitute for the locally delivered drugs, as herbal drugs have less side effects as compared to traditionally used LDD agents.
All these herbals come and collectively under what medicine? It's called phytomedicine.
Hello, ma'am. I didn't get
phytomedicine. PHYT.
Yes, ma'am. It's a phytotherapy.
Yes.
Yes, ma'am. It's a phytotherapy.
Yeah.
Yes, ma'am.
Exactly. Okay. Right. Yes, Dr.
Yes, ma'am.
You can go ahead.
How did you standardize the amount of AAA or other drugs which you have used? Herbal drugs.
Sir, we use 4 ml of propolis and 4 ml of AAA gel injected into the pocket site, sir.
4 ml, how can you inject in a single pocket? Was it injected full mouth or only in certain sites?
Sir, pocket sites more than 4 mm and we were chosen for dispensing the local drug delivery, sir. 4 ml of AAA and minimum of 2 pocket sites were selected, sir, for injection of AAA and propolis gel.
4 ml, as sir was saying, as 4 ml as one stream. Would the site take up the drug?
It's going to come out of the pocket.
Exactly. 4 ml was too great a quantity at one injection. That's what sir is trying to tell you. Yes. Most of them will come out. Majority will leak out.
Ma'am, we use periodontal pack at the site where we injected, ma'am.
Okay.
To stay that gels.
Drug. Okay. Right. Okay.
Yes.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, Saili.
Thank you.
Can we have the next poster, please? CLR 2099. Raunak.
Hello. Hello.
Yes, you're audible. Please make your video visible too.
Yes, just a moment. Hello. Hello.
Yes, you are audible. Please start.
Yes, start.
Good afternoon, respected chairperson and everyone. The title of my poster is Evaluation of Minimally Invasive Piezocorticism Assisted Periodontally Accelerated Orthodontic Tooth Movement, a clinical study. The surgical procedure called periodontally accelerated osteogenic orthodontics, or popularly called as Wilcodontics, can be termed as an amalgamation of periodontics and orthodontics. A corticotomy is a procedure whereby the only cortical bone is cut, perforated, or mechanically altered in a controlled surgical manner, at the same time into the bone marrow, and the bone marrow only minimally. Regional acceleratory phenomena. The RAP is a local response of tissue to noxious stimuli by which tissue regenerates faster than normal in a regional regeneration or remodeling process. The aim of the study was to compare the orthodontic tooth movement with and without piezocorticism assisted periodontally accelerated technique, materials and methods. The 10 patients undergoing orthodontic treatment requiring extraction as a part of treatment was selected and divided in group A and group B. In group A, 10 quadrants with conventional orthodontic treatment, and in group B, 10 quadrant with piezo-corticism assisted periodontally accelerated orthodontic tooth movement were selected. The measurements between the canine and the premolar were taken at the baseline as well as after 45 days. In the group B, the microincision was made limited to the buccal side without flap reflection, through which piezo-corticism was performed. Result: post-operatively, group A and group B showed tooth movement, and group A showed tooth movement of 0.5 to 0.7 millimeter, whereas group B showed 1 to 1.2 millimeter tooth movement. Group B was more statistically significant compared to group A. Wilco et al. In his study concluded that corticotomy was facilitated orthodontic tooth movement, decreased the treatment time. Stripoli et al. In 2018 in his study concluded that the corticotomies reduces the treatment and time approximately half as compared to the conventional orthodontic treatment. Conclusion: minimally invasive piezo-corticism assisted periodontally accelerated orthodontic tooth movement is effective in reducing conventional orthodontic treatment time. It is painless procedure and patient acceptance is good as compared to flap technique for POW, but a long-term study is required for better results. Thank you.
Yes, Dr. Muthuka, please go ahead.
You didn't raise a flap.
Hello?
Did you raise a flap?
No, sir, we didn't raise the flap. We just make the micro incisions buccally, and then we, like with the help of piezo scission, we made like 3 millimeter incisions, 3 millimeter corticoscissions into the bone.
Okay. And after that, did you give a pack or something?
No, sir, we didn't give the pack or anything.
Don't you have to protect that area because you've touched the bone, isn't it?
Yes, ma'am.
Okay. How do you think this will aid? You said with orthodontics, only plain orthodontics and then piezo-corticism. Now, what is the tissue response that you expect? Why do you think the teeth move faster?
Ma'am, this is due to the rapid acceleratory phenomena. Ma'am, due to this, due to this stimuli that we have given to the bone, there is the rapid turnover rate in. There is an increased bone turnover, and due to which there is the bone density of the trabecular bone is decreased, which leads to due to which there is more tooth movement compared to that conventional ortho movement.
What is one drawback of this therapy? Can you state one drawback of this piezo-corticism?
Ma'am, the only drawback of this piezo-corticism is like patient has to go through like incision and piezo-scission. Like whether in conventional, they can wait for that time period, maybe that.
Okay. Yes, Dr. Muthuka, please. Yes. Okay. Thank you.
Thank you, ma'am.
Next presenter, CLR PO 100. Are you ready?
Yes, ma'am. Good afternoon, ma'am. Good afternoon, sir. Am I audible?
Yes, you are audible.
Yes, ma'am. The title of my poster is the comparative evaluation of light cure Omosil-based desensitizer and Shield Force Plus desensitizer in reducing dentine hypersensitivity. Painful symptoms arising from exposed dentine are a common finding in the adult population. Dentine hypersensitivity is defined as a short, sharp pain arising from exposed dentine in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, and which cannot be ascribed to any other form of dental defect or pathology. Most widely accepted theory for dentine hypersensitivity is hydrodynamic theory. Exposure of dentine results from two different processes, either removal of enamel covering the tooth or the denudation of root surface by loss of cementum and overlying periodontal tissue. Dentine hypersensitivity can be managed with toothpastes and mouthwashes that are applied at home, but they require a considerable amount of patient compliance. However, instantaneous pain relief can be given by in-office treatment using desensitizing agents, which I've used in my short study. Upon obtaining a written consent from patients and assessment of their medical and dental histories, using tactile and evaporative stimuli, participants with dentin hypersensitivity were assessed. The determination of pain evaluation was carried by using visual analog scale, which was given to the participant to mark with a pen and grading of 0 to 10, and depending upon the intensity, the patient has to mark. Soon after the baseline screening, all the participants underwent the oral prophylaxis treatment, and they were assigned for dentin hypersensitivity treatment, in which desensitizers were applied. Patients were recalled at 7th, 14th, and 21st day for the application of the same agent. Tactile and evaporative stimuli were used at each visit, and they evaluated using visual analog scale to mark the degree of pain they experienced. And after evaluation and all the results compiled, there were significant results in reducing dentin hypersensitivity. Amongst group A and B, group A showed immediate post-operative results by the end of first week. Both the materials are effective in reducing dentin hypersensitivity, but Admira Protect, which is my first product, Light Cured Ormocert, is found to be more effective in reducing pain with longer duration of action. Thank you so much, sir and ma'am.
Why is it called Ormocert?
Because, ma'am, the main constituent of this product is Ormocert, which is a organically modified ceramic.
So when you're saying in your discussion, you should never mention the generic, only generic name, no trade names. Understand?
Right, ma'am.
Ormocert. You are saying Ormocert based, so you cannot say Admira Protect. Understand? That is
right,
very essential whenever you are doing these studies. Okay? Because
yes, ma'am.
Yes, yes. It needs masking.
Right.
Right. Yes, yes, yes.
What type of cases did you select? Was it predominantly involved cases or patients with NCCM?
So most cases with attrition, abrasion, gingival lesion.
Okay, in that case, did you quantify the amount of destruction and accordingly did you sample the patients?
Sorry, sir, can you please repeat your question?
No, you said abrasion, erosion, all those things. Did you quantify the amount of abrasion and other things and accordingly selected your patient? Because that matters with the amount of sensitivity which is going to reflect.
Yes, right. So the patients who were where pulpal involvement was there, or very deep carious lesions which were reaching the pulp, those were not included in the study.
Who was classified NCCM?
So what?
Who has classified non-carious cervical lesions?
No, sir, sorry, I have to read on this.
Okay. That's it.
The classification has a bearing on the outcome.
Right.
Yes.
Okay. I will note this, ma'am.
Okay. Right.
Thank you so much, ma'am. Thank you, sir.
Yes, yes.
Can we have the next poster? CLR PO 101. Dr. Sonia.
Hello.
Yes, Dr. Sonia, you're audible.
Yes, yes.
Good morning, everyone. Good morning, everyone. My poster topic is the effect of locally delivered probiotic Saccharomyces boulardii as an adjunct to scaling and root planing in the management of chronic periodontitis, a randomized split-mouth, single-blind clinical microbiological study. Starting with the introduction, that probiotic therapy aims at modulating the composition of microflora by administering live microorganisms that confer the health benefits to the host when administered in a sufficient amount. Hello. The probiotic has a great potential in arena of periodontics in terms of plaque modification, in halidosis management, in altering the anaerobic bacterial colonization, and improvement of the probing depth, as well as in clinical attachment loss. Aim of this study is to determine the effectiveness of Saccharomyces boulardii as an adjunct to scaling and root planing in the treatment of chronic periodontitis. Objective of this study is to evaluate the efficacy of locally delivered Saccharomyces boulardii on clinical and microbiological parameters in the treatment of chronic periodontitis, and to compare the result of scaling and root planing alone and scaling and root planing with locally delivered Saccharomyces boulardii in patients with chronic periodontitis. Material and method of this study. That study was carried out in 31 patients. The study protocol was approved from the local ethical committee. In single patient, 2 interdental suprabony pocket sites were selected, that is having 5 to 8 mm of the pocket depth in different quadrant. That is, it is considered as test site and control site. The inclusion criteria of the patients who were having no systemic diseases with the presence of minimum 16 teeth, and patient with generalized moderate to severe chronic periodontitis having pocket depth of 5 to 8 millimeters and clinical attachment loss equal to or more than 4 millimeter. Exclusion criteria of this study were the patient using tobacco in any form, alcoholic patients, and pregnant and lactating mothers, and patient with history of any systemic drugs having history 6 months before this study, and the patient who had received periodontal treatment within 6 months were excluded. The patient with aggressive periodontitis and the patient who has the intolerance to these probiotics were excluded from this study. After that, informed consent was signed from all the participants which are included in this study. In test site, the scaling, thorough scaling and root planing was performed, followed by the placement of this lyophilized sabroid boulardii in the periodontal pocket. It was delivered subgingivally by mixing the 1 gram of sachet containing 250 milligram of the this probiotic yeast with 0.5 ml of distilled water. This paste was delivered into the pocket with the help
your
of
time is up. Can you just tell us your conclusion, please?
Conclusion of this study is that this after using the locally delivered probiotic Saccharomyces boulardii has the statistically significant result when it is compared as an adjunct to the scaling and root planing alone. And the result showed that the all parameters like probing depth, plaque index, gingival index, and clinical attachment loss showed the statistically significant result after 1 month, but at the baseline there were no statistically significant results. And in case of after culturing the P. gingivalis, after comparing the 2 groups, after 4 days and 1 month, there were the statistically significant result shown when compared to test and control group. So it is effective.
The case that you had selected, you had showed photographs, showed severe recession, showed severe clinical attachment loss. You were
the patient
with that? Yes?
Yes, yes, ma'am. Patients selected that moderate to severe periodontitis.
See, after your phase 1 therapy or?
Yes, ma'am. After phase 1 therapy.
There was no improvement after phase 1 therapy. That is when you implemented this?
Yes, ma'am. There were showed so much of improvement in that with the help of non-surgical, that is only with scaling and root planing, there was slight improvement showed, that is inflammation was reduced, pocket depth was 1 mm, that is reduced.
Okay, yes. Okay, Dr. Muthukumar, please.
Did you culture P. gingivalis?
Yes, sir.
How did you do it?
After collecting the sample in the sterile condition with the help of curettes, the sample was placed, that is in this study blood agar, kanamycin blood agar was used, that is as an enriched medium. Then after that, the sample was incubated, and after incubation, the colony count was done, that is for quantification, and these organisms are confirmed after gram staining, that is biochemical test also. All the these plates are incubated at 37 degrees Celsius temperature, and in 5 to 10% carbon dioxide jar for 48 to 72 hours, and the count was for facultative anaerobes. The count was done.
Okay.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you. Yes, ma'am.
Yes.
Can we have the next poster, CLR PO102, Dr. Anisha?
Ma'am,
Yes,
am I
doctor.
audible?
Yes, doctor, you're audible. You can start your presentation.
Good afternoon, respected judges. So as we all know that chronic periodontitis is a chronic inflammatory disease which affects the supporting tissue of the teeth, and it results in the destruction of both periodontal connective tissue and the alveolar bone. Therefore, my study, it aimed to evaluate the efficacy of diode laser as an adjunct in the open flap debridement in the treatment of chronic periodontitis. So for my study, I chose patients belonging to age group 18 to 60 years of age having chronic periodontitis, and at least 3 teeth should have pocket probing depth of more than 5 mm. And the patients were chosen the patients were chosen in whom the pocket probing depth, it did not subsided after root planing, scaling and root planing. The parameters which I assessed were the pocket probing depth, the gingival index, plaque index, the relative clinical attachment level, followed by the colony forming units. So in my study, as you can see in the first picture, the baseline picture, I have used acrylic stent where I have taken 6 reading per tooth, that is mesiobuccal, midbuccal and distobuccal. I have calculated the pocket probing depth and the RCal, and when the patient came, the patient's impressions, etc., were taken, and then the collection of the subgingival sample was taken for the colony forming units. So initially, for the sample collection, the plaque samples were collected by sterile curettes. The area was properly dried, and after that, I collected the plaque samples and it was transferred into 3 ml of the phosphate buffer saline solution, and it was mixed using the vortex mixer setting system, that is for 60 seconds, and then then the sample was further diluted to 0.2 ml and spread on the trypticase soya agar plate. After that, I incubated it in the anaerobic gas pack where the pressure was 95% hydrogen and 5% carbon dioxide. After placing it for 28 to 48 hours, the results came after 48 hours, and then I used the colony count microscope to calculate the colony counts, and it was done both at the baseline and at the end of the study, that is 3 months. So coming back to the procedure, the open flap debridement was done, that is the Kirkland flap was chosen. After that, the flap was reflected both buccally as well as on the lingual or the palatal side. So I used the settings for the diode laser, that is I used 980 nanometers diode laser, and the diameter was 400 micrometers in the contact mode, that is 1.5 watts, and the degree of the tip was kept as 45 degrees. So I irradiated the flap in the inner side, that is both buccally as well as palatally, as we can see in the picture. The irradiation was done for 60 seconds per tooth, and then followed by suturing. Suturing was done, the normal interrupted sutures were given using the 40 silk suture, and the biostimulation was done at 0.5 watts in the non-contact mode. Then it was followed by placement of periodontal pack, and later on at the 3 months, at the end of the study, that is the 3 months, there was the levels, they came down for both the pocket probing depth, the gingival index, the plaque index, as well as for the colony forming units, there was a sufficient clinical attachment level gain. So it can be concluded that diode lasers, they can be safely used as an adjunct to treatment in the patients having chronic periodontitis, as it reveals a bactericidal effects and helps in the reduction of inflammation in the periodontal pockets, and it is very well accepted by the patients. Thank you, ma'am. Thank you, sir.
Yes, Muthukumar, please go ahead.
You did open flap debridement and open flap debridement with laser biostimulation.
Sir, I basically chose 10 patients. So I did a case series on the, like I only applied, I just wanted to see the effect of diode laser alone.
Okay. So you did it on the flap side.
Sorry, sir.
Did you use it on the tissue side?
Yes, sir. In the contact mode while irradiating the flap, I did on the inner side of the flap, both buccally as well as the labial side or the parietal side, both sides.
Okay. Now, regarding your power setting, you said 1.5 watts.
Yes, sir.
Can
Yes,
it be
sir.
used? Can it be used as a standard power setting for each and every case?
So in the bio-based laser that I use, that is the diode, different procedures have different settings, and it is already mentioned whether I want to disinfect the pocket or irradiate the pocket. They have given settings, like certain settings by the company itself.
Okay, but what if your working biotype is thin?
Sorry, sir. Is it?
The tissue biotype you are dealing is thin. What will you do?
Yes, sir.
Exactly, correct. That's exactly what I wanted to ask, Dr. Yes. The tissue
So yes, ma'am.
Yeah, as sir is saying, if the tissue biotype is thin, what is the tolerance?
It is used, it's usually used with a normal saline only. So patient doesn't feel any discomfort. We just have to give some horizontal overlapping strokes.
So that depends on that will mar the efficacy of the treatment. Isn't it?
You may be damaging a thin biotype.
Exactly. Exactly. If you are a little
Yes,
over, then you had trouble.
Yes, ma'am. That's why we are using normal saline. We are irrigating it again and again while using.
Okay. Okay. Right. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you so much. Next session, CLR PO 103. Is Dr. Varun here?
Hello. Yes, ma'am.
Yes, Dr. Varun, please carry on.
Hello. Good afternoon, everyone. I will be discussing my study on a trick of light influx of curcumin and toluidine blue O-mediated photodynamic therapy in fixed orthodontic patients, a randomized controlled clinical trial, with the aim to evaluate the antimicrobial and anti-inflammatory effect of curcumin or toluidine blue mediated photodynamic antimicrobial chemotherapy on dental plaque accumulation as an adjunct to scaling and root cleaning in adolescents undergoing orthodontic treatment. Coming to the material and method, the inclusion criteria of the study of my studies, the patients are enrolled with the age of 12 to 18 years who are undergoing a fixed orthodontic treatment. The GI should be more than 1.1 and the plaque index should be more than 1.1, whereas the probing depth should be equal to or less than 3 mm, and the absence of oral lesion should be there. These are the armamentarium that we have used. We have used the diode laser, we have used the anaerobic jars, we have used the colony-forming counter. And the clinical parameter that we have evaluated is the plaque index that was measured by the Tursky modification of Quelli and Hand plaque index, and the gingival index that was measured by the Lewis and Selnes method. The patients were randomly allocated in 3 different groups. The first group is the ultrasonic. In the first group, we have initially done the ultrasonic, followed by the photodynamic therapy with the toluidine blue. In the group 2, we have done the photodynamic therapy with the curcumin, and in group 3, we have only performed the ultrasonic scaling. These are the photos of the group 1. Here we have checked the plaque index at the baseline and after 30 days, and the gingival index at the baseline after 30 days. This is the application of the toluidine blue. After the application, the toluidine blue is activated with the diode laser with a wavelength of 860 nanometers. And in the group 2, this is the plaque index and the gingival index that we have taken similarly in the group 1. After that, we have done the application of the curcumin gel, and then this curcumin gel is activated with the photodynamic therapy at a wavelength of 450 nanometers. And in the group 3, only scaling and root training is done. These are the microbiological analysis of the group 1, group 2, and group 3. Here we have used the soya broth agarose gel and with the colony forming units were count. After the sample collection, the sample were transferred into the PBS, and then the sample were transferred into the agar plate with the help of the inoculating tubes. And then these samples are stored in the anaerobic jar for 24 hours to 72 hours. And coming to the results, these are the graphs that are the plaque index, gingival index, and the colony forming unit. in these graphs, when we have done the intergroup comparison, we have not found any significant. We have found a significant difference in each group, in the plaque index, gingival index, as well as in the colony forming unit. Whereas coming to the comparison in the group 1 and group, here we have done the comparison between the group 1 group 2, and in the second we have done the comparison of group 2 group 3, and here we have done the comparison with the group 3 and group 4. And in all the four groups, in all the three groups, we have found that the group where we have used the curcumin gel is found to be more better in comparison of the plaque index, gingival index, and the colony forming unit. But the results were all the different, coming to the discussion on the three different modalities, show significant improvement in the clinical parameters. The group 2 showed significantly higher reduction in the microbial count at 30 days, though no statistical significant difference was found. And
what microbial analysis have you done, doctor? Hello. Of which organism? Any particular organism?
But the comparison was done in between three different groups, ma'am. The first group is our photodynamic therapy, followed by the toluidine blue. In the second group, we have done the ultrasonic scaling, followed by the curcumin gel application. And the third, we have done.
Yes, doctor, I am aware of that. But you have done some microbial analysis.
Yes, ma'am.
Which organism? Any particular organism, or you've just cultured?
Ma'am, we have done the normal evaluation of the normal microbial organisms, ma'am. Not specific, ma'am.
Not specific.
Yes, ma'am.
Okay. What is the effect of photodynamic therapy on this colonization?
Basically, the photodynamic therapy, ma'am, it was the activation of the photosensitizer, ma'am, which binds to the target cell and which release the reactive oxygen species, ma'am, that kills the microorganism, ma'am.
Okay, right. Thank you. Yes, doctor.
Where does the dye act actually?
Hello.
Where does the dye act? In which part of the microorganism?
Sir, sorry, sir, you are not audible, sir.
Which part of the microorganism does the dye act?
Sir, your voice is breaking, sir.
Dr. Varun, sir is asking which part of the microorganism does the dye act on?
Sir, it's membrane, sir. It calls the lysis of the membrane.
Dr. Varun, thank you so much. Can we have the next poster, please? CLR 104, Dr. Ritika, please can you start? Dr. Ritika, please unmute yourself, please.
Am I audible now, ma'am?
Yes, please, go ahead.
Good afternoon, respected chairpersons. As we all know, the aesthetic needs of the patients are increasing day by day. To achieve this, not only teeth, but also gingiva plays an important role. Gingival depigmentation is an aesthetic procedure which improves smile and overall appearance of the individual. So the aim of the study was to compare gingival depigmentation healing by scalpel in adjunct to placental extract gel, that was Placentrix, and scalpel alone. In the inclusion criteria of the study, the 10 systematically healthy individuals were included, and the clinical parameters which was included was Landry's healing index, Dermot gingival pigmentation index, number of days for healing taken for healing, and the visual analog scale. Then the patients were divided into two groups and were randomly divided into control and the test group. Dermot's gingival pigmentation score was evaluated under local anesthesia. Depigmentation was done with scalpel, and then the pack was given. In the test group, after the depigmentation with the scalpel, the placenta extract gel, that is Placentrix, was evenly applied on the site, and then the pack was placed. Coming to the results, in the baseline and the post-op Domit's index scores were similar in both the groups. However, there was significant decrease in the pre and the post-op values, and the VAS score was also less in the test group. While there was no statistical significant difference between the test and control groups with the regard to the healing index, but the number of days which were evaluated for healing after depigmentation was statistically significant reduced in the test group as compared to the control group. So in the conclusion, we can say that even though the healing was similar in both the groups, but the number of days taken for healing in the test group, and as well as the patient's pain perception was less in the placental extract group. This may be due to the presence of the placental extracts which promote wound healing, and hence we can recommend the use of placentrix extract gel in depigmentation wounds to promote healing and decrease post-operative pain and morbidity. Thank you, ma'am.
Does it matter much whether the patient is going, your goal is different?
Sorry, ma'am?
Your goal for this depigmentation is totally different. You want a
healing, we were assessing the healing, ma'am.
So does it have any say in this?
Yes, the number of the days healing, the number of days reduces in the placental extract group as compared to the non-placental in the scale alone.
Yes, so it is only one arm of the study, but your goal is totally different, isn't it? That is depigmentation. Does it have a bearing on depigmentation? Will it delay depigmentation in that way?
No, ma'am. But we were assessing the healing only. After this was a procedure which we have done just to assess the healing.
Okay. So it promotes wound healing. So
yes.
Why have you chosen? So it promotes wound healing in any case.
Ma'am, actually, placental extract gel promotes a proliferation of the primary culture of the keratinocytes, and which because the placental extract has immunotrophic action at the both cellular as well as the humoral level.
Okay, right. Thank you.
Is there any other methods with which you can do depigmentation?
Yes, sir. There are various methods. For example, we can use electrocautery, lasers. Sir, recently a ceramic burr trimmer is also used for depigmentation. Sir, cryosurgery is also used for depigmentation.
Are there any gel used for depigmentation?
Sir, we can use tetrafluoroethylene. That is in cryosurgery only. So gel.
No. There is a particular type of gel.
Okay,
which
sir.
is available in a gel or a cream form, which can be used for depigmentation as well.
Sir, I'll find it out. I don't know, sir.
It has a chemical base.
Okay, ma'am.
Yes.
Okay, ma'am.
Okay.
Thank you. Can we have the next poster, please?
कौन सा जेल है जो डिपेंड कर देता है?
Dr. Zainab? Dr. Zainab, please.
Hello.
Can you start your session? Yeah. Can you start your poster?
Yeah, okay. Good afternoon, everyone. I am presenting a clinical research poster under the heading of Use of Indigenously Prepared Bone Allograft in Regenerative Periodontal Surgery. Demineralized freeze-dried bone allograft are being used in periodontal regeneration. DFDBA contains bone morphogenetic protein 2, 4, and 7 that causes new bone formation to take place during healing. Therefore, DFDBA is osteoinductive in nature. Objective: commercially available bone grafts are costly and not affordable to every patient. Therefore, a central tissue bank was established in our institution to prepare indigenous allograft biomaterials according to internationally accepted protocols. We use International Malaysian University protocol to prepare DFDBA allograft. Cases requiring regeneration with bone allografts are hereby presented. Case 1 is of grade 2 furcation defect. In the radiograph, there is shown radiolucency in the furcation defect, and preoperative horizontal probing depth was found to be 3 mm. Post-operative horizontal, then we place DFDBA bone allograft in the percussion defect after thorough debridement. And then post-operative 6 months horizontal probing depth has been reduced to 2 mm. Case 2 was angular bone defect, and pre-operative horizontal probing depth was found to be 10 mm. After surgical debridement of the area, we placed DFDB allograft in the defect, and post-operative 6 months vertical probing depth was reduced to 5 mm. Third case is of socket preservation with DFDBA followed by implant. In this case, the premolar was extracted using atraumatic procedure, and then the DFDBA was placed in the socket after thorough debridement of the socket, and then after 6 months, the radiograph was taken, which reveals significant amount of bone formation, and hence the implant was placed. Results: significant amount of bone formation was seen in all cases 6 months post-operatively, and no post-op complications were reported. Conclusion: our indigenously prepared bone allograft can be a safer and cost-effective alternative to commercially available bone grafts, and further long-term clinical trials with larger samples are required to evaluate the effectiveness of DFDBA. Several studies have also been reported in which the intrabony defect was treated with DFDBA by Hengame, and S. Wallace used grade 2 furcation defect and SC Wallace treat grade 2 furcation defect by DFDBA. Thank you. Hello.
Yes, Dr. Muthukumar. Yes, please go ahead.
In your first case, did you use a membrane?
No, sir. In this case, we didn't use membrane, only DFDBA.
It was a class 2 furcation, right?
Yes, sir. Class 2 furcation.
Class 2 furcation, ideal is to place a membrane, right?
Is the ideal case for indicated for membrane.
Membrane.
Yeah, GTR.
So, but we wouldn't be able to evaluate the effectiveness of DFDBA.
That's okay, but whatever membrane you're going to use is going to be a resorbable membrane, hardly going to stay for 4 weeks or 6 weeks, yes, not more than that. Did you do a histological study in your third case where you did an implant? So during osteotomy, you could have taken a sample and then do a histological study.
Yes, sir.
Another thing is you have not mentioned indigenous. You have not given ethical clearance. You have not said what is the protocol that you followed. What is it that you have done indigenously? How did you prepare? What is it that you have taken into consideration for preparing the indigenous material? The constituents you have not disclosed. That's very important because you need an ethical clearance.
Yes, ma'am. We follow international Malaysian University protocol, and ethical committee has been placed in for this. Yes, ma'am.
What is the source of the indigenous thing you have not revealed?
Femur head. We use femur head.
Yes, you have. Yes, that has to be included in the study. Femur
okay, ma'am.
Yes.
Femur head. Okay.
Yeah, source must be included. Yes. Yes.
It should be intimated to the patient also.
Yes.
That's more important.
Yes. Yes. Okay.
Okay, ma'am.
Okay. Thank you. Thank you.
Thank you. CLFU 107, Dr. Swapnali. Can you start your session, Dr. Swapnali? Dr. Swapnali?
Am I audible?
Yes, yes.
Yes, am I audible?
Yes.
Greetings to all. My topic for today's poster presentation is evaluation of efficacy of injectable platelet-rich fibrin with DFDBA, that is sticky bone, in the treatment of periodontal intrabony defects. Injectable PRF is a liquid form of platelet concentrate which can be polymerized with the bone grafts. It incorporates the incorporation of graft material without any addition of anticoagulants or additives, and hence it provides a stick for bone grafting. Hence, the aim of this present study was to evaluate the efficacy of IPRF and DFDBA in comparison to DFDBA alone in the treatment of intrabony defects. Coming to the materials and methods, participants with chronic periodontitis having probing pocket depth more than 5 mm and radiographic defect depth more than 3 mm were included in the study. The participants were randomly divided into two groups. The first group consisted of 10 sites of intrabony defects, and in first group, DFDBA with PRF and Corian membrane was used for periodontal regeneration, and in the second group, DFDBA with saline and Corian membrane was used. The clinical parameters like PPD and CAL were measured at baseline at 3 months and 6 months, and the radiographic defect bone field was measured at baseline and 6 months. In these photographs, we can see the preparation of IPRF. For preparation of IPRF, the 10 ml of blood was withdrawn from patient's antecubital vein, and it was immediately centrifuged for 700 RPM at for 3 minutes in digital centrifugal machine. After centrifugation, the blood gets separated into two fractions. The bottom layer consisted of RBC, and the upper liquid orange colored fluid, it consisted of platelets, plasma, and various growth factors. It was obtained with the help of the syringe, and this liquid form of PRF was mixed with the graft material. In the present study, DFDBA was used, and after 10 to 15 minutes, polymerization started, and a well thick consistency graft sticky bone was obtained. Coming on to the results, this graph one depicts the intergroup comparison of PPD at baseline 3 months and 6 months. As we can see, in both the groups from baseline to 3 months and from 3 months to 6 months, the PPD was reduced, and on intergroup comparison, the difference was not statistically significant. Similarly, this graph 2 for comparison of CAL from baseline to 3 months and 6 months for both the groups, in sticky bone group and in DFDBA group, the CAL was reduced from 8.93 to 4.8 for group 1 and from 8.07 to 4.27 for group 2. But on intergroup comparison, the difference was not statistically significant. This table 1 depicts the comparison of defect depth reduction between baseline and 6 months period in both the groups. In group 1, the radiographic defect depth at baseline was 10.22 and it was reduced to 5. And similarly for group 2 also it was reduced, but there was more radiographic depth reduction for group 1 as compared to group 2. Hence, to conclude, I would like to say the injectable PRF, the use of injectable PRF in regeneration of intrabony defect, it favors the defect depth reduction radiographically, whereas the clinical parameters were same for both the groups and the difference was not statistically significant. Thank you.
Yes, sir. Now I would like you to tell me what is the centrifugation speed that you use for this injectable?
Ma'am, 700 RPM for 3 minutes.
It was first, it was allocated by whom? Who set these rules for the centrifugation?
Ma'am, this IPRF was prepared by a protocol given by Moro et al. Ma'am.
Okay.
In 2015.
Okay. Who was the first person who elaborated on this?
Ma'am, this, ma'am, Chokran et al.
Okay.
But ma'am, this use of IPRF for making the sticky bone, it was first elaborated by Son ma'am in 2010.
You've used Corian also, Corian membrane.
Yes, ma'am. Yes, ma'am.
So how can you say the results are due to the growth factors derived from the sticky PRF or from the Corian?
Ma'am, the slower centrifugation speed and the time used for preparing the PRF, ma'am, it favors the fibroblast migration, ma'am, and the number of growth factor release is more, ma'am. Okay. And also, ma'am, the sticky bone, it provides stabilization of graft in the defect, and therefore it accelerates tissue healing and it minimizes the bone loss during healing period.
So what is the role of your Corian?
Ma'am, the Corian membrane, it was used for ma'am, GTR, like guided tissue regeneration purpose.
Okay. Thank you. Yes, sir.
Yes.
Thank you.
Thank you so much. Next presenter, please. Yes, doctor. You can start presenting.
Yeah, am I audible?
Yes.
Yeah. Good afternoon to the chairpersons. My topic for today is concentrated growth factor, a rule for root coverage. According to the introduction, the various biomaterials are used along with a coronally advanced flap, that is CAF, for root coverage. One such biomaterial is concentrated growth factor, CGF, for which, to the best of our knowledge, there is no published literature. Our aims and objectives were to determine the efficacy of sticky bone along with CGF, membrane along with the CAF as compared to CAF alone in the treatment of Miller's class 1 and class 2 gingival recession. So what we tried out was using sticky bone along with concentrated growth factor along with a coronally advanced flap as compared to coronally advanced flap alone. Now, coming to the materials and methods, the test and control sites were randomly assigned equally to group A, which was CAF plus CGF plus sticky bone, and group B was CAF alone. Parameters assessed were depth of recession, width of recession, relative attachment level, width of keratinized gingiva, gingival mucosal thickness, and percentage of root coverage. Recall intervals were 1, 3, and 6 months. Now, these are the images of one of our test sites. This is the first picture is of incision and reflection. Then phlebotomy was performed to collect blood. The third image shows sticky bone placed. The fourth is CGF on sticky bone, and the suturing was done. Then we have the preoperative image, 1 month recall, where you can see the gingiva is still healing, the 3 months recall and 6 months recall. Now, coming to the results, we had anticipated better results when CAF was done along with CGF and sticky bone, since both offer various added advantages. There was improvement in all the clinical parameters in both the groups, but the results were not statistically significant. So the conclusion, clinical outcomes revealed noticeable improvement for both the groups. However, statistically, the effectiveness of concentrated growth factor and sticky bone was not perceived to be superior to that of CAF alone. So probably further longitudinal studies with a larger sample size will help to determine the efficacy of sticky bone along with CGF for root coverage. Thank you.
Yes, Dr. Muthukumar, please go ahead.
How did you prepare CGF?
So the protocol has been given by SACO, wherein we collected the blood in 2 plastic vacuum containers. So 2 minutes, 30 seconds, there was 2,700 RPM to prepare the AFG, that's the autologous fibrin tube. And then centrifugation, the speed was changed. It was continued at 4 minutes for 2,400 RPM, then 4 minutes at 2,700 RPM, and then 3 minutes at 3,000 RPM. And then slowly for 30 seconds, there was a deceleration to prepare the CGF. This is the protocol that has been given by Dr. Sako.
Did you use a pre-programmed machine or a manual machine?
No, so it was a manual machine. We have a Remind machine wherein whenever we want to try out something new, we call the people and they assist us in programming it accordingly, according to the protocol that has been given.
Okay. Thank you. Right.
Thank you so much. Can we have the next presenter, please?
Thank you, Manish. How about sir? Yeah, I'm doing. You managed to get here. You know what? Thank you.
May I start?
Yes, please start your post.
Good afternoon, one and all. My topic for today's presentation is dermatoglyphics connected demographic is a branch of science which studies the pattern of skin or dermal ridge count on finger, toes, and soles of humans. It has been used substantially in the stream of forensics for medico-legal purposes, but in recent past, it has gained its space in the field of diagnostics. As every individual has its unique fingerprint pattern, it makes dermatoglyphics a very strong feature in diagnosing any condition like periodontitis and diabetes, which are etiologically influenced by genetics. Several work conducted have shown dermatoglyphic peculiarities in patients with periodontitis and with diabetic patients individually. So the objective of my study was to evaluate if there is existence of any dermatoglyphic uniqueness in periodontitis patients with or without diabetes. Coming to materials and methods, this study consisted of 60 participants with 30 in each, group 1 having chronic periodontitis patients and group 2 with diabetes, chronic periodontitis patients with diabetes. Fingerprint pattern was taken on a white paper with the help of ink method, and a total of 600 fingerprints were analyzed manually with magnifying glass. Patterns were observed for loop, arch, and whorls according to the classification by Sir Richard Henry, and palm analysis was done for angulation like ATD angle, DAT angle, and ADT angles. Values were statistically evaluated using unpaired student t-test, and the p-value more than or equal to 0.05 was considered statistically significant. Results showed that there was more of a loop pattern in chronic periodontitis group and more higher frequency of whorl pattern in diabetic patients with chronic periodontitis, which was statistically significant and was in agreement with the meta-analysis by C.L. Jonas in 2017. Moreover, there was statistically significant difference seen in ADT and ATD angles in comparison with between two groups. Therefore, the study concludes that a particular fingerprint pattern and palmar pattern is seen in chronic periodontitis and diabetic patients with chronic periodontitis, indicating the use of these parameters as a screening tool for future diagnostic purposes, and with the hope of a future of digitization where unlocking the oral and general health would be as easy as unlocking the smartphone with the help of fingerprint sensors. Thank you all.
Yes, what are the other studies with dermatoglyphics in dentistry?
There have been different studies that has seen dermatoglyphics, like Vineet Garg et al. In 2017, then Mehta et al. In 2015, then Surekha et al. In 2018, Gargi et al. In 2017. They all have showed different patterns, a particular pattern which is seen in chronic periodontitis patients when they compared with the healthy group. And there are studies where the diabetic patients have been compared for a particular dermatoglyphic patterns when compared to the healthy group. But this is the first study where we have combined both periodontitis and diabetic in a same patient and considered their dermatoglyphic patterns.
Does these whorls and this palmar pattern have any impact on the way you hold the brush?
Ma'am, actually, these are the patterns which are basically influenced from the embryogenic life of an individual prenatal. So this is like a unique pattern, and they have told that there is no influence of later postnatal life on these. So it is not much influenced on the basis of what way we hold the brush.
Because this palmar, plantar, whatever you say, because it should, yes, we ultimately believe in plaque control, isn't it? That's exactly.
Yes, ma'am.
Thank you. Thank you. Yes, Dr.
Thank you, ma'am.
Yes.
Thank you.
Yeah.
Next poster, please. Yes, Dr. Anjali, can you start?
Yes, ma'am. Am I audible?
Yes, yes.
Okay. Good afternoon, everyone. The title for my poster presentation is Association Between the Gingival Biotype and the Obesity. It is a case control study. As we all know that gingival biotype is defined as a buccolingual thickness of the gingiva, and it is basically classified into a thick gingival biotype or a thin gingival biotype. The gingival biotype is more resistant to inflammation and trauma as compared to a thin. And thin gingival biotype is more prior to more to inflammation of the periodontium, resulting in more pocket formation as well as gingival recession. So gingival biotype is also determines the outcome of root coverage procedures. There are various factors which is important to determine the gingival biotype, which includes amount of bone present, tooth form, inclination of the tooth affected near the gingival biotype. The genetic factors also influences the gingival thickness. In a recent study, it has been stated that the obesity play a role in influencing the thickness of the epithelium, as the gingival biotype is a measure of the epithelium present and the underlying connective tissue, which is the lamina propria. Now, the aim of my study is to investigate the relationship between the gingival biotype and width of attached gingiva in obese and non-obese patients. The methodology, we selected 50 obese and 50 non-obese patients, and we selected on the basis of the body mass index. The gingival thickness was measured on the facial aspect of the maxillary teeth at a midway between the free gingival group and the mucogingival junction. This gingival thickness was measured at 4 points, and mean of the gingival thickness was taken. The gingival thickness was measured by a digital vernier caliper, whereas the width of attached gingiva was measured using a graduated periodontal probe. Now, for the result and the statistical analysis, a student unpaired student t-test was done and a patient correlation coefficient was done. In student p-test, we found a significant value, statistically significant value of the gingival thickness and width of attached gingiva in obese and non-obese patient, which was statistically significant. When it comes to the correlation between the parameters of obese and non-obese in the intra-group, we found that where there was increase in the BMI, there was increase in the gingival thickness. So there was a positive correlation between them. Same with non-obese group also, there was increase in gingival thickness if the BMI was in increased scale. The other parameter which we did was for the bar diagram, which shows that between the obese and non-obese, where there was BMI was increased, the gingival thickness was also increased, and the width of attached gingiva was increased. So the result of the study showed that there is a positive correlation between the body mass index and the gingival biotype, and width of attached gingiva and gingival thickness higher in obese individual as compared to a non-obese individual, with a statistically significant difference, which is less than 0.0. The conclusion, the study concluded the gingival thickness and the width of attached gingiva is higher in obese individual as compared to a non-obese individual. Thank you.
Suppose an obese individual becomes a non-obese individual, will it affect the biotype?
Ma'am, my study is on the basis of one of the article where they show that the thickness of the epithelium increases as there is the increased BMI or the obesity. So we took that relation and like the TAT relation we included into the oral cavity with the gingival biotype.
Okay, thank you.
How did you measure the width of attached gingiva?
So we measured with the help of a graduated periodontal probe, sir, from the mucogingival junction to the margin of the margin of the marginal gingiva, and we minus the sulcus depth with the help of the periodontal probe. Only we minus the depth which we take it for the sulcus depth. We came to the width of attached gingiva. Sir.
Are there any other clinical methods?
Yes, yes, sir. There are. So there are methods to measure the width of attached gingiva. That is the roll test, is the tension test which we do. If there is rolling which take place, which shows that the width of attached gingiva is inadequate and educate, according to that, there is one more test. If there is Schiller's potassium iodide solution has been applied toward it, and the staining will be the keratinized tissue present there. So with that also we can measure the width of attached gingiva.
What is the odds ratio? Suppose you have a mixture of an obese individual with a thin gingival phenotype. Is it possible?
Yes. Sorry, ma'am. Sorry, ma'am.
I'm just asking you. Now, you said obese individuals generally have a thick gingival phenotype. Now, what's the odds ratio? A thick obese individual having a thin gingival phenotype. Is it possible? So you have to study that also.
Yes.
Understand?
Yes, ma'am. Yes.
You have to include that also. So
yes, ma'am.
You're saying that generally obese individuals have thick gin. So you have to say that, yeah, those that.
Yes, ma'am.
Yeah. Okay. Thank you.
Thank you, ma'am. Thank you.
Thank you. Next, please. Dr. Sharmila. CLR PO 111. CLR PO111. Dr. Shamila, are you there? Mrs. Sailesh, I think the student is
She's
not
there, ma'am. It's login, ma'am.
Sorry.
She is there, ma'am.
She's there. Dr. Sharmila. Mr. Sailesh, I think we should go to the next presenter. We'll keep this on hold.
Okay, ma'am.
Dr. Neha, CLR PO 112.
Yes, ma'am.
Just a second. The poster will be shared.
Good afternoon, everyone. Am I audible?
Yes, you are audible.
Yes, ma'am. Thank you, ma'am. So the topic for my poster presentation is assessment of correlation of lipid profile and severity of periodontal diseases in patient with dyslipidemia. So to begin with the introduction, American Academy of Periodontology, the International Workshop of Classification of Periodontal Diseases 1999, has defined periodontitis as an inflammatory disease of the supporting tissues of the teeth caused by a specific microorganism or a group of microorganisms resulting in progressive destruction of the periodontal ligament and alveolar bone with pocket formation, recession, or both. Now, there are increasing evidence linking periodontitis to systemic diseases like diabetes, cardiovascular diseases, obesity. So having said that, inflammation plays a potential role in the pathogenesis of metabolic diseases like dyslipidemia. So dyslipidemia is a multi-etiologic and polygenic disease. Periodontitis and plasma lipids is that periodontitis could alter between periodontal disease and serum lipid level. So the purpose of this study is to evaluate periodontal condition of patients presenting with dyslipidemia. The methodology, we have taken the periodontal parameters and the lipid levels of patients, including the triglyceride level, LDL, HDL, and cholesterol level. As we can see in the diagram, in periodontitis, there is involvement of pro-inflammatory cytokines like interleukin-1 beta, then tumor necrosis factor alpha, and there is reduced lipid clearance. Hence, again, hyperlipidemia will be seen. So after all the statistical analysis, we have got the result that there is a consistent relationship between the lipid profile and the periodontal disease severity in patients. Hence, we concluded that it is a two-way relationship between periodontitis and serum lipid level. The chronic inflammation clearly plays a role in the pathogenesis of both the disease. Now coming to the future perspective, of particular note are the patients with aggressive periodontitis. Since this disease develops early in life, the cumulative effect of chronic inflammation and dyslipidemia over many years can result in severe cardiovascular events. Given the recent report of a genetic association between aggressive periodontitis and cardiovascular diseases, this would appear to be an important area for further studies. With this, I will like to conclude my presentation. Thank you.
Yes, Muthukumar, if you have any questions.
It's no term called aggressive periodontitis as of now.
Yes, sir.
There is no term called aggressive periodontitis as of now, as per the recent classification.
Sorry, sir, I can't hear you.
There is no term called aggressive periodontitis as per the current classification.
2017.
Yes, sir.
So how would you better phrase it? Because it includes a certain entity, isn't it?
Yes, ma'am.
Because you are going into far advancements, genetics and all that dyslipidemia. So you should also follow the latest classification.
Yes, ma'am. Yes, ma'am.
The latest classification also says the genetics.
Yes.
Evidence is not that so clear so far.
Yes.
Yes, ma'am. Yes, sir.
Not conclusive at all.
Conclusive.
Yes. Okay. Okay,
yes, ma'am.
Thank you. Thank you.
Okay. Okay, ma'am. Thank you, sir. Thank you, ma'am.
Thank you. The next poster, please. CLR PO 113. Deepshika.
Yes, ma'am. Ma'am, I'm audible.
Yes, yes, you're audible. Please start.
Very good afternoon. The poster presentation is on the topic assessment of contributors of SMILE. Making of a perfect smile. A smile is one of the fundamental networking tool in the facial expression. It is a way of non-verbal social communication. A beautiful smile is not only an expression, but it is also produced by a proper harmony and integrity of facial and dental related factors. In order to restore this aesthetic components, it is important to determine the shapes of maxillary anterior teeth and their relationship with the interdental papilla and gingival biotype during smile. So objective of this study was to evaluate smile line, tooth shape, gingival biotype, and gingival angle with the help of photographs and commercially available image analyzer software. So the methodology include 81 subjects which were recruited who satisfied the inclusion and exclusion criteria. Clinical photography were captured. The first photographs was taken, as you can see in the picture, while the first photography was taken while the subjects were with their maximum smile line on a non-reflective green backdrop with a white opaque ruler 30 centimeter, which was perpendicular to the floor. The second photography was taken with a graduated periodontal probe that was placed perpendicular to the occlusal plane next to the incisor that was used as a guide to determine the unit in the image analyzer. The assessment of tooth shape and gingival angle was determined in the image analyzer. So when we are talking about the tooth shape, it was assessed by the crown length and crown width. See, so the crown length was determined by the measuring the distance from the most apical part of the crown to the mesial edge along the long axis, and crown width was assessed by the assessing the distance between the mesial and distal contact points. The next in the gingival angle, it was assessed by drawing a line from the most apical labial gingival margin to the most apical part of the mesial and distal contact points. The gingival biotype was assessed by probe transparency method. Next was the smile line. The smile line was estimated by taking the references of the incisors, in which it was more than 100% percentage of clinical visibility of clinical crown was indicated as high smile line, whereas 75 to 100 percentage of clinical crown visibility was stated as average, and less than 75 percentage of clinical crown visibility was stated as low. The data was collected and coded and fed in SPSS, and the p-value was obtained less than 0.05. When we talk about the result, when the tooth shape was compared with the gingival angle,
your time is up actually. Your time is up actually. Can you just tell us the conclusion, please?
Yeah, ma'am. When it was compared with the other parameters, it was there was no statistical significance. But when the tooth shape was compared with the smile line, it was highly significant. So the study concluded that the thick gingival biotype is mostly present in the studied subjects, and average smile line was seen with the triangular tooth shape, whereas low smile line was mostly seen with the tapered tooth shape. And as we have seen the result that the smile line was highly significant as compared to the other parameters. Thank you, ma'am.
Where does this play a role, your assessment?
Ma'am, actually the study was done to assess the smile, ma'am. So the smile, it has the component of teeth as well as the gingiva and the lip framework. So this study.
So where is your assessment of the Cupid's bow?
Ma'am, I in my study I was like I only the objective of my study was to only evaluate the smile line, ma'am.
Okay.
Yeah, ma'am.
Okay, because you said all those parameters that contribute to the smile. That's exactly why I asked you. Understand? Okay, yeah. Thank you. Yes, sir.
Did you correlate the measurement of the crown with actual measurements?
Sorry, sir.
You said you took measurements on the image analyzer software, right?
Yes, sir.
That's based on the photograph which you have taken.
Yes, sir.
How did you standardize the photographs?
Sir, before clicking, I have, while taking the photographs, I had standardized the distance and the megapixel, that was 24.1 megapixel, which was standardized in my camera. So the same photographs were taken for each subject, sir.
What about the angle?
Sir, it was perpendicular to the floor, sir, and it was around 3 meters from the floor, sir.
Did you use a tripod or something?
Yes, sir, tripod.
Thank you, doctor. Can we have the next poster, please? Dr. Srishti?
Am I audible, ma'am?
Yes, you're audible. Please start with this question.
Good afternoon, everyone. My topic is evaluation of the position and diameter of the greater parietal foramen by using whole-beam computed tomography for clinical preservation of underlying structures during parietal tissue graft harvesting. So, the treatment with the subepithelial corrective tissue graft technique is one of the most trending.
Hello. Doctor, please unmute yourself.
Am I audible?
Yes, yes. Go ahead.
So to safely separate the subepithelial connective tissue from the palate, the knowledge of the anatomical landmarks and structures underlying the palate is important. Concern has been markedly raised related to the potential risk of damaging the greater parietal artery. So the aim of the study is to evaluate the position and diameter of the greater parietal foramen by using whole-beam computed tomography for clinical preservation of underlying structure during parietal graft harvesting. Materials and methods used were a total 120 CBCT scans of the patients were used, and the axial section of the CBCT image will be reconstructed to assess the location of greater parietal foramen with respect to the three posterior maxillary teeth, that is first molar, second molar, and third molar. Three tangents was drawn parallel to the middle of the interproximal to the face of the maxillary, first, second, and third molars at the location of the GPS were assessed, and similarly the distance from GPF and greater parietal foramen and alveolar ridge as well as mid parietal suture were calculated, and we got the results that position of GPF is near M2 in maximum of the CBCT scans, and the distance was higher in age less than 45, and in males the distance of GPF from alveolar ridge as well as mid parietal sutures were significantly greater, and the diameter was higher in females. The majority of research on GPF location was conducted on dry cells like study done by the Kumar et al. In 2011. and in 2007 by Saralia, which provide limited information on the patient's age, gender, or race. The present study findings clearly showed significant gender differences in GPF diameter. When age 6 are included in the study parameters, obesity meta-analysis offers the advantage to providing information about age 6 and ethnicity. So to conclude it, considering the significant anatomy of GPF according to the age and sex, clinicians must be cautious while treating palatal region. Thank you.
You quoted ethnicity. How did you attend to that feature? Yeah, you have from different ethnic populations. No, but your study is interesting. So it should in the future, because that's the future. Regenerative surgery and flap and grafts. So it should be, because when you said ethnicity, age, right, sex, right. But when you say ethnic, yes, you have to provide that information also, because you cannot say a Mongoloid looking individual having different anatomical variation. Understand? So you have to. Thank you.
Sir, do you have any questions, sir?
Okay.
Thank you, sir.
Thank you, sir.
Thank you. Can we have the next poster, please? Yes, doctor, please start your presentation.
Am I audible?
Yes, you are audible. Please start the presentation.
The topic for my poster presentation is incidence of cervical hypersensitivity after periodontal therapy, a retrospective survey. Dentinal hypersensitivity is defined as short, sharp pain arising from exposed dentine in response to various stimuli, which is typically thermal. Besides causing discomfort, the condition may deter a patient from establishing or maintaining adequate oral hygiene procedures, further complicating the oral health maintenance. It can also have an impact on the quality of life, affecting everyday activity of the patients. And sensitivity post-periodontal therapy can occur as a result of removal of cementum, causing exposure of dentinal tubules. Prevalence of hypersensitivity after periodontal treatment in patients with no hypersensitivity prior to the treatment is a matter of concern, and there is lack of data regarding dentinal hypersensitivity after periodontal therapy among Indian population, which gives the need for such a study. The objective of the study was to evaluate the incidence of dentinal hypersensitivity after periodontal therapy. The investigation was carried out in the form of a questionnaire to which the participant responses were recorded and analyzed statistically. The questions included information about brushing technique, frequency of brushing, bristle diameter, and time spent on brushing. The severity of sensitivity was assessed using visual analog scale. A total of 230 participants were included in the study, where mean of sensitivity before and after the treatment was measured, and it was found to be statistically significant. Correlations between brushing frequency and sensitivity before, brushing time and sensitivity before, bristle diameter and sensitivity before and quality of life was assessed. And the results showed that the mean difference of sensitivity before and after treatment shows sensitivity is increased in both scaling and root planing patients, while it is shown to have decreased in flap surgeries. The study result shows that there is positive between overall sensitivity with bristle diameter, brushing technique, brushing frequency, and duration of brushing. The result of the present study suggests that there is increase in cervical dentinal hypersensitivity in patients undergoing periodontal therapy. So effective treatment modality must be followed to manage these cases efficiently, quickly, and permanently. Thank you.
That you have hypersensitivity following post-treatment is known. It's already been, yes, elicited. But yes, you said in the Indian population, there is paucity of literature. There are so many studies on hypersensitivity.
Yes, ma'am.
So in what way you think the Indian population would differ on the basis of hypersensitivity as regards to periodontal treatment? It's their immune system.
Ma'am, I didn't get your question, ma'am.
No. Now you said the Indian population, there was very limited studies. That's why that's provide, yeah. So that's why I want to know why. Do you think the Indian population would differ in any way to the parameters of hypersensitivity that have already been done? Elucidate.
Ma'am, you were not audible, ma'am.
Not audible?
Now you're audible, ma'am.
Yeah. No, you said in the Indian population, there was dearth of literature. So I want to know if the Indian population differ in any way from the parameters of hypersensitivity as given to other populations post-treatment. Is it that we have better immune capacity, better tolerance capacity?
Yes, ma'am. I think we have a better tolerance capacity because
pain perception. Okay, right. Thank you. Yes, Dr. Muthukumar, please go ahead.
How did you assess the bristle diameter and other things?
Sir, we have not assessed bristle diameter of every patient. It was a questionnaire study, sir. So soft, medium, hard bristles. So the patient was asked to mark.
Yes, thank you.
Thank you.
Thank you, doctor. Next poster, please. CLRPO 116. CLRPO 116. Kedareshwari. Mr. Sailesh is the presenter here. Mr. Sailesh. Is the presenter here? Mr. Sailesh. Hello. Hello. Mr. Sailesh, can we have at least the next poster, please? Mr. Sailesh?
Hi, yes, ma'am.
Can we at least have the next poster, please? Because time is running.
Yeah.
CLRPO 117. CLRPO 117, are you in, Dr. Gopal? Mr. Sailesh, have you let in all the participants? Mr. Sailesh?
Yes, ma'am. Gopal also is not entered.
Have you let in all the participants? No one is in the waiting room, right?
Yes. 117, Gopal, no.
116, Dr. Kedareshwari. Is she there in the waiting room by any chance? Can we have CLR poster 118, please? Mr.
Yes,
Shailesh?
ma'am.
Just a second. Yes, doctor.
No one is logging, ma'am.
Okay, no problem. Let them present. Whoever is there, let them finish first. Dr. Vedavalli.
Yes, ma'am.
Yeah, please go ahead.
Yes. Good afternoon to everyone. Today I'm here to present my study on the evaluation of the dimensions of alveolar bone in the maxillary anterior region, a retrospective CBCT analysis. Recently, there's been a growing demand for the replacement of the maxillary anterior teeth with immediate implant placement. As apart from aesthetics, there's a sense of social well-being when the tooth is being replaced immediately after extraction. However, immediate implant placement has been associated with a greater rate of complications and failures, as there's a significant changes in the ridge dimensions, which continue up to 1 year following tooth loss, with the majority of the changes taking place within the first 3 months, particularly in the buccal aspect. Hence, immediate implant placement should be considered only when the buccal plate thickness is more than 1 millimeter to prevent these complications. And according to Hyunba et al. In 2010, the maxillary anterior teeth has a buccal plate thickness of less than 1 millimeter. Therefore, the evaluation of the buccal plate thickness in the maxillary anterior region is detrimental in evaluating the timing of implant placement, particularly in the aesthetic region. Taking this into consideration, the present study aimed to find out the average buccal plate thickness of the maxillary anterior teeth in patients of a South Indian population using CBCT analysis. So a total of 100 patients CBCT, that is 50 males and 50 females, aged between 30 to 60 years, who were a part of an ongoing randomized control trial, were taken up and analyzed for their buccal and palatal bone thickness at 3 levels based on the Zhang et al. Criteria given in 2020. So this image is that of a patient CBCT which was analyzed, in which the yellow lines are the reference lines. The horizontal yellow line is that representing the level of the CEJ, and the vertical line is the line drawn perpendicular to the level of the CEJ with respect to the anatomical landmark, which is either the floor of the maxillary sinus or floor of the nasal cavity. And the T1 and T2 depicts the buccal and palatal bone thickness at the level of the alveolar crest. T3 and T4 depicts the level at 1 millimeter from the alveolar crest, and T5 and T6 depicts the buccal and palatal bone thickness at the mid-root level. Moving on to the results of my study. So the buccal plate thickness was the highest for the tertile group, which included the patients aged between 31 to 40 years, which is the third tertile, followed by the second tertile, which included patients between 41 to 50 years, and was lowest for the patients aged between 51 to 60 years, which were the patients belonging to the first tertile. With regards to gender, there was no statistically significant difference between the buccal and palatal bone thickness. And this table depicts the values of the buccal plate thickness 1 millimeter from the level of the alveolar crest, and it can be noted that the buccal plate thickness was less than 1 millimeter in the maxillary anterior teeth and the maxillary first premolar, and was slightly increased in the maxillary second premolar region. And these results were concomitant with that of Hyunba et al. In 2010. To the best of our knowledge, this is the first study to have evaluated using CBCT the buccal plate thickness of the maxillary anterior teeth in patients of a South Indian population, and the finding that the buccal plate thickness is less than 1 millimeter in the maxillary anterior teeth, similar to that of the premolars, is a clinically relevant information which can be translated into clinical scenarios where immediate implant placement is planned. Thank you.
Thank you, because it's a retrospective study.
Yes, ma'am.
Okay, right, thank you. You've been assessing that. So how will it help you actually?
Ma'am, so the results of the study reveal that the buccal plate thickness in majority of the patients with respect to the anterior teeth and premolars is less than 1 millimeter. So it gives us more emphasis on bone augmentation procedures which will be required during implant placement.
Okay, right, thank you. Thank you.
And as maxillary anterior teeth has more demand for immediate implant placement.
Yes.
Thank you.
Yeah, that's very important. Okay, thank you.
Thank you. Thank you, sir.
Thank you, doctor. CLR PO 120. Sorry, CLR PO 119, right?
Yes, ma'am.
Yeah. Dr. Aparna.
Yes, ma'am.
Mr. Shailesh, the screen, please. Yes, doctor, please go ahead.
Good afternoon, everyone. My topic for today is PCSK9, a possible link between periodontitis and cardiovascular disease. So proprotein convertase subtilisin kexin type 9 is an enzyme encoded by the PCSK9 gene in the humans on chromosome 1. And this post-transcriptionally promotes the degradation of LDRs in the hepatocytes, and it is most commonly expressed in the kidney, heart, and the liver. And the inhibition of this PCSK9 has several effects on the platelets, the endothelial cells, macrophages, and the vascular smooth muscles. The aim of my present study was to estimate the levels of serum PCSK9 in cardiovascular patients with gingivitis and chronic periodontitis. So cardiovascular patients with gingivitis and chronic periodontitis who were aged between 20 to 80 years were included in the present study, and patients with any other systemic malignancies, pregnant and lactating women, and patients who had underwent periodontal therapy within the last 3 months were all excluded from the present study. So the present study is a case control study design, and all the clinical examination was carried out by a single calibrated examiner. The OHI index, the PISA index, the PPD, and the CAL levels were also recorded in the present study. So following the informed consent based based upon the inclusion and exclusion criteria, the patients were divided into two groups. Group 1 patients were cardiovascular patients with gingivitis, whereas Group 2 was cardiovascular patients with chronic periodontitis, and 2 ml of blood was collected from all the patients by a phlebotomist. It was centrifuged at 2000 rpm for 5 minutes, and the serum was separated. And this serum was stored at minus 80 degrees Celsius, following which the sample processing was carried out using a sandwich ELISA kit. And it was noted that the parameters, all the parameters, which was the PISA, the PCSK9 levels, the HDL levels, LDL levels, triglyceride, and the cholesterol levels were all statistically significant. And also we carried out a regression analysis with the serum circulating serum PCSK9 levels as the dependent variable. And it was noted that there was a positive correlation between the PCSK9 and the triglycerides, the cholesterol levels, and the LDL levels. And there was a negative correlation between the PCSK9 levels and the HDL levels. So moving on to discussion, as we all know, it has been well established that periodontal disease and the cardiovascular disease are correlated to each other, and it has been noted that changes in the lipid profiles of patients with chronic periodontitis is most often manifested as decreased HDL levels and increased LDL levels. So based upon this, in the present study, we aim to examine the effects and the consequences of the circulating serum PCSK9 on the subsequent cardiovascular risk. And it was noted that the serum PCSK9 levels were drastically increased in the Group 2 patients when compared to Group 1 patients. Apart from this, it was also noted that with the increase in serum PCSK9 levels, the LDL levels, the triglyceride levels, the cholesterol levels, and the inflammatory burden was also increased, whereas the HDL levels were decreased. So in conclusion, it can be noted that the elevated PCSK9 levels can have a potential role in evaluating the risk of your cardiovascular disease as a result of the impact of your chronic periodontitis. Thank you, ma'am.
Do you know of any PCS9 inhibitors that are available, FDA approved, as you are suggesting?
Sorry, ma'am?
Do you know of any PCS9 inhibitors, as you said, to bring down the hyperlipidemia or whatever?
Yes, ma'am. There are 2 FDA-approved PCSK9 inhibitors which are currently available, ma'am. One is alirocumab and the other one is evolocumab, ma'am. And in India, only the evolocumab is approved by the DCGI, and it has been used in hyperlipidemia and familial hypercholesteremia cases also, ma'am.
Okay, thank you.
Any questions, sir? Thank you, doctor.
Yeah, thank you, ma'am. Thank you.
Can we have the next poster, please? CLR PO 120. Dr. Shanvi?
Yes, ma'am. Yes, ma'am.
Go ahead with the question.
Yes, ma'am.
Yes, you're audible.
Yes, good afternoon, respected sir, ma'am. Today I am presenting my poster on the topic dental and periodontal complication of lip and tongue piercing, prevalence and influence factor. Are your piercing ruining your smile? Coming to the introduction, over the last decade, piercing of the tongue, lip or cheek has grown in popularity, especially among the adolescent and young adults. Oral piercing usually involves lip, cheek, tongue or uvula, with the tongue as the most common pierced site. With the increased number of patients with pierced intra and perioral sites, dentists should be prepared to address issues such as potential damage to the teeth and gingiva and the risk of oral infection that could arise as a result of piercing, that should be educated regardless of the dangers that may be following the piercing of the oral cavity. Now, the sites of the oral piercings are tongue, lip, cheek, uvula, and frenum. Now, coming to the methodology are, we have taken 110 subjects were taken, out of which 52 were male and 58 were females, with the age of 18 to 35 years. The inclusion criteria were presence of intra and perioral piercing. Exclusion criteria were known systemic disease or condition needed for medication that could affect the periodontal tissues, pregnancy and lactation. Whereas the influencing factors are aesthetic reason, fashion, cultural influence, and influence of the friends. Now the complications, we have 2 complications, early and late complications. In early complication, we have pain, edema, hemorrhage, inflammatory reactions, whereas in the late complications, we have abnormal tooth wear, tooth chipping, gingival, localized periodontal destruction, cracked tooth syndrome,
Ludwig angina, that is late complication, and these are the late complications. And now coming to the prevalence, it is more prevalent in females than male. That is the ratio of 3:1. Now coming to the results, according to the percentage of general dental practitioners, the dental
is highly prevalent with a percentage of 80 to 90.
And followed by recession, gingival recession, that is around 62%. And the last is the galvanic response, that is around 1 to 2%. Now coming to the conclusion,
we have the
is greater in
and then lip piercing, longer
tongue and piercing is associated with greater prevalence of dental defects and gingival recession, and
with greater attachment loss and probing depth of the tongue piercing, and this of the
side. Sometimes
filament morphology affects the integrity of the periodontium.
Thank you.
Which is more severe, tongue piercing or lip piercing?
Tongue piercing is more severe as it
leads to the gingival recession in the lingual aspect of the tooth, and we will see the ulcers also. It is seen over. It is more and atresion, gingival atresion.
Yes, the tongue is also very much vascular when compared.
Yes, ma'am. And we can see Ludwig angina in the if we are doing the tongue piercing, we can see the Ludwig angina also over there.
Okay. So everything depends on your more ornamental morphology, how big.
Yes, ma'am.
Yes, right?
Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
Thank you. No questions.
Thank you. Mr. Shailesh, can we have CLR poster 116? Mr. Shailesh?
Yes, ma'am.
Can we have CLR poster 116, please? The participant is waiting.
Is 116 Dr. Kedashwari.
Right.
Some internet issue with Dr. Kedashwari, ma'am.
Okay. Dr. Kedareshwari, are you here? Shailesh, is CLR PO 117 in? I think we can have that session done. I think, yes, Dr. Gopal is in.
Yes, ma'am.
So can we have the next poster then? CLR PO 117 poster, please.
Hello.
Yes, doctor. Yours is yes. Please go ahead.
It has been written 116 over there. Can I start?
That's okay, doctor. Please, this is your title, right?
Yes.
Yes, please go ahead.
Good afternoon, judges. My topic for the poster presentation is association of nasolabial angle and lip length with the gingival and interdental smile line, a gender-based evaluation. Coming to the introduction, smile is considered to involve voluntary changes in facial musculature, indicating social expression of happiness, greeting, and pleasure. Essential of aesthetic smile include a hormonal relationship of teeth with facial structure, such as lip framework and gingival scaffold. So the maxillary lip length and the nasolabial fold can change the musculature and after smiling. So we planned with so the study was planned with the aim to evaluate and correlate nasolabial angle and lip length with the interdental and gingival smile line in periodontally healthy patient based on gender. Hoffman et al. In 2012 classified the gingival and interdental smile line as a high gingival smile line in which there is a display of gingiva. In the image we can see the poster, and where there is no display of gingiva, it has been low gingival smile line. And in case of cupid bow, where there is there's no display of gingiva in the zenith of the central papilla. Similarly, in interdental smile line, there is display of gingiva, and low gingival smile line, there is no display of gingiva. And the cupid bow, there is no display of gingiva, only at the interdental of the central incisors. So the study was included 120 periodontally healthy patient which has a clean, good alignment, and those who are not gone for the any dental treatment were included in the study. 60 male and 60 females were included, and the photographs were taken in the lateral and lateral position at rest and smiling, and at front straight position at rest and smiling, and the images were measured on the image software. Coming to the result, the difference of the nasolabial angle and grit length during smiling was higher in female compared to the male, and the majority of the female presented high gingival smile line in the male, and the majority of high interdental smile line was presented by both the groups. So coming to the conclusion, nasolabial angle and lip length influence the quantum of the gingival exhibit in the maxillary anteriority with a definitive sexual dimorphism, and this can be considered a valuable reference point in smile designing procedure. Thank you.
Ma'am, sir, any questions?
Seems to be more like a morphometric
Thank you.
analysis.
Thank you, doctor.
So, yeah, thank you.
Thank you. Thank you. Thank you. Mr. Shailesh, can we have CLR poster 116, please? The participant is in. Dr. Kedar Ishwari. Doctor, please unmute yourself.
Yes, ma'am.
Yeah, please go ahead with your presentation.
Okay, ma'am. Thank you, ma'am. Good afternoon, everyone. Today I am going to present a poster about morphometric variation in maxillary central incisors and its influence on gingival characteristics, a preliminary epidemiological study in an Indian population. The presence of interdental papilla between the maxillary central incisors has its influence on the aesthetics and the biological function. The preliminary investigations indicate that there is an association between the two different crown forms and the periodontal characteristics. So the main objective of this study was to compare the influence of different crown forms of maxillary central incisors on its gingival characteristics. A total 100 systematically and periodontally healthy patients were selected with well-aligned bilateral maxillary central incisors. In their initial visits, they were the gingival thickness of each patient were noted with the help of a probe visibility method, and the presence or absence of interdental papilla. If the papilla completely fills the interproximal space, it is noted as present or it is noted as absent. If it is not present, it is noted as absent. And the impressions of maxillary anterior extent was taken, and then the crown length, crown width, and the gingival angle were measured. The crown length was measured from the most apical portion of the gingival marginal gingiva to the incisal edge, and the crown width. The crown length was divided into three equal portions. That is cervical portion, middle portion, and the incisal portion. And the crown width is measured at the junction between the crown cervical and the middle portions. And the gingival contact surface area is measured from the apical portion of the contact point to the incisal portion of the mesial surface of the maxillary central incisors. And the gingival angle is defines the degree of curvature of the marginal gingiva, and it is a line formed at the intersection of two lines connecting from the apical portion of the free margin gingiva along the long axis of the tooth of maxillary central incisor to the apical portion of the contact point mesially and the distally. The crown, different crown forms and the gingival angle and the contact surface to crown length ratio and crown width to crown length ratio were noted as a mean plus or minus standard deviation. The result shows that the triangular crown form shows the absence of interdental papilla, whereas a square crown form shows the presence of interdental papilla. And the gingival angle the gingival angle also shows that there is a highly significant relationship with the different crown forms. So I hereby conclude that the varied crown forms has its influence on the gingival characteristics, which acts as a valid guideline for the prosthetic restorative or anterior implant placement. Thank you.
Thank you. See, your tapered form shows more fill than your square form. The picture that you have shown, your square form, your tapered form is showing more fill than your square form. Anyway, thank you. Right.
Thank you.
Thank you.
Thank you, doctor.
Thank you.
Thank you. Just Mr. Shailesh, is Dr.
Yes.
Sharmila in?
No, ma'am.
No, right? Okay,
It's not
so
picking
I
call
think,
also, yeah.
okay, I think we are done with the session. So we have come to the end of the session. So we are highly honored to have senior people like you, ma'am, and sir, Muthukumar sir. Thank you so much for judging the session so patiently. We would like to have your evaluation sheets till the end of the day.
Oh, yes, sure.
Thank you, ma'am. Thank you all participants.
Thank you, Dr. Sangamitra.
Thank you. Thank you.
Thank you. Good.
Thank you, ma'am. Thank you, sir. Thank you.
Yeah.
A very good afternoon to one and all present. I hope I'm audible.
Yes, ma'am, you're audible.
Thank you. Okay, on behalf of 45th ISP Conference Scientific Committee, I would like to welcome all of you for this session. I extend a very warm welcome to all the delegates, the presenters, and the judges for this session. To begin with, I'd like to introduce the judges of this session today. We have Dr. Prerna Kataria ma'am, who's an excellent academician with work experience of more than 13 years, who has various national and international publications to her credit. And along with Dr. Rajdeep sir, who's currently affiliated to High Tech Dental College and Hospital, Bhubaneswar, and has his expertise in field of implantology and is a superlative academician. So we could good afternoon, ma'am. Sir, we'd like to begin with the session.
Good afternoon.
Dr. Shailesh,
Good afternoon.
Could we just begin with the presentation?
Yes, ma'am.
Can we start? Dr. Shravanti, you could start with your presentation, please.
Yes, ma'am. Good afternoon, everyone.
Title of my poster is Knowledge, Attitude and Practice of Oral Hygiene Aids and its Role in Prevention of COVID-19 Transmission in Hospital-Based Questionnaire Study. Introduction. The global outbreak of the novel coronavirus disease has brought to the forefront the importance of hand hygiene and sanitization. As the oral cavity is the portal for the viruses in the body, it is sensible to state that oral hygiene is essential in reducing infection from the oral cavity. Mechanical plaque control is the mainstay behind maintaining a healthy and plaque-free oral cavity. Furthermore, to avoid cross-contamination, it is important to make sure that oral hygiene aids are not in the same container. However, there is less focus on the oral care to reduce viral load and to prevent the risk of cross-contamination. Hence, the aim of the
Dr. Shravanti, your voice is not audible.
Ma'am, am I audible, ma'am?
Yeah, please
Hello?
continue.
Yes, ma'am. And the object is to assess oral hygiene habits and to evaluate care and disinfection control behaviors of oral hygiene aids. Coming to materials and methods, this was a cross-sectional descriptive study involving patients visiting our college, and resulting sample size was 385, considering 95% confidence interval. And the questionnaire included demographic data, history of COVID and vaccination status, and other part included questions regarding knowledge, attitude, and practice of oral hygiene aids and its role in prevention of COVID-19 transmission. Results were analyzed using chi-square test, and mean age of the population was 40.11 years and had almost equal proportions of males and females. 22.6% of the population has suffered from COVID and 92.7% got fully vaccinated. Knowledge of COVID-19 transmission through oral hygiene aids was found in 57.4% of the population, and no difference in knowledge of oral hygiene aids and its role was found between gender. The results have highlighted associations with that sharing oral hygiene aids among individuals could be a potential route of COVID-19 transmission. To conclude, the use of appropriate use of oral hygiene aids and good practices could prevent the transmission of COVID-19. Thank you. Thank you.
Hello.
Sir.
Are you audible?
Yes, sir. Please continue.
Yeah. So ma'am, according to you, which is the best choice of mouthwash which should be advised to the patient or to a patient for COVID for preventing COVID-19 transmission? Is it COVID-19 or is it chlorhexidine?
COVID-19.
Okay.
Dr. Prerna, ma'am, please.
Yeah, there are COVID ward in every hospital, and I have seen approximately 5 to 10 patients in a single ward. So what do you think the oral hygiene measures are satisfactory on that aspect? Hello? Hello? They are using the common washrooms and, the common...
Basins.
Hello? Maybe there is some network issue.
Dr.
Am I
Shravanti?
audible?
Yes. Yes, you are audible, ma'am. Apparently, I guess Dr. Shravanti has got some
So
connectivity
what is
issue.
the role of the oral hygiene aids in prevention of COVID-19 transmission in a single ward patients?
Oral hygiene aids should not be kept in same container.
Maybe there is some network issue. You are not audible. Okay, can we
Actually,
move
ma'am,
to
that's the end of her slot. Yes, yes.
yeah,
Can we
move
have the
to
next
another?
presentation,
Yeah.
please?
Yes, ma'am.
Dr. Farah, please start with your presentation. Dr. Farah, please start your presentation.
Is I'm audible, ma'am?
Yes, yes, please continue.
Okay. Good afternoon, everyone. The title of for my today's poster is Knowledge, Attitude, and Practice Regarding Infection Control Measures Among the Dental Student During COVID-19 Pandemic. Introduction. COVID-19 has rapidly emerged as a public health crisis globally. A large number of healthcare providers have been reported to contract this infection in hospital setup. The spread of COVID-19 poses a significant challenge in dental setup, and the healthcare providers are potential carriers of COVID-19 infection. Hence, it is important to implement preventive measures in dental setup to check the spread of COVID-19 infection. Thus, the aim and objective of my study was to assess the level of knowledge regarding infection control measures among the dental students, to evaluate the attitude towards the infection control measures among the dental students, to assess the practice of infection control measures among the dental students. The methodology. A questionnaire consisting of 15 questions were divided into 3 parts as knowledge, attitude, and practice, each consisting of 5 questions. Were created using Google form, and the link was shared and data was collected from the students. The distribution of the study participants was divided according to their status: final year BDS, interns, and postgraduate students. Total number of 103 participants were evaluated. The findings had been statistically evaluated using the chi-square test and SPSS software to calculate the distribution of the responses of the study participants according to their knowledge, attitude, and practices. The p-value that was less than or equal to 0.05 was statistically significant. The result was among the total study participants, 27% were final year BDS, 37% were interns, and 34% were postgraduate. In regards to knowledge category, according to the status, there was statistically significant difference between the knowledge adequacy and status of the study participants, whereas the final year BDS participant had more inadequate knowledge compared to interns and postgraduate. With regards to attitude, with respect to the attitude towards the adherence to the infection control measures, the majority of the respondents believed that infection control measures to be necessary. Hence, there was a positive attitude towards the infection control measures. Hence, there was no statistically significant results were seen. With regards to practice, there was a statistically significant difference between the practice and the status of the study participants. The practice of the final year BDS students were poor when compared to interns and postgraduates. Thus, my study concluded that that the overall participant had a positive attitude towards the infection control measures against the COVID-19. However, due to inadequate knowledge of the final year BDS students, they had a poor practice compared to interns and postgraduates in regards to infection control measures during COVID-19 pandemic. Hence, more emphasis should be given in educating the undergraduate students so as to enhance and upgrade their knowledge about the infection control protocol. Thank you.
So what was the main reason behind that? They are not aware of that knowledge and practice among the,
Ma'am, there
for
was
the
like a
infection
slight
control.
carelessness might have been seen.
What was the reason?
Among the final year BDS, like they had inadequate, carelessness or like inadequate knowledge as compared to like interns and the postgraduates.
I think finally BDS always emerge in the more dental practice, more clinical. They are doing more clinical work.
Yes.
So is that the reason? Okay, Dr.
Ma'am,
Azim, please.
in regards to COVID-19, like
Yeah, in pandemic.
Prerna ma'am, maybe they haven't attended the college properly during this
Yes.
time. That might be a reason.
ma'am,
Yeah,
they
the
had like
online
inadequate
actually
knowledge,
virtual classes
so
were there.
so practice like they had little few carelessness, and like when they returned back like from the lockdown and everything, so they had a little bit of carelessness in their practice.
Yeah, maybe.
I mean,
Okay. Dr. Azim,
Yeah,
do
ma'am.
you
Yeah,
want to
so
ask?
no, ma'am.
Yeah. Okay. Next participant, please.
Thank you.
Shailesh, can we have the next poster, please?
Yes, ma'am.
Mr. Shailesh, please upload the next poster.
Yes, ma'am.
Good afternoon, everyone. I hope I am audible to everyone.
Yes, ma'am.
Dr. Rima, please continue.
Good afternoon, everyone. Today I'm going to present a poster on the epidemiological survey, which was a questionnaire-based survey titled Awareness About COVID-19 Among Dental Practitioners in Western Maharashtra, which was framed with an aim to evaluate the knowledge among dental surgeons for basics of COVID-19 in the wake of current COVID-19 pandemic. The questionnaire consisted of 20 close-ended questions in English language, and the main source of the data collection was online questionnaire using various social media platforms. Dental students, staff, and practitioners from Western Maharashtra were included in the study, and total of 282 responses was obtained using convenience and snowball sampling. The questionnaire design was basically divided based on 4 categories, namely knowledge regarding basics of COVID-19, method and time interval for sample collections of COVID-19 patients, clinical aspects and practice during COVID-19 pandemic, and infection control and treatment aspects. So coming to the results, 87% of the participants believe that COVID-19 is caused due to SARS-CoV-2 virus, while 70% dentists recommended the use of telecommunication and pharmacotherapy. Confusion was about the use of rapid antigen kit was noticed among the participants. Also, the participants were unsure about the time interval for sample collection of COVID-19 patients. Coming to the discussion part, in accordance to a study conducted by Sue Mallet et al. In 2020, approximately half of the respondents from the present study agreed that upper respiratory tract samples should be collected after every 10 to 14 days. While in present study, more than 90% dentists reported that individuals from all age group can be affected by COVID-19, while Gio et al. In 2020, in his study, stated that only elderly people with underlying disease with a mean age of 47 to 59 years are most commonly affected. Loss of smell and taste sensation was considered as one of the symptoms of COVID-19 in the present study, which was in accordance to the study conducted by Joachim Müller et al. In 2020. According to 83% participants of present study, RT-PCR is the laboratory test for the diagnosis of COVID-19, which was similar to a study done by Hongzhi Liu et al. In 2020. So to conclude, overall good knowledge about the COVID-19 among the participants was seen, except in the area of screening tools available for detection of novel coronavirus. So there is the need to create more awareness regarding screening tool and diagnostic laboratory tools available for COVID-19. Sound knowledge among the participants was observed in the terms of clinical aspects and infection control measures, which will further prevent the spread of COVID-19. Though certain limitations in terms of limited sample size and responses obtained were still exist with the present study. So further studies are needed with a larger sample size to extrapolate the results to a larger dental fraternity.
Dr. Rima, I'm sorry to interrupt, but that's the end of the time slot. Ma'am, sir, we could proceed with the question answer.
Yes. Tell me, what is the best safety measures among the practitioners?
Basically, the dental practitioner, the distance between the practitioner and the patient is about 35 to 40 centimeter. The best way to prevent or to take care is using following proper protocols like wearing PPE kit, mask, face shield, and to keep a distance as much as possible from the patient while performing procedures which involves the aerosol production.
Okay. Do you think RT-PCR is required in each and every patient before entering into the clinic?
Ma'am, it is not really necessary if the patient is asymptomatic or if there is no history with the patient or family of the patient. It is not really necessary.
Okay, thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Dr. Shailesh, next poster, please.
Yes, ma'am.
Hello, sir. I'm audible.
Yeah.
Hello, I'm audible.
Yes, ma'am.
Okay. Good afternoon, respected chairperson. I am here to present a poster on the topic of spectrum of changes in the thickness of attached gingiva among the tribal population of Chhattisgarh state. As the term gingival biotype was introduced to describe the thickness of the gingiva in a buccolingual dimension. So various studies have revealed a wide range of clinical differences in tissue biotype to form a thickness in the individuals. In recent years, dimensions of the different parts of the masticatory mucosa, especially gingival thickness, has become a subject of considerable interest in dentistry, both from the epidemiological, aesthetic, and therapeutic point of view. So the objective of my study is to evaluate the thickness of the attached gingiva among the tribal population of the Chhattisgarh, to evaluate the thickness of the attached gingiva among the urban population of the Chhattisgarh, and to compare the changes in the thickness of the attached gingiva between the tribal and urban population of Chhattisgarh. As it is a pilot study comparing the gingival thickness in the tribal and urban population of the Chhattisgarh. So the total sample size is 48, tribal of 24 samples and urban of 24 samples. The inclusion criteria including age of 18 to 45 years and individuals having healthy periodontal tissues with less than 20% of bleeding on probing and presence of all anterior teeth in upper and lower arch. The exclusion criteria including the gingival recession, pregnancy and lactation, smokers, use of any medication such as cyclosporin or calcium channel blocker, any systemic diseases, or patients with the previous orthodontic treatment. So here are the materials that are used. The procedure, the procedural steps including the oral prophylaxis followed by the anesthesia of the attached and interdental papillary area. After that, with the help of UNC 15, the gingival thickness is measured, and after that, the vernier caliper is finally used to measuring to record the thickness of the attached gingiva. The result shows the statistically significant difference in the maxillary arch of the tribal and urban population. So coming to the discussion, the prevalence of the thick gingival biotype differs in the races, ethnicity, and geographical location. A higher proportion of thicker biotype in the tribal population compared to the urban population has suggested a need for the investigation in genetic factors that can affect the gingival biotype. Another possible explanation is related to the differences in the methods of measurement and measurement points. So concluding my presentation, the proportion of the thick gingival biotype compared to the thin biotype in maxillary arch was higher in the tribal population of Chhattisgarh. Hence, it could have a positive influence on the gingival biotype. Thank you,
Dr.
everyone.
Vaida, sir, ma'am, could you continue with the question answers, please?
Yeah, tell me the significance of adequate width of attached gingiva.
Yes, ma'am. If there is an adequate width of attached gingiva, then there is a proper masticatory forces that have proper masticatory forces. It can prevent the trauma from occlusion, or it can prevent the further inflammation that causes the destruction of the periodontal periodontium.
Is there any other significance? Why we required the attached gingiva?
Yes, ma'am. Ma'am.
Okay, Dr. Razdeep.
Yeah, and instead of using the DNC 15 probe, would we have used any other instrument? It would have been
Yes,
less
sir.
traumatic.
Yes, sir. We can use endodontic reamer with stopper that can cause lesser trauma to that area, sir.
Okay. Thank you.
Thank
Ma'am,
you, sir.
any more questions?
Thank you. Mr. Shailesh,
Yeah,
next poster,
participant.
please.
Yes, ma'am.
Mr. Shailesh, please keep a watch on the timer, please.
Yes, ma'am.
Good afternoon,
Please.
ma'am. Good afternoon, ma'am. Good afternoon, sir. Am I audible?
Yeah.
My poster is on proposal of novel functional risk assessment model, that is modified implant disease risk assessment model based on the conventional risk assessment model which was given by Heath Mayfield in 2020. So this is a nine-sided polygon in which primary stability is included as an additional factor. So the importance, the rationale for adding primary stability is it is a very essential criteria in order to achieve osseointegration. The primary stability is very important. So it is a factor which depends on both patient related factors as well as the procedure factors, that is the type of the implant and the surgical procedure. The patient related factors like the bone quality and the bone density. So if we include this parameter into this model, there would be more accurate risk assessment done. So the primary stability was included. The primary stability was included based on the ISQ scale, that is the implant stability quotient, based on resonance frequency analysis. The ISQ scale was having a range of 60 to 70, and the codes were given from 0, 1A, 1B, and 2, 4 codes, and the risk was made as low, moderate, or high. So when the code is when the range is 70, the code is interpreted as 0, and the risk is no or minimal risk, and is depicted as normal green. And when the code is 1A or 1B, it stands for moderate primary stability level, where 1 is in the range of 65 to 69, 1B is in the range of 60 to 64, 1A is for low risk, that is the yellow figure, yellow web, and 1B is for the 60 to 64 range, where the risk is in the orange color, it is moderate risk, and when it is below 60, the code is 2 and indicates that the patient has high risk and the stability is very low. So in this way, we can assess the risk levels for the patient to develop the implant disease. So by adding this parameter, both the patient side as well as the operator side parameters are included, which will assess the furlong success survival of the implants. So to conclude, compared to the conventional IDRA, this novel modified IDRA would be helpful for assessing the development of implant disease more accurately, so precise management of the patient can be done. Thank you.
So, ma'am, could you
Yeah,
continue with the
what are the
question?
factors? Yeah, what are the basic factors required to achieve the primary stability of an implant?
The basic factors are the first thing is we have to choose a proper bone, like the bone should be having a adequate amount of density. Then is sufficient bone volume should be present. Then is we have to consider a proper implant size, like usually the root form implants which are tapered will have more stability. And then is the surgical procedure, the orientation of the implant should be proper, so that we place the implant exactly at the center of the ridge. These factors will depict the primary stability mainly.
What is the minimum torque which we should achieve?
The minimum torque should be above 55, sir, according to consensus report, fifth world workshop. Hello.
Hello.
So,
Hello. Yes.
So,
Yeah,
are there
no,
any more
it's okay.
questions?
No, thank you.
Can we have the next poster, please?
Dr. Sriraj?
Yes, sir. Good afternoon, respected chairpersons. Today I'm giving my poster presentation on knowledge among dentists and medical practitioners in India about bidirectional relationship between diabetes and periodontitis. We know various systemic reviews support a bidirectional relationship between diabetes mellitus and the periodontal disease. The diabetes mellitus is a risk factor for developing periodontal disease, and patients diagnosed with the diabetes are considered as high risk group with a greater susceptibility to severe forms of periodontal destruction. The dramatic increase of well-established bidirectional relation between diabetes mellitus and periodontal makes it essential for patients with diabetes mellitus to pay attention to their periodontal status. The objective of the study was to assess the knowledge and awareness about bidirectional relation between diabetes and periodontitis among dental and medical practitioners. There was a cross-sectional study, the distribution study carried out among the dental and medical practitioners. The questionnaire prepared via Google form and snowball sampling was done, distributed via email and WhatsApp. Coming to the results of the study, most of the age group that responded was less than 30 years of age among medical and dental practitioners, and the gender that male practitioners were more in the study, the respondents, and the professional experience whoever responded was less than 10 years of experience, and most of the area in India have been responded in that survey. Coming to the awareness about the among the practitioners, most of the question gave the statistical significant results, and among that, the number of patients that managed the average managed in the last year was less than 10% among the medical practitioners, and the awareness, the questions about awareness of the dental diabetic and periodontal disease was less. Respondent was in medical practitioners. Coming to the discussion, oral health has not been traditionally viewed as a part of general assessment within the medical practice, according to Sheham. According to Moradian in 2005, medical students have insufficient knowledge of oral systemic interactions and oral health disparities across training years. And less than third of endocrinologists reported that they would frequently advise patients with diabetes mellitus to visit a dentist. And the majority agree that the medical professionals should be taught about oral health, which is consistent with the previous study conducted in North Carolina by Owens. And Coming to the conclusion, the present study concludes that there is sufficient knowledge about bidirectional relation between diabetes mellitus and periodontitis among dental practitioners than medical practitioners, and overall positive response about relation was more. So there is a need to give proper knowledge among medical practitioners regarding the periodontitis and its relation to diabetes and its complication.
Okay, now is it concluded?
Yes,
Hello?
sir.
Yeah. Now tell me, is the diabetes mellitus is a risk factor for periodontitis, or the periodontitis act as a risk factor for the diabetes mellitus patient?
Yes, ma'am. Both have the bidirectional relationship. In periodontal disease, there is a more inflammatory markers and C-reactive protein, the excess C-reactive protein toxins released from the by the bacteria. It affects the insulin resistance. The receptors that helps in uptaking of insulin to the tissues. It affects the insulin resistance, and the same way, the increased advanced glycation end products in diabetes mellitus also affects the periodontium by more collagenous activity and having more collagenous activity and more collagen destruction and less turnover rate of collagen. So there is a bidirectional relationship between both the disease, periodontitis and the diabetes mellitus.
Okay, thank you. Dr. Asif?
Can we perform a periodontal surgery in someone who is suffering from diabetes?
Sir, we can perform periodontal surgeries after making the patient normoglycemic. Like hyperglycemic patients will be having more destruction. So patient, we need to tell the patient to control the diabetic condition by taking the medications, and after controlling the diabetic condition, after giving proper test and all, we can proceed with the scaling and root planning initially. Then after that, by reviewing the response of the initial periodontal therapy, we can go for surgical therapy.
Thank you.
Thank you, sir.
Mr. Shailesh, next presentation, please.
Yes, ma'am.
Dr. Himaja, please start with your presentation.
Good afternoon, ma'am. Am I audible?
Please continue. Please continue.
Yes, good afternoon, everyone. Today I'm going to present my paper titled The Comparative Evaluation of 3 Desensitizing Agents in Reducing the Dentinal Hypersensitivity Following the Ultrasonic Scaling. So coming to aim of the present study is to compare the efficacy of the 3 different mouth rinses in relieving the hypersensitivity following the ultrasonic scaling. Coming to introduction, dentinal hypersensitivity is a common consequence following the ultrasonic scaling in a periodontitis patients, and management of dentinal hypersensitivity include a variety of agents for use at home or in office. And mechanism of actions of these agents is by nerve desensitization, protein precipitation, plugging of the dentinal tubules, sealing dentin, or ablating with laser. Most commonly, toothpaste containing the desensitizing agents are used to treat the dentinal hypersensitivity. Mouth rinses, they provide an alternative means of delivering these agents to the dentinal pulp complex. So as there is very scarce data available on the mouthwashes, I have chosen the study. So coming to methodology, a total of 80 patients were included in the present study. Among these patients, they were divided into 4 groups, and the test group patients, they were used to ask 3 different mouth rinses. That is, group A were group A patients were recommended to use the Rexidine Please, and group B, they were asked to use the Sensodyne K, and group C, they were recommended to use the Hyora K, and the 4th group, they were not given any mouthwash. And the assessment of the hypersensitivity was done using the cold blast test and the visual analog scale at baseline and at 7 days after the administration of the mouthwashes. So coming to the statistical analysis, we have measured the standard deviation and the variance on the variance. So the results, they have shown that the Sensodyne K has showed greater variation in the pain when compared with the other three mouth rinses. And when coming to the group, like for the patients who have used the mouthwash and who have not used the mouthwash, the patients who have used the mouthwash, they have shown reduction in the hypersensitivity when compared with that of the patients who have not used the mouthwash. So coming to the discussion part, from the results of the present study, it is evident that all the three mouthwashes, they showed a reduction in the hypersensitivity, and these results were in accordance with the studies which were previously conducted by the Peria et al. In 2001 and Sunita Sharma, who have demonstrated that mouth rinses which contain potassium nitrate had reduced the hypersensitivity. And coming to conclusion, all the mouthwashes, they have showed the
Dr.
reduction.
Himaja, that's the
Sensodyne
end of
K
your
has
time,
showed
please.
better
Can we go
reduction
ahead
in
with the question answers?
Okay, ma'am.
Yeah,
Ma'am,
tell
sir.
me. Yeah, tell me what is the most common cause of hypersensitivity, dentinal hypersensitivity? Most common.
Gingival recession, ma'am, and loss of the enamel and will cause mostly gingival recession, cervical ablation, saturation, abstraction.
Yes. And what is the significance of Novamine? Have you used Novamine contain
Yes, ma'am.
mouthwash or the dentifrices?
No. Sorry.
Okay, Dr. Razi?
So what are the other measures to control hypersensitivity apart from using dentifrices or mouthwashes?
Sorry, sir, I'm not able to hear you.
What are the other measures of controlling
Yes,
hypersensitivity apart from using dentifrices or mouth rinses? Is there any other measure we
we can use the adhesive sealers, sir, like fluoride varnishes, oxalic acid, this, and we can also use the lasers, sir. And dentin bonding agents, glass ionomer cements can also be used, sir.
Thank you.
Thank you, sir.
Dr. Shruti, please start with your presentation.
Yes. Hello. Am I audible?
Yes, yes, please continue.
Good afternoon, judges. The topic for my poster is knowledge, awareness, and attitude of PRF among dental students on its use in periodontics. Coming to the introduction, periodontal tissue regeneration has always been a dare for the periodontist because of its structural intricacy. But with tissue engineering, this aim has partially been fulfilled with bone grafts and substitutes such as GTR membranes and growth factors. So PRF is prepared from the patient's own blood, that is activated platelets become closed among a fibrin metric scaffold and release growth factors, cytokines, playing key role in tissue regeneration, including cell proliferation, differentiation, extracellular matrix synthesis, chemotaxis, and angiogenesis. So knowledge, awareness, and attitude regarding PRF by dental students during their academic years are crucial due to its direct influence on their attitude to create awareness and perform appropriate treatment modalities at the community level to achieve good periodontal health. So the objective of this study was to evaluate, assess, and compare the knowledge, awareness, and attitude of PRF among dental undergraduates and postgraduates on its use in periodontics. Coming to the methodology, a questionnaire-based study comprising of questions evaluating the awareness, knowledge, and attitude on the use of PRF in periodontics was conducted among 100 students, that is both undergraduates and postgraduates, and the results were tabulated. So a total of 31 questions were asked on awareness, knowledge, and attitude. So coming to the awareness, most of the undergraduates and postgraduates were aware about the use of biomaterials in periodontics and also were aware about the use of PRF. But only 55% of the undergraduates were aware of the different types of PRF and also the components present in PRF. Now, coming to the knowledge, most of the undergraduates were not very sure about the use of different materials, use of PRF in different fields of periodontics. But coming to the use in postgraduates, 68% felt that it was technique sensitive, and only 65% felt that it was cost effective, and only 50% felt that the PRF decreases the healing time period, and also believe that there are disadvantages present with PRF. Coming to the attitude, around 39% felt that the PRF will be successful in all cases of periodontal treatment, and only 21% agreed that the patient will accept PRF as a treatment modality in periodontal surgeries. While most of the answers, such as whether they were provided with sufficient information regarding PRF in BDS curriculum, only 79% agreed that they were given less information during their BDS curriculum, and also 89.5% agreed that they would have liked more information during the BDS curriculum, and they had responded that 60% wanted the information regarding PRF through clinical exposure rather than CDE programs and also discussions. Now, coming to the results, so majority of the study population were aware about the PRF and its advantages, and only the postgraduates had a better understanding and knowledge about PRF, and entire study population agreed that they were given less information during their BDS curriculum. Now, coming to the discussion and conclusion, the present study clearly shows a lack of knowledge among the undergraduate students during their early academic life regarding use of PRF in periodontics. Hence, steps should be taken to incorporate positive knowledge by creating problem-based education system in the curriculum. Thank you.
Ma'am, the questions,
Hello.
please.
Yeah, do you think that this kind of knowledge and awareness, of such kind of surgical topics, they help in choosing MDS in perio?
Ma'am, like if they were aware about, like most of the undergraduates, if they are aware about such techniques used in periodontics, maybe in clinical practice, like who are not going to pursue post-graduation, it might be a little more helpful for such undergraduate students now.
Okay, thank you.
Yes, thank you.
Sir?
Yeah. Hello.
Rajiv, sir, you have a question?
Yeah. So, have you heard about PRGF?
Sorry, sir?
Have you heard about PRGF?
PRGF, sir? Platelets is growth factor, sir?
Yeah. So, do you think PRF or PRGF is better? Comparing PRF or PRGF, which is better, you think?
Sir, I'm not really sure about it, sir.
Okay. Thank you.
Yes, thank you, sir. Thank you, ma'am.
Thank you, Mr. Shailesh. Please, next poster.
Yes, ma'am.
Good afternoon, ma'am. Am I audible?
Yeah.
Yes, please continue.
Good afternoon, one and all. I'm here to present a poster titled as Knowledge, Attitude and Practice of Teleperiodontics Among Dentists. Is it the required upgrade to conventional periodontics? As it is not new that the integration between the digital and telecommunication technology in the health sector to provide health care for the individuals far away to reach a hospital is well known. And teleperiodontics, which is a branch of telehealth which focuses on application of digital communication technology without demanding a specialist presence on site, thus enabling a wider reach to the patients. And this modality of teleperiodontics and teledentistry has become more popular since the advent of the pandemic. The aim of the study is to assess the knowledge, attitude, and application of teleperiodontics in everyday dental practice. And the objectives include knowledge about teledentistry and teleperiodontics among the dentists, attitude on teledentistry and teleperiodontics, and application of teledentistry and teleperiodontics in everyday dental practice. The methods and materials included an electronic questionnaire of 29 close-ended questions were circulated via email and WhatsApp to to the dentists in the East and West Godavari districts of Andhra Pradesh, of which 350 responses were received. The questionnaire contained 7 sections, and the first section contained demographic details, which are age of the dentist, their qualification, and the gender of the dentist. And the other sections included the knowledge about teledentistry, their periodontal diagnosis, attitude towards dentistry, attitude towards teleperiodontics, practice of teledentistry, and practice of teleperiodontics in everyday dental practice. And all of these results were statistically analyzed using chi-square test, and a 95% of confidence interval was kept. Coming to the results, statistically significant results were obtained for the following questions that have been displayed on the poster in various sections, and each question belongs to one of the sections that I've mentioned above. It has been found that 80% of the dentists who have responded have knowledge about teledentistry and teleperiodontics, of which 70% have been using teledentistry as in their regular practice in this pandemic. Coming to teleperiodontics, it is still a new science, and only 40% of the dentists were very confident about diagnosing or identifying a periodontal disease using the digital communication methods. And to conclude, I would like to say that this knowledge, attitude, and application of teleperiodontics is more popular among the newer generation of the dentists who belong to 21 and 30 years of age group. And the application of this particular science is yet very less, as proper protocol is yet to be formulated. Thank you. And I thank the ISP forum as they have allowed me to present the poster at this national platform.
Yeah, Dr. Razi.
Yeah, ma'am, I could ask a question. So, what do you think? What are the challenges which is related to teledentistry in present scenario? Are there any challenges which general dentists or dentists will face during this present scenario? Certainly, it will be helping us a lot. Yeah.
So?
Yeah, please carry on. Yeah, please carry on.
There are challenges in teledentistry in the present scenario, sir, as a definitive diagnosis is cannot be obtained. A physical presence of the patient in the dental office is mandatory to obtain a diagnosis, with which only the treatment can be effective. But to some extent, preventive measures can be employed in the patients for the management until an office visit can be planned, sir.
Okay. Thank you.
Mr. Shailesh, next section, please.
Good afternoon, everyone.
Please continue, Dr.
May I start, ma'am? Yes, ma'am. Good afternoon, everyone. The title of my poster is Knowledge, Attitude, and Practice Regarding Use of Various Mechanical Interdental Aids as a Preventive Plaque Control Method among Practicing Dentists in Ahmednagar, Maharashtra. The notion that plaque on teeth plays a role in destruction of tissues supporting the teeth is centuries old. Like we all know that periodontal disease is initiated by plaque formation, which if not removed on regular basis, leads to inflammation, periodontal tissue destruction, and finally tooth loss. The 1965 study by Lowe et al. Demonstrated the cause and effect relationship between plaque accumulation and gingival inflammation. Also, Linde and Associates demonstrated that gingivitis, if left untreated, progresses in periodontitis. And to seize this progression of plaque control comes into action. Plaque control is defined as removal of microbial plaque and food debris from the oral cavity. It can be achieved either mechanically or chemically. The mechanical method of plaque control is achieved by various types of toothbrush, different types of interdental aids, tongue cleaners, etc. And we being dentists are responsible to educate and motivate the general population to follow appropriate oral hygiene methods. But do we practice the same? And if we do, then what do we choose? This cross-sectional study aims to understand the self-reported knowledge and practices of dentists in Ahmednagar towards self-use of interdental oral hygiene.
Dr.
aids
Richa,
from
sorry to
their
interrupt.
premises.
Please put on your camera.
Yes, ma'am.
Please continue.
Yes, ma'am. The methodology is we used a pre-tested 20-item online closed-ended structured questionnaire and delivered it through email to the practicing dentists and faculty in Ahmednagar. The results showed that 173 participants responded out of 180. 69.7% dentists believe that interdental aids should be used customarily with toothbrushing. Overall, 76% dentists used interdental aids routinely, out of which 79% preferred dental floss, but only 24% used it every day. Among dentists with experience over 5 years, only 47% used interdental aids regularly, out of which 79% preferred dental floss. The female dentists were more conscious regarding the use of interdental aids when compared to the male dentists, and 28% females used interdental aids regularly, while only 12% male dentists used it on daily basis. Coming to the discussion, dentists showed adequate knowledge but irregularity in use due to lack of motivation. Majority of dentists still prefer dental floss, and there's a slight shift towards the newer techniques like water flosser. The experienced dentists showed better knowledge but did not religiously use the interdental aids for self-practice, while younger generation of dentists showed a better drive regarding self-practice of interdental aids. Lack of patient compliance was seen due to inadequate patient education and motivation on the dentist's own part. This was supported by studies done by Nakamura et al. And Daisy et al. To conclude, I'd like to say,
Dr. Richa, that's the end of your time, please. Sorry. Ma'am, could we go ahead with the question answer?
डॉक्टर रिचा आप कौन सा इंटरडेंटल क्लीनिंग यूज करते हैं?
Ma'am, I personally use dental floss.
Okay, yeah, me too. Okay, what is super floss?
Ma'am, I don't know.
What is new floss? Okay, Dr. Asif.
Thank you.
Thank you. Mr. Shailesh, next poster, please.
Yes, ma'am.
Am I audible now?
Yes.
Yes, please continue.
Our topic is appraising awareness on COVID-19 and oral health among medical and non-medical undergrad students, a questionnaire study. Coronavirus disease caused by SARS-CoV-2, a potentially fatal disease, has become a global public health concern. As we know, India is a densely populated country, and the understanding of this novel disease is evolving. It's important for the audience to be aware of the basic modes of prevention that can diminish the spread of the coronavirus disease 2019 infection. Methodology: the questionnaire is formed on the basis of the knowledge awareness, and it contains 20 questions about the definition, contagiousness, symptoms, incubation, source of infection, route of transmission, treatment, and infection control practices related to the COVID-19. A questionnaire-based survey was made in an offline mode and distributed among 1,200 undergrad students to investigate their knowledge and awareness about the COVID-19. The inclusion criteria was undergrad students were included aged between 18 to 25, and the first group was made up of medical students like medical, dental, nursing, pharmacy, and the exclusion criteria were the patients, those are previously or currently diagnosed with the COVID-19. Discussion. A careful analysis of the participants' responses showed that despite almost all of the medicos participants, 94%, and non-medicos, 91.6%, knew that COVID-19 is a contagious disease, and about 67.4% of medicos respondents and 15.2% of non-medicos knew the definition of SARS-CoV-2. Only slightly more than half of them knew 57.2% of medicos and 2% non-medicos about the COVID-19 definition. On the other hand, 66% of medicos and 14.8% of non-medicos knew the source of origin of COVID-19. In general, 76.2% of medicos and 76.6% of non-medicos think that first dose of vaccination is not sufficient for protection against the COVID-19. And when risk perception towards the healthcare personnel has been quantified, we found that only 49.2% of non-medicos assume that dentists are more exposed to the risk of infection than other health professionals. These findings also reveal respondents' knowledge of association between oral health and severity of the COVID-19, as almost more than half medical respondents, 21.4% and non-medicos 22.6% were aware of this association. And lastly, this response was confirmed that medicos 24.6% and non-medicos 18.6% have knowledge about diabetic patients more prone to COVID-19. The conclusion of my study is from the present study, we can conclude that awareness and knowledge regarding COVID-19 among medical and non-medical students were good. Most of them were aware of the precautionary measures to be followed during the outbreak, but a small part of the study population requires the education. Thank you, ma'am. Thank you, sir.
Yeah, Dr. Razi, please ask some question.
No, ma'am.
Yeah, next participant, please.
Mr. Shailesh, please, next poster.
Yes, ma'am.
Mr. Shailesh, next poster, please. Please start with the presentation. Unmute yourself, please.
Am I audible, ma'am?
Yes, please continue.
Yeah, a very warm good afternoon to everyone. My epidemiological research is a cross-sectional study to find out the prevalence of gingival recession and non-carious cervical lesion among the outpatient section of periodontology department in our hospital. We all know one of the major problem of periodontal origin is gingival recession. And this gingival recession, when occurring in concurrence with non-carious cervical lesion, the management becomes more complex. So the aim of the study was to evaluate the prevalence and association of gingival recession and non-carious cervical lesion. The study was carried out in 50 participants, and details about their demographics, oral hygiene status, which included the materials and the method of toothbrushing, was recorded. And indices like to evaluate the gingival recession and non-carious cervical lesion was also obtained. The type of gingival recession was recorded according to Cairo et al. As given in the 2017 classification of periodontal and peri-implant diseases and conditions. And the non-carious cervical lesion was recorded using Smith and Knight tooth wear index. And the results of the study showed that 41.6% of population had the presence of either gingival recession or non-carious cervical lesion. And the prevalence of gingival recession in concurrence with this non-carious cervical lesion was found out to be 17.5%. And this is highly significant. And based on the data obtained from the regarding the toothbrushing, it was found out 50% of the individuals used medium and hard bristle toothbrushes, and 36% were not even aware of the type of the toothbrush bristle. And these data are highly significant. And coming to the pattern of toothbrushing, 36% individuals used exclusive horizontal pattern of toothbrushing, and 60% used a combination of horizontal and vertical pattern. And this is also highly significant. So based on the results, it is very clear that gingival recession occurs in concurrence with non-carious cervical lesion. And also, this is highly influenced by the pattern of toothbrushing and also the materials, that is a type of bristles used for toothbrushing. So to conclude, the science and technology advancement has bestowed us with versatile treatment options even for the rarest diseases. But what we fail to look upon is the basic preventive measure that is readily available at the doorstep. So creating a proper awareness about the brushing method is the best preventive treatment to prevent this hard and soft tissue wear, that is gingival recession along with non-carious cervical lesion. So always alert the patient to avoid the tissue wear. Thank you.
Yeah, I think periodontists are always best. You tell me why they are best.
maybe we start our treatment from the beginning. Like every treatment procedure should begin from maybe brushing technique. We are the ones who
No.
educate the patients.
Your topic is hard and soft tissue because we are dealing with both the tissues.
Okay.
I think that's my opinion.
Okay. Okay.
Okay. Dr. Razi?
Do you think use of electric toothbrush are better to avoid gingival recession, or is it just a myth?
No, sir. I feel maybe who are not able to do it manually, for them it may be better. But this electronic toothbrush is never better than manual toothbrush for normal persons.
Thank you.
Thank you, sir.
Shall I start?
Please go ahead. Please start.
Good afternoon, everyone. The topic for my poster presentation is mucormycosis and COVID-19, forthcoming of the unforeseen. Several cases of mucormycosis in people with COVID-19 have been increasingly reported worldwide, in particular from India. Mucormycosis is an angioinvasive disease caused by fungi of order mucoril like Rhizopus, Mucor, Rhizomucor, and Cunninghamella. The aim of the present study is to obtain information about the primary and secondary etiologic factor predisposing an individual to mucormycosis. Coming to material and method, patient complaining of mobility of teeth, presence of multiple abscess, and pain in periorbital, frontal, and temporal region were provided with a screening questionnaire to obtain information on demographic detail, history of past COVID-19 infection, associated comorbidities, duration of hospitalization, drug taken during COVID treatment, and present signs and symptoms. After initial screening, clinical examination along with radiologic, blood, and microbiologic examination were carried out. 42 patients diagnosed with mucormycosis were selected for the study. On the right-hand side, we can see the image which shows presence of multiple abscess and presence of palatal perforation with pus discharge. Coming to the result, out of 42 patients, 39 patients gave history of past COVID-19 infection. The presence of comorbidities in mucormycosis, it was seen that there were 17 cases with newly diagnosed diabetes mellitus and 28 patients with pre-existing diabetes mellitus, taking the count to 25, which is more than 50% of the diabetes cases. The time interval between COVID-19 and development of mucormycosis. It was seen that majority of patients develop mucormycosis within a period of 1 to 10 days, while 3 patients develop mucormycosis during COVID-19 infection itself. The time interval between development of mucormycosis and patient reporting to the hospital. It was seen that majority of patients reported to the hospital within a period of 11 to 20 days. It was seen that the maxillary sinus and the ethmoidal sinus were more commonly involved. This was in accordance to the study conducted by Mehta et al. In 2021. Coming to the discussion, diabetes was found to be a primary etiologic factor and was present in more than 50% of mucormycosis cases. Diabetes is a pro-inflammatory state which leads to deficient control of SARS-CoV-2 replication. In this study, 22 patients were on steroid therapy. Though corticosteroids are considered essential therapy in patients with COVID-19 on supplemental oxygen, it has a risk for mucormycosis and its uses lead to drug-induced hyperglycemia. Coming to the conclusion, simple diagnostic measures including routine clinical and radiographic examination of moderate to severe COVID-19 hospitalized individual, along with periodic post-hospitalization evaluation and follow-up, can help in early management of mucormycosis and prevention of disabilities. Thank you.
What is the most common oral manifestation?
In this
Among
patient, we have found
COVID
that
patients?
there was presence of palatal perforation, presence of multiple abscess, then there was presence of mobility of teeth, and along with that, we were able to see necrotic areas around the oral cavities in the nasal area.
Okay, but that's in a very advanced stages of disease.
The most common manifestation, we see that there is an involvement of maxilla, and so there is abscess and mobility.
Okay, anything related to healing?
Yes, ma'am. There is a delayed healing, or healing does not occur.
Okay, thank you.
As the blood supply to the area is disturbed due to
Yeah.
presence of thrombosis and infarction.
Okay.
So what do you think is the main reason for rise in mucormycosis case in COVID-19 patients?
So can you please repeat?
So what is the main reason for rise in mucormycosis cases in
So we
COVID-19
can say
patients?
that
Is
in
it diabetes?
COVID-19 patient, there is an increase in pro-inflammatory state, and there is increased level of cytokine, interleukin 1, interleukin 4, and interleukin 10. So these, and along with this, there is a presence of pre-existing disabilities like diabetes, immunocompromised state. So in this condition where there is diabetes, there is an increase in hyperglycemia, which will dysregulate the COVID virus replication. Also, there will be insulin resistance. And along with this, when we use oxygen mask or ventilators, the surface might get contaminated due to the mucormycosis. So there are multiple factors playing a role, but in the study, we found that the diabetes is the most commonly associated factor. Also, along with this, there will be an increase in iron load.
Does prolonged use of steroids leads to mucormycosis?
So we can see that as the steroid leads to an immunomodulatory effect. So in steroid, there is also increase in hyperglycemic state. So it will favor the multiplication of hyper, and also the steroid are on the counter available in India. So which will further limit the proper use of steroids and hence can play a role. Also, there is a decrease in T cell and decrease in amount of chemoattractant. So the phagolysosome mechanism might get affected, due to which there will be more aggressive multiplication of the mucor fungi. Thank you, sir. Thank you, ma'am.
Next poster 039.
Good morning, everyone. Am I audible?
Yes, doctor. Please go ahead.
Okay. This is a preventive approach on the periodontal maintenance in pregnancy, nurturing for future. First, we see the changes. The hormonal changes includes the increase in the progesterone and the estrogen level by 30% and 10%. There is slight immunological depression in the cell-mediated immunity. In oral microbiota, we see that the level of the black pigmented bacteroids and the pre-intermedia Provotella have been shown to be increased. In pregnancy, there is a chances of preeclampsia. Also in the third trimester, there is the depression of the inferior vena cava caused by the gravid uterus. Coming to the changes in the periodontal, we see the pyogenic granuloma, which is shown to be the incidence of 1.8 to 5%. And the pregnancy gingivitis is a well-recognized entity for 30 to 100%. And also there is gingival enlargement caused by the drug-induced gingival enlargement, such as the calcium channel blockers and the immunosuppressant drugs. Coming to the drug used, acetaminophen have been widely used, and the tetracycline should be avoided during the pregnancy period as it causes the yellow discoloration of the fetus. Immunosuppressant drugs such as cyclosporin should also be avoided, and the anticonvulsant drugs such as the valproate should be avoided as it causes the neural crest defect. Smoking and alcohol should be avoided by the pregnant women as it causes the fetal alcohol syndrome. Coming to the premature birth, when there is increase in the prostaglandin level, there is premature birth. As prostaglandin increases the uterine contraction. Also, there might be slight sensitive gums seen in the pregnant woman due to the changes in the lamina dura, pregnancy gingivitis, and low birth rate periodontal diseases might be seen. Coming to the maintenance in the first trimester, every dental treatment can be progressed. The patient should be advised about the dental treatment prior to the treatment.
Doctor, Your time is up actually. Can you give us your conclusion? Yes, Dr. Lakshmi Priya.
Yes, ma'am.
You can just give us your conclusion.
Okay. So in pregnant women, we can perform the dental treatment in the first trimester, second and but however in the third trimester, the last few weeks should be avoided.
Any questions, judges?
Yeah, which microorganism level is increased in pregnant patient?
Pre-intermediate cytocapnophaga and
Why? Can you please tell me the reason?
because there is increase in the subgingival bacteria, subgingival plaque. So there is increase in the both the anaerobic and the aerobic ratio.
Do you know the term sclerotic therapy to remove the pyogenic granuloma? Hello.
No, ma'am.
Okay, go ahead. Dr. Razib?
Oh, thank you.
Yeah, can we have the next presenter, please? Dr. Kanchan Jagda, 040.
Dr. Kanchan, please start. Dr. Kanchan.
Dr. Kanchan, please unmute yourself. We can see you in the participant list, please. The time is running. Dr. Kanchan.
Can you move to next presenter?
Yes.
Yeah.
Yes, Ms. Finish, please go on.
Hello, ma'am. Am I audible?
Yes,
Yes, ma'am.
doctor.
Please start, ma'am.
Good afternoon to all the respected judges and the delegates present online. So this is Dr. Shailaja Mohan, and I'm presenting my topic on the management of medical emergencies in the periodontal practice. It is a KAP survey. So as to introduce my topic, I personally believe that the knowledge about the medical emergencies is very important and vital to all the dental healthcare professionals, as they need to act promptly and give the first aid care immediately. So coming on to the methodology, it was a cross-sectional survey and it has a validated questionnaire comprising of 56 questions, out of which 34 was knowledge related, 5 was attitude related, and 17 was practice related. And it has been split into the various clinical scenarios, as you can see in the center column of my the red cross which I have provided here, emphasizing the importance for first aid and medical emergencies. So the various clinical scenarios include the COVID emergencies, syncope, epilepsy, hemorrhage, foreign body obstruction, asthma, allergy, cardiac emergencies, and diabetic emergencies. And after obtaining the ethical clearance from my institutional ethics committee, I have set out this questionnaire to the targeted participants, which includes the basically the periodontists primarily, and also the graduated dental healthcare professionals. And they via the Google Forms, and their responses were recorded. And I've also provided the link for my KAP questionnaire on my poster. Moving on to the results, there was a total of 281 respondents. A minimum score obtained was 14 out of 56, and maximum score obtained was 55 out of 56. And out of this, and an average, like there was a 19.90 percentage of the 281 participants obtained a score of 14 to 25, and 44 to 80 percentage of the participants obtained a score of 25 to 40, and 35.30 percentage of participants obtained a score of 40 to 56, which I've also given on the represented it graphically on the chart below. And as you can see, and to conclude, as you can see, the above results demonstrate the need for training of the dental healthcare professionals for the management of the medical emergencies, and this will help avoid the medical legal issues and adverse behavior towards the healthcare professionals in both the undergraduate and postgraduate levels. So these are my references, and thank you.
Yeah. Tell me, what is the impact of the low oxygen level on periodontium in COVID patients?
Ma'am, they can, ma'am, there could be like a periodontal degradation, ma'am. So there could be like the degradation of the periodontal fibers. So, and I'm not sure, ma'am. Like, sorry.
Okay. Dr. Asif?
No, ma'am. Thank you.
Thank you so much. Next
Thank
poster,
you, ma'am.
please. Thank you. Mrs. Shailesh.
Good afternoon, ma'am. Am I audible?
Yes, please go ahead.
Good afternoon, everyone. Today, my poster presentation topic is on knowledge, attitude, and practice regarding interdental cleaning aids among dentists of Saurashtra region in Gujarat. So, it is basically an online structured survey composed of 20 questions, 10 to 200 dentists of Saurashtra region. So, my questionnaire was divided into 3 parts: knowledge, attitude, and practice. Knowledge, in 60 to 80% dentists are aware for intact papilla, dental floss is used, whereas 40 to 50% are aware that for moderate papillary recession, interdental brush is used. But around greater than 60% for complete loss of papilla, interdental brush is used. Now we come to attitude portion. Dentists mostly have positive attitudes, because the blue portion you can see in the pie chart, that is yes, and the red part will be no. So the interdental cleaning is important for good gingival health. 99% dentists say yes. So patient compliance in using it, 67% of dentists are agreed with that. Then 39% agree with that floss-induced injuries outnumber its benefits. 96% says that motivating patients has positive impact in dental practice. 98% type of embrasure should be considered before prescribing. They agree with that. But 43% stop flossing if your gum bleeds. Now, coming to the practice portion, my first question was, do you advise interdental aid to your patient? 96% dentists say yes. Do you help patients to choose interdental aids? 95% dentists around said yes. But do you come across floss injuries in your practice? 63% dentists agree with that they have come across with the injuries. And do you recommend water pick? That only 43% recommend with that. So the conclusion is that only 60 to 80% dentists aware about interdental aids, and they have positive attitude also, but not everyone is using. So health awareness programs should be encouraged. Adequate training at undergraduate as well as postgraduate should be encouraged to increase the prescription practice, because there is necessity to know the factors where it affects the prescription of interdental cleaning aids. Thank you.
Yeah, Dr. Asif?
No, ma'am. Thank you.
Yeah, next participant, please.
Mr. Shailesh, next poster, please.
Good afternoon, delegates. The topic of my poster is assessing the knowledge, anxiety, and fear of patients visiting dental hospital during COVID-19 pandemic in Bhubaneswar city, Orissa. Introduction. Information about the age of transformation of COVID-19 make people afraid of being infected with COVID-19. So they are reluctant to go to the dental health care providers and finally decide not to do or to delay the dental care during the COVID-19.
Sorry to interrupt. Dr. Shubhalakshmi, please put on your camera.
Ma'am, it's on, ma'am.
Yes, please continue.
Thank you, ma'am. The aim of my study is to assess the knowledge, anxiety, and fear of patients visiting the dental hospital during COVID-19 pandemic. We have taken a sample size of 111 subjects, and the source of data would be the subject visiting the outpatient of Kalinga Institute of Dental Science, Bhubaneswar, and indicated for any dental treatment. For the procedure, a set of 15 questions are set before and after the treatment are given to the patient to record their data. And for the inclusion criteria, patients above 18 years of age, subjects undergoing any dental treatment procedure during COVID-19 pandemic, patients who give their informed consent, and patient who will be needing the reevaluation after the treatment. These are the inclusion criteria, and exclusion criteria are the patients who refuse to give the informed consent for their dental treatment, patient visiting for routine dental checkup and not receiving any type of dental treatment, and patient not reporting to the department for the reevaluation. And all the statistical analysis are taken by using SPSS 23 software. For the result, here the graph shows the pre-treatment responses shows that their fear for any kind of dental treatment or even to in the sitting area or the reception area during the COVID-19 pandemic. But after a set of 15 questions and recording their response, the post-treatment responses are that they understood that why they have to fear why they have the fear to go to the dental hospital any for their any dental treatment, and they come with a better response and they agreed to check their oral cavity and do the needful treatment. For the discussion, the present study provided the information about the anxiety level of the subjects before and after the procedure. The results of the study suggested that the subjects were anxious considerably while deciding to visit the dental hospital for their treatment during COVID, and patients were more anxious in the reception area before screening. But with proper consultation, anxiety level decreases. For to conclude, the anxiety level of the subjects toward the dental treatment is directly related to their perspective towards the dentist and fear of getting infection during COVID-19. Whereas a set of questionnaire before the procedure lead to modification in their treatment plan as well as in the ambience of dental hospital during COVID. Thank you. These are the references.
Okay, what's your opinion in terms of infection, transmission of the infection
Ma'am,
in
ma'am,
dental
in the
clinics?
yes, ma'am, in the COVID-19 before, ma'am, when a patient having lack of knowledge that why he is getting the fear, the cause of fear, if that is clear to the patient, then it will be then they are very much agreed to do any kind of treatment. So in the reception area only, when the patient is doing for any providing the demographic data, that's where if we arrange the chairs, maintain a minimum gap, sanitize each and every entry rooms and the objects, and sanitizing even the reception area before the patient starting the entry in the day. This will help to get their uh, seeing view the hospital or coming to the hospital.
Do you think the aerosols, the dental aerosols, are responsible for spreading the or the transmission of disease?
Yes, ma'am. Yes, ma'am. Ma'am, while doing the ultrasonic scaling, the aerosols which contain mixed with the saliva and they direct come in contact with the nasal cavity, and also the splash also when they come contact with the eye, they contain the microorganisms or they can easily get mode of transmission, ma'am.
Okay, Dr. Azdeep.
Do you think the anxiety is more in younger population or in older population?
So in this questionnaire, so both the population they showed the same response as this is the new virus which are spreading more frequently, sir, through the nasal and oral. Uh, so they are very much anxiety for the any kind of dental treatment or even since visiting to the hospital.
Okay, thank you.
Sir, ma'am, I would just like to bring it to your notice that we are time bound. We have to finish the session by 4. So if you could just
Yeah,
speed up the
yeah.
Yeah,
presentations,
please,
please.
please,
Yeah,
please.
surely,
Thank you.
surely.
Thank you so much. Next presenter, please.
Am I audible?
Yeah, please.
Please continue.
The video has been stopped by the host. Can you please switch?
You continue, please.
Good afternoon, everyone. Today's my topic for poster presentation is assessment of knowledge, awareness, and practice of platelet-rich fibrin in dental implants among dental professionals. Platelet-rich fibrin is a biomaterial derived from the human blood, part of a platelet concentrate obtained through centrifugation process, relatively inexpensive and simple to use. PRF can lead to healthy fibrin membrane production, and it is a fibrin mesh structure that stores a variety of growth factors and cytokines and gradually releases them during remodeling. The application of PRF in the implant surface is recommended to increase bone to implant contact, which in turn enhances osseointegration, and the use of PRF is also recommended as a regenerative material, either alone or in combination with bone grafts. So the PRF has been used in earlier studies in the peri-implant defects or peri-implantitis, and it has shown a positive results. The objective of my study is to access the knowledge, awareness, and practice of platelet-rich fibrin and its use in regenerative material in dental implants among dentists. So in methodology, a descriptive cross-sectional study was conducted among dental professionals through a self-structured questionnaire, and 20 questions were included in the study. Among the 20 questions included in the study, questions were on knowledge, awareness, practice of PRF in implants as a regenerative material among dental professionals. So the results were among the dental professionals, more than 90% of them are aware of this procedure in implants, of use of PRF as a regenerative material, and it has a property of wound healing and promotes osseointegration when used in implants. According to this study concludes that the dental professionals have adequate knowledge, awareness regarding the use of platelet-rich fibrin during routine implant procedures, and also it can be used as an adjunctive regenerative material. However, studies evaluating the awareness and usage of technique of the PRF preparation and the practical applications warrants further interest. Thank you, ma'am.
Sir, ma'am, any questions?
Is PRF alone is good for implant treatment or peri-implantitis, or is it used with in conjunction with another graft material?
It can be used along with the autogenous bone graft material, ma'am. Or studies are there, ma'am, in PRF used as alone in the peri-implant defect cases, ma'am.
So which is better, PRF alone or PRF along with any other regenerative material?
Ma'am, sir, PRF along with the grafts, sir, autogenous grafts or any graft material, GTR membrane has shown positive results.
Is it good with PRP, IPRP, TPRP?
Yes, ma'am. I'm not sure about it, ma'am.
Okay, thank you.
Thank you.
Hello, am I audible?
Yes, please continue with your presentation.
Yeah, good afternoon, everyone. My poster presentation today is based on the research carried out in my department on knowledge, awareness, and practice regarding the use of probiotics in dentists of Gujarat state. Probiotics are dietary supplements which are a promising area of research in the treatment of periodontitis, dental caries, and halitosis. They act by microbial adhesion to the target tissue and by competing with pathogenic microbes on adjacent sites by secretion of antimicrobial substances. The aim and objective of the present study was to assess the knowledge, awareness, and practice of probiotics in routine dental practice in dentists of Gujarat state. It was a web-based cross-sectional study which consisted of 159 participants. The duration of the study was 3 months, and the questionnaire was formulated in an English language, and it was circulated via email and WhatsApp. Coming to the results showed that the MDS graduates were more aware about the term probiotics and its uses as compared to BDS graduates. 55% of the dentists were aware that dairy products and fermented foods were sources of probiotics. 88.7% of the dentists were aware that probiotics are made up of live microorganisms, whereas 25% of the dentists were not aware about the contraindications of probiotics. Just prescribe probiotics to their patients, and mostly it was prescribed along with antibiotics. And out of these 47%, which is the 75 participants, only 48% of the dentists, they saw clinical benefits on adjunctive use of probiotics. So coming to the discussion, we came across a study which was done by Abdul et al. In 2019 to see the knowledge of among dental students about the use of probiotics. So we carried out a study in order to see about the knowledge and awareness in the dentists of Gujarat state, because as we can see, there are beneficial results of probiotics are seen. So in order, so we would like to increase the use of probiotics among dentists of Gujarat state. So I would like to conclude that presently only more than 50% of the dentists are aware about probiotics and are aware about the beneficial use of probiotics. But the practice of probiotics as an adjunct to dental practice is very less. So more efforts should be made in order to incorporate the use of probiotics along with dental practice. These are my references, and thank you.
What is the mechanism of action behind that?
Yes, ma'am. In periodontitis, the mechanism of action is that it decreases the pH of the oral cavity, so it does not allow the formation of plaque and calculus. It also releases antioxidants, so they act as scavenger of reactive oxygen species. So that also helps in avoiding periodontitis. And in dental caries, they act by competing with the microorganisms, and they not allow the microorganisms to adhere to the tooth side. So they also help in prevention of dental caries. Whereas in halitosis, they act by converting the
Stabilize the
volatile.
specific kind of bacteria. Which kind of that?
Ma'am, a variety of bacteria is currently used in probiotics such as Lactobacillus species, Streptococcus species, Enterococcus species, and
Okay, thank you.
Bifidobacterium
Thank you.
species.
Hello.
Hello.
Ma'am, I couldn't unmute myself that time.
Dr. Monica, please continue with your presentation.
Am I audible, ma'am?
Yes, please continue.
Good afternoon, respected jury members. Today's topic of my poster presentation is on knowledge, attitude, and behavior towards oral health among the teaching staff members of non-medical faculties in SJT University, Gurugram. Coming to the introduction, the oral health is an integral part of the general health and a valuable asset for an individual. So it is a highly personalized concept, the awareness of which highly relies on an individual's culture and socio-economic status. The prevention of dental disease depends upon the involvement of the community, the professional and an individual. So oral health of an individual depends upon oral and dental health attitude, oral hygiene knowledge and behavior. So the aim of my study is to evaluate and assess oral health knowledge, attitude and behavior among the teaching staff members of non-medical faculty. Materials and method of the study into a Google form containing self-administered questionnaire containing 15 questions was developed and distributed to non-medical faculty members of the university. And the questionnaire was in a format of multiple choice questions. The participants were told to pick up only one answer for each question, and the percentage and frequency distribution for each questions was then calculated and processed in the Excel sheet, and percentage was calculated for each option of each question. Then all the questionnaire is basically divided into 3 sections. First section include the questions that are based on the on the knowledge of the oral health practices, and includes first to 6 questions as shown in my poster. Second section include the questions based on the attitude of the faculty members for the maintenance of oral health, and the last section include the questions which covers the basic behavior taken by the faculty members towards the maintenance of oral health. And based on the data obtained, the results showed that the knowledge, attitude and behavior towards the maintenance of oral hygiene in a professional environment was not inappropriate, as shown in the graphs also. Coming to the conclusion,
Your time is over, please. Over to the question answers, ma'am, sir.
No, thank you.
Thank you.
Next presentation, please.
Hello, excuse me, ma'am. Ma'am, I tried to unmute myself. Ma'am,
Kanchan, wait. Once this last presentation is done, you will be given an opportunity. Please wait.
Okay. Am I audible, ma'am?
Yeah.
Yes.
Hello, ma'am.
Yes, ma'am. Go ahead.
Good afternoon. I am here to present my poster on awareness of association between SARS-CoV-19 and periodontal disease among dental healthcare professionals. The main objective of the study is to know the level of awareness, protective measures, and cognizance regarding COVID-19 and periodontal diseases. As the periodontal diseases increases the inflammatory response in patients, which might lead to the systemic symptoms and clinical course of COVID-19. Also, the potential association of periodontal disease and COVID-19 severity is explained by alteration in the expression of cellular receptors, enhancing the virulence of SARS-CoV-2 and the possibility of periodontal pockets acting as viral reservoirs. A cross-sectional study was conducted using a Google Form questionnaire, and the questions are: is poor oral hygiene a risk factor for SARS-CoV-2 infection? Is periodontal inflammation associated with COVID-19? And are you aware that shortness of breath is a symptom of infection with the novel coronavirus? Are you aware that COVID virus infects the epithelial cells of lungs via aerosol route by binding to angiotensin converting enzyme 2 receptors? And do you know that cytokine storm is a link between COVID-19 and periodontal disease? Also, do you know that stress elevates cortisol levels, leading to gingival inflammation and periodontal tissue destruction? And is smoking a risk factor for both COVID-19 and periodontitis? Coming to the results, a statistical analysis was done through online basis, and it was observed that 82% responded positive to that oral hygiene is risk factor for SARS-CoV-2 infection, and 59% responded positive to the cytokine storm is a link between COVID-19 and periodontal disease, and 75% responded that stress elevates cortisol levels, leading to gingival inflammation. Also, 87% responded positive to that smoking is a risk factor for COVID-19 and periodontitis. And from the results, it was concluded that there is an awareness of association between SARS-CoV-19 and periodontal disease among dental healthcare professionals. Thank you.
Okay, no question from my side. Dr. Rajveer?
Mr. Shailesh, could we have the last pending poster for Dr. Kanchan?
Hello.
Yes, Dr. Kanchan, just give us a minute. We are putting up your poster. You could present.
Okay, ma'am.
Dr. Kanchan, please continue.
Yes, ma'am. A very good afternoon to one and all. Today, I'll be presenting a poster on knowledge and awareness of mucormycosis in the undergraduate students of third and final year in dental colleges of Pune. Introduction. COVID-19 pandemic was first reported in China and has since then spread all over the world, leading to a high degree of morbidity as well as mortality. Also, patients recovering from COVID-19 are suffering from many complications post-recovery. Mucormycosis is one such complication. Mucormycosis is a rare but a deadly fungal infection with oral involvement, and its prognosis is related to early diagnosis and treatment. Hence, the role of dentist is quite crucial. The aims and objective of the study are to assess the knowledge and awareness of mucormycosis in the undergraduate students of third and final year in dental colleges of Pune. Methodology. A cross-sectional web-based questionnaire study was carried out. Third and final year students of dental colleges of Pune consenting to be a part of this survey were included. Questionnaire using Google Forms was shared with the participants, and the questions were divided into demographic, awareness, and knowledge-based questions. The knowledge-based questions were further divided into etiopathogenesis, diagnosis, treatment, and prevention. The statistical analysis was evaluated using Pearson's chi-square test and the SPSS software. The p-value of less than or equal to 0.05 was considered to be statistically significant. The graph, as we can see, it shows the overall average knowledge of mucormycosis was about 76% in third and final BDS students based on the points scored. The second graph shows that there is not much of a difference in the third and final BDS students in the awareness of mucormycosis of dental colleges in Pune. Results: a total of 184 subjects responded to the survey, and it was seen that average percentage of third and final BDS students had lesser knowledge of diagnosis and etiopathogenesis of mucormycosis. However, Knowledge about the treatment and prevention of mucormycosis was significantly more. Conclusion, from the survey, we could
Dr.
conclude
Kanchan, that's the end of your time slot. I'm really sorry.
from
Ma'am,
the
we could go
survey.
ahead with the questions. Sir?
Could you please name a drug which is widely used for treatment of mucormycosis in present
Sorry,
scenario?
sir.
Could you please name a drug which was widely used in present scenario for treatment of mucormycosis?
Voriconazole, then
Amphotericin B was also used.
sorry, sir.
Yes. Amphotericin B.
Amphotericin B, that's amphotericin B drug.
Amphotericin B. Okay, ma'am, do you have any questions?
Okay. No, thank you.
Thank you.
Thank you. That will be all. I would like to extend my vote of thanks to Dr. Prerna and Dr. Rajdeep, sir. Thank you so much for your patience and time for judging this session. And I'm really sorry for any inconvenience that has been caused. Thank you so much for being present today.
Thank you, Dr.
Thank you, Aspen. Thank you, Dr. Amrita. Thank you, Prerna, ma'am.
Thank you, Dr. Razif. Thank you, everyone.
So that will be the end of today's session. Thank you, everybody. Thanks a lot.
Thank you.
कौन आया है?
हाँ, तो नहीं मेरे पर्स में रखना है।